Pediatric infectious diseases: hepatitis A, hepatitis B, hepatitis C, rotavirus infection, osteomyelitis, septic arthritis, meningitis, botulism, infant botulism, poliomyelitis, tetanus, rabies, infectious rashes in childhood, rubella, measles, chickenpox, roseola infantum, fifth disease, scarlet fever, Coxsackie virus infections, impetigo, staphylococcal scalded skin syndrome. Home library lists is settings. Infectious gastroenteritis in children. Acute gastroenteritis is a common infection in childhood. The majority of cases are caused by viruses, while 20% are bacterial, and a small number are parasitic. Most children have a mild presentation where nausea, vomiting, and diarrhea are not severe enough to prevent adequate oral intake or participation in normal activities. Severe disease is characterized by signs of significant dehydration, and organ damage, fevers equals 40 degrees Celsius, signs of sepsis, bloody or bilious emesis, and toxic appearance. Children with mild to moderate gastroenteritis can be diagnosed clinically. Children with severe illness, atypical presentations, or signs of significant dehydration should undergo laboratory studies. Treatment is usually supportive with fluid replacement, antiemetics, and antipyretics. Antimicrobial therapy, empiric or tailored, may be utilized for children with suspected or confirmed bacterial or parasitic infections. Prevention of infectious gastroenteritis involves vaccination of infants against rotavirus, travel vaccines where appropriate, and patient/caregiver education on hand hygiene and food and water hygiene. CE. Epidemiology. Common illness in children, causing each year, NL copyright 1.5 million outpatient visits, copyright 200,000 hospitalizations sent. Severe illness is more common in children. And etiology. Most cases of gastroenteritis in children are viral gastroenteritis. 1+20% of cases are bacterial gastroenteritis. 2 parasites, example Giardia lamblia, should be considered in children with persistent diarrhea. VA. OIEEE. Clinical features. Symptoms of infectious gastroenteritis in children are similar to adults and typically include O nausea and vomiting, O fever, OE abdominal pain, copyright diarrhea sent in children. Additional clinical features that raise concern for severe illness include O fever equals 40 degrees Celsius or tachypnea, copyright signs of poor peripheral perfusion, copyright bloody or bilious emesis, O petechiae, O altered mental status or excessive crying/fussiness. WRCE. Diagnostics. Scent diagnosis is usually clinical. Scent consider diagnostic studies for infectious gastroenteritis in children with 1. O severe gastroenteritis, copyright immunocompromise, copyright recent international travel or local outbreak, OE symptoms lasting 1 week, assess for signs of significant dehydration, if present, order diagnostic studies for dehydration. AIFs. Copyright diagnosis of viral gastroenteritis in children is usually clinical. Diagnostic studies for infectious gastroenteritis are not routinely indicated. AO. Collapse fine text outline. Differential diagnoses. Gastrointestinal causes 6. Scent gastrointestinal causes of acute abdomen, scent inflammatory bowel disease * congenital disorders with diarrhea 17 intussusception plus functional diarrhea 8 antibiotic associated diarrhea. Extraintestinal causes 1 pneumonia, scent meningitis in children, scent otitis media, scent uterine children and adolescents, scent toxic shock syndrome. The differential diagnoses listed here are not exhaustive. 7 A. Treatment. Treatment of infectious gastroenteritis in children is generally supportive. All patients 11I3. Scent provides symptomatic treatment. Copyright give antipyretics and antiemetics as needed. Copyright antidiarrheal medications are not routinely used. L2I plus consider antimicrobial therapy for select patients. 1-2 OC empiric antibiotics for bacterial gastroenteritis. OC treatment of diagnoses. Scent optimize nutrition. Copyright maintain adequate oral intake through breastfeeding or age-appropriate foods. 2 Copyright zinc supplementation is recommended for patients with malnutrition or in low-income regions. 2 Educate patients and/or caregivers on preventing onward transmission of gastroenteritis. Mild to moderate gastroenteritis, 11L2. Encourage fluid intake. Scent give oral rehydration solution, ORS, if signs of moderate dehydration are present. I. Advise caregivers to seek medical assistance if signs of significant dehydration develop. Severe gastroenteritis or children with admission criteria for dehydration, 11L2I. Admit to hospital and initiate contact precautions. Scent identify patients in shock and start for fluid resuscitation. Scent initiate treatment of dehydration and electrolyte repletion with either 4 fluids or ORS. OI. OES. Complications. Scent dehydration, scent malnutrition. Electrolyte imbalance, reactive arthritis, secondary lactase deficiency 1, 4I. We list the most important complications. The selection is not exhaustive. WV equals A. Collapse, find text. O. Outline. X. Infectious gastroenteritis in children. Extraintestinal causes, 1. Pneumonia, scent meningitis in children, scent otitis media, scent uterine children and adolescents, scent toxic shock syndrome. The differential diagnoses listed here are not exhaustive. O or notes OE. Treatment. Treatment of infectious gastroenteritis in children is generally supportive. All patients I3. E provides symptomatic treatment. Copyright give antipyretics and antiemetics as needed. O antidiarrheal medications are not routinely used. 1 mil 2 plus consider antimicrobial therapy for select patients. 2 OC empiric antibiotics for bacterial gastroenteritis. OC treatment of diagnoses. Scent optimize nutrition. Copyright maintain adequate oral intake through breastfeeding or age-appropriate foods. 2 Copyright zinc supplementation is recommended for patients with malnutrition or in low-income regions. 2. Scent educate patients and/or caregivers on preventing onward transmission of gastroenteritis. Mild to moderate gastroenteritis. IL-2. Scent encourage fluid intake. Scent give oral rehydration solution, ORS, if signs of moderate dehydration are present. I.e. advise caregivers to seek medical assistance if signs of significant dehydration develop. Severe gastroenteritis or children with admission criteria for dehydration, L2I. Scent admit to hospital and initiate contact precautions. Scent identify patients in shock and start for fluid resuscitation. Scent initiate treatment of dehydration and electrolyte repletion with either 4 fluids or ORS. 0 Craven note AO red N. Complications. Dehydration, scent malnutrition, scent electrolyte imbalance plus reactive arthritis J** secondary lactase deficiency, 1, 4I. We list the most important complications. The selection is not exhaustive. Copyright red note, VO 1 and C. Prevention. Scent C. Prevention of infectious gastroenteritis. Scent breastfeeding is associated with a reduced incidence of acute gastroenteritis in infants. WZ your vets. WV equals A. Collapse, find text. O. Outline. Infectious gastroenteritis in children, 1/1. Right upper quadrant, RUQ. Sent biliary colic, sent acute cholecystitis, sent acute cholangitis, sent emphysema 2 cholecystitis, sent acute hepatitis, sent pyogenic liver abscess, sent liver rupture, copyright duodenal ulcer, sent portal vein thrombosis. Right lower quadrant, RLQ, sent acute appendicitis * colitis, sent inflammatory bowel disease, IBD. Pubic region. Sent obstructed hernias, urinary retention, sent pelvic inflammatory disease, PID, sent ureteric colic, nephrolithiasis, copyright diverticulitis, copyright cystitis, UTI. Sex-related, Q, sent ectopic pregnancy, sent ovarian torsion, sent ruptured ovarian cysts, sent endometriosis. Right or left upper quadrant, sent pancreatitis, sent lower lobe pulmonary infarction, pulmonary embolism, emphysema, ureteric colic, sent pyelonephritis. Diffuse locations. Left upper quadrant, LUQ. Sent peptic ulcer disease, PUD, sent acute gastritis, sent splenic infarction, sent splenic rupture, sent splenic abscess. Epigastrium, acute esophagitis, acute pancreatitis, sent acute mesenteric ischemia, sent peptic ulcer disease, PUD, sent Mallory-Weiss syndrome, myocardial infarction, sent pericarditis, abdominal aortic aneurysm, AAA, aortic dissection. Left lower quadrant, LLQ. Copyright diverticulitis, sent inflammatory bowel disease, IBD. Periumbilical. Acute appendicitis, sent mesenteric ischemia, sent abdominal aortic aneurysm, AAA, sent aortic dissection. 3. Sent bowel obstruction, renal infarction, sent testicular torsion, sent peritonitis, retroperitoneal hematoma, sent prostatitis, sent aortic dissection. Differential diagnoses of acute abdomen by region VV. Copyright emboss. X. Upper respiratory tract infection. Upper respiratory tract infections, URTIs, involve structures at or above the vocal cords, example the nasal cavity, sinuses, pharynx, and or larynx. URTIs include the common cold, acute rhinosinusitis, pharyngitis, laryngitis, influenza, croup, and COVID-19. Most URTIs are caused by viruses such as the rhinovirus. URTIs more commonly occur in the fall and winter and are especially common in children. Typical clinical manifestations include rhinorrhea, nasal congestion, sore throat, and cough. Diagnosis is generally clinical, although diagnostic testing may be performed to assess for specific infections, example influenza, COVID-19, group A streptococcal pharyngitis. In most cases, treatment is supportive, with symptoms typically resolving within 14 days. Antibiotics are not indicated unless there is a confirmed bacterial infection. WA°AO. Epidemiology. More commonly occur in the fall and winter. 1. Sent higher incidence in children than adults. 2. Copyright children, 6 to 10 per year. Adults, 2 to 4 per year. Epidemiological data refers to the U.S., unless otherwise specified. RSOE. Etiology. Most URTIs are caused by viruses. 3. Viral. Sent rhinovirus, coronavirus, influenza virus. 21. Respiratory syncytial virus, RSV, adenovirus, parainfluenza virus, human metapneumovirus, Epstein-Barr virus, enterovirus, bacterial. Streptococcus pneumoniae, Streptococcus pyogenes, Haemophilus influenza, Mycoplasma pneumoniae, sent Moraxilla catarrhalis. 6. Many of the pathogens that cause URTI can also cause lower respiratory tract infections, LRTIs. 3. Food. WA. CE. Diagnostics. Most URTIs can be diagnosed clinically. Consider diagnostic studies in selected patients. Nonspecific laboratory studies. Routine studies, to support the diagnosis and/or determine disease severity. OCBC may show, equals lymphopenia, example in COVID-19 8 lymphocytosis, example in pertussis, influenza, infectious mononucleosis 1 IL-7-10, OESR and CRP may be elevated. 11 disease-specific laboratory studies. Consider specific studies based on clinical suspicion to support treatment and/or disposition decisions. Plus rapid strep test, suspected acute bacterial tonsillopharyngitis. Back collapse fine text outline. Disease-specific laboratory studies. Consider specific studies based on clinical suspicion to support treatment and/or disposition decisions. Plus rapid strep test, suspected acute bacterial tonsillopharyngitis. Heterophile antibody test, suspected infectious mononucleosis 10 disease-specific NAATs, example PCR, in patients with copyright indications for influenza testing 7 copyright COVID-19 symptoms and/or known exposure, 4. V. At shared node. Common causes of URTIs. Common causes of URTIs 3 Telt, 22. Most common condition pathogens clinical features diagnostic testing. Asterisk onset, gradual asterisk fever, rare, low grade if present, underscore asterisk nasal congestion, rhinorrhea, A, Conan coded 25 asterisk rhinovirus, asterisk clinical diagnosis sneezing asterisk sore throat, cough no prominent localizing features. A clinical diagnosis is possible during asterisk onset, abrupt, OE, influenza season. Scent fever, common, typically high, influenza 17 plus influenza virus consider a rapid molecular assay or RT chills, myalgias PCR for diagnostic confirmation. Sore throat, dry cough AIC diagnostics for influenza. Onset, variable RT-PCR, gold standard, and/or antigen fever, common -1924 asterisk SARS-CoV-2 test EOVIPETOO cough, shortness of breath SEOE2C COVID-19 testing. Loss of smell and/or taste. Onset, gradual fever, present in 50% of cases facial pain and pressure with clinical diagnosis based on diagnostic tenderness to palpation criteria for acute rhinosinusitis nasal congestion, rhinorrhea opacification of sinuses on transillumination. Scent rhinovirus *S pneumonia *H influenza acute rhinosinusitis 25. Viral. Copyright onset, gradual degree fever, rare, low grade if present, copyright rhinorrhea, cough, hoarseness scent primarily a clinical diagnosis might plus Breer * bacterial * rapid strep test WA, throat culture if. Tonsillopharyngitis 261 S pyogenes copyright onset, abrupt pentascore S mice A copyright fever, common, typically *C diagnostics for acute tonsillitis and high pharyngitis. Copyright sore throat, painful swallowing copyright inflammation of the pharynx and tonsils degree no cough. Rhinovirus scent primarily a clinical diagnosis scent hoarseness, ZF laryngitis, 2, *S pneumonia laryngoscopy for patients with red flags in, * barking cough Z ** H influenza hoarseness. Onset, abrupt in children, gradual in adults primarily a clinical diagnosis fever, common, typically high visualization of the epiglottis, example with dysphagia and drooling pharyngoscopy or laryngoscopy, *H influenza epiglottitis 61 *S pneumonia *S pyogenes plus respiratory distress * imaging, example lateral X-ray neck, if there is plus muffled voice diagnostic uncertainty * tripod position. Treatment. Supportive care. Supportive care antiviral therapy for influenza, example oseltamivir, in selected cases, example severe illness. Supportive care for patients with severe COVID-19 and/or risk factors for severe COVID-19, pharmacotherapy may include Copyright antiviral therapy, example remdesivir, copyright glucocorticoids, example dexamethasone. Supportive care, example intranasal steroids, phi antibiotics, example amoxicillin/clavulanate, C. Antibiotic treatment in acute bacterial rhinosinusitis. Supportive care antibiotics, example penicillin, amoxicillin, for patients with confirmed gas infection. Asterisk supportive care, example hydration, air humidification, vocal rest. Antibiotics, example cefotaxime, ampicillin/sulbactam, glucocorticoids, example dexamethasone, airway management in epiglottitis. Al. Find text outline. RPT jocumuate siasecanir AII asterisk glucocorticoids, example dexamethasone, onset, gradual primarily a clinical diagnosis TL asterisk para-influenza fever, common, low-grade asterisk consider imaging, example anterior-posterior X7. 7 croup RA7, A8. NBD Tyzek epinephrine virus barking cough, worse at night, ray neck, if there is diagnostic uncertainty. Su, asterisk airway management asterisk Strider asterisk C diagnostics of croup. Equals E373 cent C acute management checklist for croup. Scent onset, gradual asterisk fever, rare, low grade if asterisk culture or PCR of nasopharyngeal present, specimen within the first 2 weeks of asterisk antibiotics, example azithromycin, pertussis, 9L asterisk B pertussis, 1 rots. Asterisk common in adolescents and young adults, rare in adults aged 40 years asterisk onset, gradual infectious plus Epstein-Barr asterisk fever, common asterisk monospot test asterisk supportive care mononucleosis, 2, virus plus marked lymphadenopathy asterisk CBC with differential asterisk avoidance of strenuous exercise and contact sports asterisk malaise asterisk splenomegaly asterisk sore throat, exudative pharyngitis. Cats mate by quid equals I WAA O. Treatment. Symptomatic treatment, 11L221I28. Scent general. Copyright zinc, example zinc acetate or gluconate lozenges, and probiotics, example containing lactobacillus casei, have been shown to shorten symptom duration. 2930 Copyright oral antihistamine/decongestant combinations may improve symptoms but can cause adverse effects, example dry mouth and dizziness. Scent rhinorrhea or sinus congestion. O. Elevate the head of the bed to improve sinus drainage. O. Apply warm packs to the face for 5 to 10 minutes 3 times a day for facial pain. NLO nasal saline irrigation. Copyright intranasal decongestants, example oxymetazoline plus pain or fever, analgesics, example ibuprofen and/or acetaminophen asterisk cough, non-pharmacological measures may be beneficial, example honey 22131. Differential diagnoses. Infectious OLRTIs, example pneumonia. Copyright acute HIV infection. O. measles. Scent non-infectious. Copyright allergic rhinitis. O. upper airway cough syndrome. Copyright vasomotor rhinitis. O. asthma exacerbation. O. gastroesophageal reflux disease. The differential diagnoses listed here are not exhaustive. CE. Complications. Most URTIs are mild and self-limited and rarely cause complications. 1. Back collapse. Find text outline. X. Upper respiratory tract infection. Symptomatic treatment. General. Copyright zinc, example zinc acetate or gluconate lozenges, and probiotics, example containing lactobacillus casei, have been shown to shorten symptom duration. 2930 Copyright oral antihistamine/decongestant combinations may improve symptoms but can cause adverse effects, example dry mouth, and dizziness. Rhinorrhea or sinus congestion. Elevate the head of the bed to improve sinus drainage. Apply warm packs to the face for 5 to 10 minutes 3 times a day for facial pain. 0. Nasal saline irrigation. Copyright intranasal decongestants, example oxymetazoline plus pain or fever. Analgesics, example ibuprofen, and/or acetaminophen * cough. Non-pharmacological measures may be beneficial, example honey 22131. Your notes. OE. Differential diagnoses. Infectious OLRTIs, example pneumonia. Copyright acute HIV infection. Measles scent. Non-infectious. Copyright allergic rhinitis. Upper airway cough syndrome. Vasomotor rhinitis. Asthma exacerbation. Gastroesophageal reflux disease. The differential diagnoses listed here are not exhaustive. AE. Complications. Most URTIs are mild and self-limited and rarely cause complications. LRTI scent. Otitis media. Secondary bacterial infection. See also the respective articles for complications of specific causes of URTI, e.g., copyright sinusitis complications. Pertussis complications. We list the most important complications. The selection is not exhaustive. VA. OSSH end by J. QO shared notes manage. Prevention. Educate patients and caregivers on respiratory hygiene and hand hygiene. Recommend regularly cleaning and disinfecting surfaces that are touched often, example door handles. Advise patients to stay at home until both. Copyright Afebril for 24 hours without the use of antipyretics. Symptoms are improving. Scent. Ensure age-appropriate immunizations are up to date, including seasonal vaccines, e.g., copyright influenza vaccination. COVID-19 vaccination. RSV vaccination. S. Back collapse. Find text outline. X. Congenital torch infections. Congenital infections are caused by pathogens transmitted from mother to child during pregnancy, transplacentally, or delivery, peripartum. They can have a substantial negative impact on fetal and neonatal health. The acronym TORCH stands for the causative pathogens of congenital infections, Toxoplasma gondii, others, including Treponema pallidum, Listeria, Varicella zoster virus, and Parvovirus B19, Rubella virus, Cytomegalovirus, CMV, and herpes simplex virus, HSV. Torch infections can cause spontaneous abortion, premature birth, and intrauterine growth restriction, IUGR. These infections can also cause abnormalities in the CNS, the skeletal and endocrine systems, and the complex organs, example cardiac defects, vision, and hearing loss. Prophylaxis is of great importance during pregnancy. Primary prevention includes vaccination for varicella and rubella, prior to pregnancy, hygiene measures, washing hands and avoiding certain foods, and screening for syphilis. During pregnancy, affected infants require regular follow-ups to monitor for hearing loss, ophthalmological abnormalities, and developmental delays. Several other pathogens can also be vertically transmitted during pregnancy and have detrimental effects on the fetus and/or newborn. These include HIV in pregnancy, perinatal hepatitis B, group B streptococci, E. coli, gonococcal infections, and chlamydial infections, West Nile virus, Zika virus, measles virus, enterovirus, and adenovirus. The pathogens are discussed in more detail in their respective articles. WA. FA, CES. Overview. Description. Congenital torch infections are vertically transmitted infections, acquired directly from the mother and transmitted to the embryo, fetus, or newborn through the placenta or birth canal, that are capable of significantly influencing fetal and neonatal morbidity and mortality. 1. Scent. Toxoplasmosis scent. Others, example syphilis, varicella, parvovirus B19 infection, listeriosis, scent. Rubella cytomegalovirus, CMV, Asterisk herpes simplex virus, HSV, infection. Common findings. Scent during pregnancy, may cause intrauterine fetal demise and miscarriage. Scent in neonates. O hepatosplenomegaly, O jaundice, O lethargy, O growth retardation. Copyright thrombocytopenia. Overview of ital torchi infection. Clinical features, diagnosis, treatment, prevention. Asterisk classic triad. Copyright chorioretinitis 7. Asterisk avoidance of uncooked meat. Asterisk T. Gondii specific IgMP web. 7. Copyright hydrocephalus plus pyrimethamine, sulfadiazine. Asterisk avoidance of handling cat feces. Toxoplasmosis. Antibodies EE, AE. Copyright diffuse intracranial calcifications, ring, and folinic acid. Asterisk immediate administration of spiramycin 2. Asterisk PCR for T. Gondii DNA enhancing lesions, prevent fetal toxoplasmosis, petechiae and purpura, blueberry muffin rash. Early congenital syphilis, onset 2 years. Asterisk PCR copyright frontal bossing, brigades. Copyright Hutchinson teeth. Copyright interstitial keratitis. Copyright sensorineural deafness. Degree Saver shins. Spontaneous abortion and premature birth. Meningitis, sepsis. Vesicular and pustular skin lesions, IICA. Avoidance of unpasteurized dairy products. Bacterial culture, avoidance of cold deli meats. Listeriosis. Degree ampicillin and gentamicin. IUGR, premature birth. Chorioretinitis, cataract. Direct fluorescent antigen. Varicella zoster immune encephalitis test, DFA, globulin, VZIG, pneumonia. PCR for VZV. DNA CNS abnormalities. Serology, IgM antibodies, hypoplastic limbs. Active immunization of mother before varicella zoster virus, VZV, pregnancy, dash. Acyclovir 2 SEFL breastfeeding. Passive immunization with VZIG. PCR for parvovirus B19. Aplastic anemia. DNA fetal hydrops. Frequent hand washing. Intrauterine fetal blood. Parvovirus B19. Avoid potentially contaminated workplaces, example schools, pediatric clinics. Serial ultrasounds to rule transfusion if indicated. Out fetal hydrops. Back collapse. Find text outline. IUGR sensorineural deafness, asterisk cataract. SAS Rubin HSAFEGS RORESVR POL2s. Asterisk serology, IgM antibodies. Bare IgM antibodies, Uvella Lear defects, example PDA, pulmonary artery plus PCR for rubella RNA stenosis, sent CNS abnormalities. Asterisk petechiae and purpura, blueberry muffin rash. Jaundice, hepatosplenomegaly. IUGR sent chorioretinitis. Degree of nascent viral culture, CMV, avicular calcifications. Asterisk PCR for CMV. DNA. Asterisk petechiae and purpura, blueberry muffin rash. Asterisk microcephaly. Sent seizures. Premature birth, IUGR sent skin, eyes, and mouth involvement. Vesicular herpes simplex virus lesions, keratoconjunctivitis. Asterisk viral culture, HSV, asterisk localized CNS involvement, sent PCR for HSV. DNA meningoencephalitis. Multiple organ involvement, sepsis. Supportive care. Ganciclovir and valganciclovir. Supportive care. Acyclovir. Supportive care. Active immunization of mother before pregnancy, 1 second immunization of mother after delivery if serologic titers remain negative. Frequent hand washing. Avoid potentially contaminated workplaces, example schools, pediatric clinics. Cesarean delivery if lesions are present and delivered. Transplacental transmission occurs following primary infection of a seronegative mother during pregnancy. Maternal IgM antibodies, which are unable to cross the placenta. In general, the earlier in pregnancy a torch infection occurs, the more severe the complications. Copyright ON with live vaccines. Attenuated live vaccines, measles, mumps, rubella, and varicella, are contraindicated in pregnancy. Conception should be avoided for 1 month after immunization. DS. CE Regal IWBPV. Epidemiology 0.5-1:10,000 live births per year in the US21. Pathogen Toxoplasma gondii. Transmission Mother o cat feces. Copyright raw or insufficiently cooked meat o unpasteurized milk, especially goat milk. Copyright see etiology in toxoplasmosis. Fetus. Copyright transplacental transmission equals first trimester, 15% equals third trimester, 70%. Clinical features 3. Scent. First trimester increased risk of premature birth and spontaneous abortion. Copyright classic triad of toxoplasmosis equals chorioretinitis, a form of posterior uveitis, equals diffuse intracranial calcifications equals hydrocephalus. Copyright possible other non-specific clinical features petechiae and purpura, blueberry muffin rash, equals fever v. Back collapse. A. Find text. Manage. A. Outline. Equals hydrocephalus OE. Possible other non-specific clinical features petechiae and purpura, blueberry muffin rash, fever, jaundice, hepatosplenomegaly, lymphadenopathy, pneumonitis, seizures, macrocephaly or microcephaly, Fa thrombocytopenia. Scent. Second or third trimester, subclinical or mild toxoplasmosis. Scent. Sequelae of congenital toxoplasmosis. O. Epilepsy. Copyright intellectual disability. O. Visual disabilities, chorioretinitis, increased risk of chorioretinal scars, cataracts, and glaucoma. MS. Copyright sensorineural hearing loss. Diagnostics 5. Scent. Mother, see diagnostics in toxoplasmosis. E. Fetus, PCR for T. gondii, DNA in amniotic fluid. 4. Scent. Newborn, OCT/MRI, intracranial calcifications, hydrocephalus, ring-enhancing lesions. Copyright T. gondii specific IgM antibodies, CSF, serum. Copyright PCR Fort. Gondii DNA, CSF, serum. Copyright ophthalmological evaluation, chorioretinitis. Treatment, 51. Scent. Mother, immediate administration of spiramycin to prevent fetal toxoplasmosis. 6. E. Fetus, when confirmed or highly suspected, switch to pyrimethamine, sulfadiazine, and folinic acid. Scent. Newborn, pyrimethamine, sulfadiazine, and folinic acid. Prevention 31. Avoid raw, undercooked, and cured meats. Wash hands frequently, especially after touching soil, example during gardening. Scent. Avoid contact with cat litter. And the 4 Cs of congenital toxoplasmosis, cerebral calcifications, chorioretinitis, hydrocephalus, and convulsions. WA. CE. Congenital syphilis. Epidemiology 23:100,000 live births per year in the US, 17. Pathogen Treponema pallidum. Transmission, 71. Mother. Sexual contact, contact with infectious lesion, OC. Etiology in syphilis. Fetus, transplacental transmission from infected mother. Back collapse. Find text outline. E. Fetus. Usually spiacental ualnsim mom recti mower. Copyright increased risk of transmission with recent syphilis infection. 1. Copyright risk of transmission increases with gestational age. Scent. Neonate, perinatal transmission during birth. Clinical features of congenital syphilis. 8. E. In utero syphilis. E. Miscarriage. Copyright stillbirth. O. Hydrops fetalis plus early congenital syphilis, onset 2 years of age. Copyright typical facial features, saddle nose, frontal bossing, short maxilla. Copyright dental findings, Hutchinson's teeth, notched, widely spaced teeth, mulberry molars, poorly developed first molars. Copyright eyes and ears, asterisk. Syphilitic keratitis, non-ulcerative, interstitial keratitis that develops as a late complication of syphilis equals more common in patients with congenital syphilis than acquired syphilis equals causes stromal inflammation. equals sensorineural hearing loss. Copyright skin, regades, perioral fissures, cracks, and / or scars, particularly near the corners of the mouth and nose. Skeletal equals saber shins and anterior bowing of the tibia, causing it to resemble a saber. Other causes include rickets and Paget disease of bone. Painless arthritis in knees and other joints. Neurological, cranial nerve palsies, example CN8 defect causing deafness, intellectual disability, hydrocephalus. Diagnosis, 10. Sent mother, see diagnostics of syphilis in pregnancy. Sent fetus, repeated ultrasound examinations, placentomegaly, hepatomegaly, ascites, and / or hydrops fetalis, neonate ORBR or VDRL, serum, copyright dark field microscopy or PCR of CSF CBC and differential radiographs of the long bones. Further studies depend on clinical features of congenital syphilis. Treatment. Plus neonates, 10 days of 4 penicillin G, 9 mothers. Copyright treatment depends on whether diagnosed prenatally or postnatally. Treatment of syphilis in pregnancy and treatment of syphilis. Prevention, 7. Prenatal screening for syphilis and, if positive, antibiotic treatment, should take place in early pregnancy because placental transmission is most likely to occur after the first trimester. Sent nationally notifiable condition, congenital syphilis and syphilitic childbirth must be reported to the local or state health department. And Hutchinson triad, interstitial keratitis, sensorineural hearing loss, Hutchinson teeth. Back collapse spine text outline. Badicott SL Allen IAHHTTEAO. Epidemiology. 3:100,000 live births per year in the U.S., 1 pathogen. Listeria monocytogenes transmission 121. Sent mother. Copyright contaminated food, especially raw milk products. Copyright other possible sources, fish, meat, and industrially processed vegetables, example ready-made salads. Copyright see etiology in listeriosis. Fetus. Copyright transplacental transmission from an infected mother. Copyright direct contact with infected vaginal secretions and / or blood during delivery. Clinical features, 13. Listeriosis of pregnancy. Copyright increased risk of premature birth and spontaneous abortion. Early onset syndrome, granulomatosis infantiseptica equals severe systemic infection characterized by disseminated abscesses, may develop in any organ system, equals most common findings, respiratory distress and skin lesions equals signs of meningitis may already develop. Sent neonatal listeriosis. Late onset syndrome, 5 days to 3 weeks after birth. Listeria meningitis / encephalitis. Neonatal infection. Diagnosis. Culture from blood or CSF samples, pleocytosis, or treatment. For ampicillin and gentamicin, for both mother and newborn, 14. Prevention, 12. Avoidance of soft cheeses. Avoidance of potentially contaminated water and food. Sent nationally notifiable condition, listeriosis must be reported to the local or state health department. Sent seafood and water safety. 7x. Congenital varicella infection. Epidemiology. Sent seroprevalence in the general population is 95%. 15. Most mothers have been vaccinated, so congenital infection is rare. Varicella zoster virus, VZV, transmission, 61. Sent mother. Primary infection equals airborne droplets equals direct skin contact with vesicle fluid reactivation, usually in immunocompromised individuals. Copyright see chickenpox and shingles. Sent fetus, transplacental transmission from an infected mother. Clinical features, 16. Sent congenital varicella syndrome, infection during first and second trimester, 17. Hypertrophic scars, cicatricial skin lesions, copyright limb defects, example hypoplasia, equals. F. Find text. O. Outline. Clinical features. Degree. Sent congenital varicella syndrome, infection during first and second trimester, 7O hypertrophic scars, cicatricial skin lesions, OLEM defects, example hypoplasia, copyright ocular defects, example chorioretinitis, cataracts, microphthalmia, OCNS defects, example cortical atrophy, seizures, intellectual disability, hydrocephalus. Sent neonatal varicella, copyright mild infection, maternal exanthem 5 days before birth, copyright severe infection, maternal exanthem. Diagnosis, 161. Sent newborn and mother O. Usually clinical diagnosis is confirmed by appearance of skin lesions ODFA or PCR of fluid collected from blisters or cerebrospinal fluid, CSF, copyright serology. Sent fetus, PCR for VZV DNA, in fetal blood, amniotic fluid, and ultrasound to detect fetal abnormalities. Treatment, 161. Sent for pregnant women or newborns with severe infection, acyclovir. Administer post-exposure prophylaxis in newborns if mother displays symptoms of varicella. Sent immunization of seronegative women before pregnancy. Sent VZIG in pregnant women without immunity within 10 days of exposure. Sent nationally notifiable condition, varicella must be reported to the local or state health department. 7AE. Congenital parvovirus B19 infection. Epidemiology, 9. Sent 5% incidence in pregnant women per year in the US. Higher prevalence in daycare workers and elementary school teachers. Pathogen. Parvovirus B19. Sent mechanism of action, infection of erythrocyte progenitor cells in bone marrow and endothelial cells by attaching to their P antigen. Cell destruction equals hydrops fetalis in neonates and pure RBC aplasia in adults. Transmission. Mother O. mainly via aerosols O. rarely hematogenous transmission OC. Fifth disease. Sent fetus, transplacental transmission from infected mother. Clinical features 191. Sent severe anemia and possibly fetal hydrops. Fetal demise and miscarriage/stillbirth in approximately 10% of cases, risk is highest in the first and second trimesters. Sent most intrauterine infections do not result in fetal developmental defects. Diagnosis. Sent mother, serologic assays for IgG and IgM against parvovirus B19. Serologic assay analysis for parvovirus B19 results positive IgM, negative IgM and * acute infection. Sent maternal immunity, positive IgG, * refer to specialists. Sent reassurance. Very recent infection. Sent no maternal immunity, negative IgG _ refer to specialist * counseling. Back collapse. Fine text outline. SS full copyright PCR for parvovirus B19 DNA, amniotic fluid or blood, copyright periodic ultrasound of fetal vessels for anemia / and hydrops fetalis, every 1 to 2 weeks, copyright in cases of suspected anemia according to Doppler ultrasound, fetal hemoglobin levels are determined via the umbilical vein. Treatment. Sent intrauterine fetal blood transfusion in cases of severe fetal anemia. Additional platelet transfusion if thrombocytopenia is also present. Prevention. Hand hygiene, frequent hand washing. Sent pregnant women with risk factors for torch infection should avoid potentially contaminated workplaces, example schools, pediatric clinics. WA. CES. Congenital rubella infection. Epidemiology. Most mothers have been vaccinated, so congenital infection is very rare. J0 pathogen. Rubella virus transmission. Sent mother O mainly via airborne droplets OC rubella. Sent fetus copyright transplacental from infected mother. Copyright risk of fetal infection is high in the first trimester, decreased in the second trimester and then increased again in the third trimester. 21. Copyright risk of congenital rubella syndrome 22 equals 1 to 12 weeks gestation, Period of organogenesis highest risk equals 12 to 20 weeks gestation, very low equals 20 weeks gestation, no documented cases. Clinical features 22. Scent intrauterine rubella infection, miscarriage, preterm birth, fetal growth restriction, especially likely if infection occurs during the first trimester, scent congenital rubella syndrome, copyright triad of congenital rubella syndrome equals cardiac defect, most common defect, example patent ductus arteriosus, pulmonary artery stenosis, equals cataracts. Other eye manifestations may also occur later in life, including glaucoma and salt and pepper retinopathy, abnormal retinal pigmentation, equals cochlear defect, bilateral sensorineural hearing loss. Early features equals hepatosplenomegaly, jaundice equals hemolytic anemia, thrombocytopenia equals petechiae and purpura, i.e., blueberry muffin rash, due to extramedullary hematopoiesis in the skin, equals transient meningitis and or encephalitis equals pneumonia. Late features equals CNS defects, microcephaly, intellectual disability, panencephalitis equals skeletal abnormalities equals endocrine disorders, example diabetes, thyroid dysfunction, equals vascular disease, equals immune defects. Diagnosis 23. Scent newborn and mother OPCR for rubella RNA, throat swab, CSF, copyright serology, abnormally high or persistent concentrations of IgM and or IgG antibodies, copyright viral culture, nasopharynx, blood, fetus. Back collapse fine text outline. Scent fetus copyright IgM antibody serology, chorionic villi, amniotic fluid, copyright PCR for rubella RNA, chorionic villi, amniotic fluid, treatment. Plus intrauterine rubella infection 23 copyright 16 weeks, reassurance and symptomatic therapy, example acetaminophen, scent congenital rubella syndrome, supportive care, based on individual disease manifestations, and surveillance, including monitoring for late-term complications. Prevention 24. Scent immunization of seronegative women before pregnancy. Scent nationally notifiable condition, suspected congenital rubella syndrome must be reported to the local or state health department. QBCCC triad of congenital rubella syndrome, cataracts, cochlear defects, cardiac abnormality. WA. OE. Congenital CMV infection. Overview. Epidemiology. 0.5 to 1% of live births per year in the U.S. 28 pathogen. Cytomegalovirus. Transmission. Scent mother, via CMV contaminated blood, urine, saliva, and genital secretions. Copyright blood transfusions. Sexual transmission. Copyright droplet transmission. Copyright transplant transmitted infection, example bone marrow, lungs, kidneys, cytomegalovirus infection. Fetus, transplacental transmission from an infected mother. Scent newborn, during birth or postnatal via breast milk from infected mother. Clinical features 26. Scent fetal infection. Copyright increased risk of fetal demise. OIUGR. Copyright oligohydramnios or polyhydramnios, placental abnormalities. Scent newborn infection. Copyright severity. Subclinical infection, 90% 10% go on to develop a late complication, most commonly hearing loss, 26 equals symptomatic infection at birth, 10% 70 to 80% go on to develop a late complication. Copyright CNS findings equals hydrocephalus microcephaly. Copyright sensorineural hearing loss, 30%. 1, 27. Copyright chorioretinitis, 10%. Copyright nonspecific findings, similar to other torch infections, equals petechiae, purpura, blueberry muffin rash, equals hepatosplenomegaly, jaundice equals small for gestational age, SGA, equals seizures, lethargy, poor suck equals hemolytic anemia, thrombocytopenia equals pneumonia. Late complications equals hearing loss, vision impairment equals psychomotor retardation, intellectual disability equals dental abnormalities. 1. Diagnosis, 28 I1 I29. Back collapse fine text outline. Diagnosis copyright. Sent fetus and newborn ECNS imaging, hydrocephalus, periventricular calcifications or intraventricular hemorrhage copyright ultrasound, periventricular calcifications, hyperechogenic foci, bowel and liver, ascites, and hydrops fetalis sent newborn and mother EOCM IgM antibodies, blood, copyright viral culture or PCR for CMV DNA, urine, saliva, sent fetus viral culture or PCR for CMV DNA, amniotic fluid, EOCMV IgM antibodies, fetal blood. Differential diagnosis, 28. Sent congenital toxoplasmosis copyright causes chorioretinitis, hydrocephalus, and intracranial calcifications copyright intracranial calcifications in congenital toxoplasmosis typically show ring enhancement. Treatment. Fetus O severe anemia, intrauterine blood transfusions copyright thrombocytopenia, platelet transfusions sent newborn copyright supportive therapy of symptoms, example fluid and electrolyte imbalances, anemia, thrombocytopenia, seizures, secondary infections, copyright ganciclovir, valganciclovir or foscarnet sent mother, valacyclovir is the only therapy approved during pregnancy. 30 Prevention. Sent frequent hand washing, especially after contact with bodily secretions of small children, example diaper changing, avoidance of food sharing with children, avoidance of kissing small children on the mouth. Copyright congenital toxoplasmosis may manifest with symptoms resembling congenital CMV infection. WA. CE. Congenital herpes simplex virus infection. Epidemiology. 1:3,000-10,000 live births per year 81. Pathogen. Mainly herpes simplex virus 2, HSV2, in rare cases HSV1. Transmission 31. Mother O primary infection, contact with contaminated oral secretions via small skin lesions O reactivation, usually in immunocompromised individuals OC herpes simplex virus infections. Sent fetus, transplacental transmission from an infected mother, rare, newborn, perinatal transmission during birth, 30% transmission rate if mother has not yet undergone seroconversion at time of delivery. Clinical features 32. Sent intrauterine HSV infection, 5% of cases, copyright fetal demise, preterm birth, very low birth weight O microcephaly, hydrocephalus, and other CNS defects microphthalmia and chorioretinitis copyright vesicular skin lesions sent perinatal and postnatal transmission copyright skin, eye, and mouth disease equals vesicular skin lesions BDE, ASRS QA back collapse fine text outline. OOOE. Congenital herpes simplex virus infection. Epidemiology. 1:3,000-10,000 live births per year 31 Pathogen. Mainly herpes simplex virus 2, HSV2, in rare cases HSV1. Transmission 31. Sent mother copyright primary infection, contact with contaminated oral secretions via small skin lesions copyright reactivation, usually in immunocompromised individuals OC herpes simplex virus infections. Sent fetus, transplacental transmission from an infected mother, rare, newborn, perinatal transmission during birth, 30% transmission rate if mother has not yet undergone seroconversion at time of delivery, FA clinical features 321. Sent intrauterine HSV infection, 5% of cases, O fetal demise, preterm birth, very low birth weight 1E microcephaly, hydrocephalus, and other CNS defects copyright microphthalmia and chorioretinitis copyright vesicular skin lesions sent perinatal and postnatal transmission copyright skin, eye, and mouth disease equals vesicular skin lesions equals keratoconjunctivitis leading to cataracts, chorioretinitis vesicular lesions of oropharynx OCNS disease meningoencephalitis, manifesting with fever, lethargy, irritability, poor feeding, seizures, bulging fontanelle, equals possibly vesicular skin lesions O disseminated disease features similar to those of sepsis, with organ involvement, example liver, CNS, lungs, heart, adrenal glands, kidneys, GI tract, vesicular skin lesions, may not appear until late in disease course. Diagnosis. Sent mother, typically a clinical diagnosis. Sent fetus, the ultrasound may show CNS abnormalities. Newborn, perform neonatal HSV testing. Copyright standard, viral culture of HSV from skin lesions, conjunctiva, oro/nasopharynx, or rectum. Copyright alternative, PCR for HSV DNA, CSF, blood. Treatment 33. Asterisk newborn and mother, for acyclovir or valacyclovir, sent additionally in newborns, supportive therapy of fluid/electrolyte imbalances, SIRS, septic shock, seizures, secondary infections, etc. Prevention of neonatal HSV infection 341. Plus antiviral therapy, acyclovir, beginning at 36 weeks of gestation for individuals with a known history of HSV lesions. 1 cesarean delivery in women with active genital lesions or prodromal symptoms, example burning pain. 1. Copyright HSV should be considered in infants up to 6 weeks of age with vesicular skin lesions, persistent fever with negative cultures, and/or symptoms of meningitis, encephalitis, or sepsis. Skin, eye, and mouth disease caused by HSV has a good prognosis if detected and treated early. OAO. Sources. Last updated October 19, 2023. Back collapse fine text outline. Equals. Essay. Infection of cells, e.g. muscle cells, and development of B. bradyzoite-filled cyst, thus progressing to chronic stage. Release of sporozoites. Tachyzoites. Tachyzoite. Infection of a cell and asexual reproduction. I. Potential placental colonization and transplacental transmission. V7, equals SALA. Extraintestinal phase intermediate host. Life cycle of Toxoplasma gondii. External phase. Sporulation of oocysts sent into the environment, ASE release of allocysts into feces / release of sporozoites, and OE_OEGA. Release of bradyzoites. Tachyzoites. Gametocytes X develop into oocysts mess. Development O sexual forms, gametocytes. Infection of epithelial cells and asexual reproduction. Enteroepithelial phase definitive host. The life cycle of toxoplasmosis involves transmission to a human host through the ingestion of cat feces particulate that contains oocysts or ingestion of meat, i.e., pork, containing toxoplasma cysts. Cross-placental transmission is possible after the initial infection of pregnant women. Copyright emboss. Urocongenital torch infections, 2/5. Blueberry muffin syndrome. Newborn with acute myeloid leukemia, AML, multiple bluish-purple macules and nodules are distributed across the face and scalp, with a few extending onto the torso. Jaundice is also present. This appearance is termed blueberry muffin syndrome. Differential diagnoses include hematological disorders, other malignancies, and congenital infections. The jaundice in this case may be related to the underlying AML but is not part of the blueberry muffin appearance itself. Source, Big 1, in, Case Report, Blueberry Muffin Syndrome by Ben Miloud S, El Hadoji, Alaki Belgidizi, Ida M, Goharo A. Pan-African Medical Journal, licensed under CC by 2.0. Macular scar in congenital toxoplasmosis. Fundus photography of the left eye of an infant, optic disc not shown. The macular area shows a sharply demarcated scar with depigmentation and hyperpigmentation, affecting both the retina and choroid. This clinical finding is a typical sign of congenital toxoplasmosis. Source: copyright IMPP. Overlay. Congenital toxoplasmosis. Cranial CT scan of an infant, for contrast, axial view, the left lateral ventricle is highly dilated, hatched red overlay. Hyperdensities are visible in the parenchyma of the right frontal lobe, green overlay, and in the occipital lobe, green overlay, white arrow, indicating parenchymal calcifications. Hydrocephalus, ventriculomegaly, and parenchymal calcifications are typical radiological features of congenital toxoplasmosis. Source: Figure 1 in congenital toxoplasmosis presenting as central diabetes insipidus in an infant, a case report by Mohammed S., Osman A., Al-Jarayan N.A., Al-Nemri A., Solet Ma, BMC Research Notes, licensed under CC by 2.0. Overlay. Congenital toxoplasmosis. Cranial CT scan of an infant, for contrast, axial view, the left lateral ventricle is highly dilated, hatched red overlay. Hyperdensities are visible in the parenchyma of the right frontal lobe, green overlay, and in the occipital lobe, green overlay, white arrow, indicating parenchymal calcifications. Hydrocephalus, ventriculomegaly, and parenchymal calcifications are typical radiological features of congenital toxoplasmosis. Source: Figure 1 in congenital toxoplasmosis presenting as central diabetes insipidus in an infant, a case report by Mohammed S., Osman A., Al-Jarayan N.A., Al-Nemri A., Solet Ma, BMC Research Notes, licensed under CC by 2.0. Overlay. Internal capsule lesion in neurotoxoplasmosis. MRI head, T2 weighted, with contrast, axial plane, of a patient with cerebral toxoplasmosis. A small nodule, hatched overlay, in the right internal capsule is accompanied by hyperintense perilesional edema, solid overlay. Neurotoxoplasmosis more commonly manifests with multiple lesions and it has a propensity for the corticomedullary junction, thalami, and basal ganglia. It is a leading cerebral opportunistic infection in patients with AIDS. Source: Intracranial Toxoplasmosis 001.jpg by Prashant Sadala, Wikidoc, licensed under CC by SA 3.0. Overlay. Internal capsule lesion in neurotoxoplasmosis. MRI head, T2 weighted, with contrast, axial plane, of a patient with cerebral toxoplasmosis. A small nodule, hatched overlay, in the right internal capsule is accompanied by hyperintense perilesional edema, solid overlay. Neurotoxoplasmosis more commonly manifests with multiple lesions and it has a propensity for the corticomedullary junction, thalami, and basal ganglia. It is a leading cerebral opportunistic infection in patients with AIDS. Source: Intracranial Toxoplasmosis 001.jpg by Prashant Sadala, Wikidoc, licensed under CC by SA 3.0. Congenital torch infections, 2 fourths. Skin alterations in congenital syphilis BV. Plantar surfaces of the feet in a newborn with congenital syphilis. The right foot shows a fluid-filled blister. The left foot shows a blister that has already peeled. These features suggest pemphigus syphiliticus, which is pathognomonic for congenital syphilis. Source: copyright IMPP. Congenital torch infections, 1/4. Copyright overlay. Newborn with congenital syphilis. A face of a newborn infant with perioral fissures, brigades, indicating indicated by black arrow, and nasal discharge, indicated by white arrow, can be seen. These clinical features are characteristic of congenital syphilis. Source, ID hashtag 2246, CDC/Dr. Norman Cole, Centers for Disease Control and Prevention licensed under public domain. Urocongenital torch infections, 3/4. Hutchinson's teeth resulting from congenital syphilis BV. The central incisor teeth are narrow and notched, Hutchinson teeth, while the molars are not fully developed, mulberry molars. These findings occur after continued inflammation and scar formation through congenital syphilis. Source, ID hashtag 2385, Susan Lindsley, Centers for Disease Control and Prevention licensed under public domain. Further notes, Public Health Image Library, Bill, ID 2385. Urocongenital torch infections, 4/4. Spirochetes on dark field microscopy. Photomicrograph of rabbit testicular tissue, dark field microscopy combined with immunofluorescence, 54x magnification. Spiral bacteria are visible, which is the characteristic appearance of spirochetes. Source, 2335, CDC/CW Hubbard, Centers for Disease Control and Prevention's Public Health Image Library licensed under public domain. Congenital torch infections, 1/1. Overlay. Morganian, hypermature, cataract BV. Slit lamp photography. The completely opacified lens is visible in the pupil. Its darker, inferior part represents the sunken nucleus, blue overlay, within the liquefied cortex, white upper part, yellow overlay. This is the typical appearance of Morganian hypermature cataract. The anterior chamber shows deposits, probably macrophages filled with lens protein, examples indicated by arrowheads. This suggests a phacocytic process, which, if left untreated, can lead to phacolytic glaucoma. Hatched overlay, optical cross-section of the cornea, produced by slit lamp. Source, copyright IMPP. Congenital torch infections, 1/1. Y/Y/Y. Copyright. Overlay. Morganian, hypermature, cataract BV. Slit lamp photography. The completely opacified lens is visible in the pupil. Its darker, inferior part represents the sunken nucleus, blue overlay, within the liquefied cortex, white upper part, yellow overlay. This is the typical appearance of Morganian hypermature cataract. The anterior chamber shows deposits, probably macrophages filled with lens protein, examples indicated by arrowheads. This suggests a phacocytic process, which, if left untreated, can lead to phacolytic glaucoma. Hatched overlay, optical cross-section of the cornea, produced by slit lamp. Source, copyright IMPP. TLW 0.2 miles 0.38 build 53 7.8 centimeters. Overlay. Congenital CMV infection BV ultrasound of the CNS, parasagittal section, dilated lateral ventricles with hyperechoic deposits that are compatible with intraventricular hemorrhage. Source, copyright IMPP. TIW 0.2 MI 0.38 C8-5 WCHTL/COP build 53 7.8 centimeters. Congenital CMV infection S overlay. Ultrasound of the CNS, parasagittal section, dilated lateral ventricles with hyperechoic deposits that are compatible with intraventricular hemorrhage. Source, copyright IMPP. Congenital torch infections, 2/2. TIW 0.1 MI 0.39 C8-5 WCHTL/COP build 234 8.8 centimeters. Overlay. Congenital CMV infection VV ultrasound of the CNS, coronal section, dilated lateral ventricles with hyperechoic deposits that are compatible with intraventricular hemorrhage, green areas. Arrow equals periventricular calcification, Source, copyright IMPP. TLW 0.1 MI039 C8-5 WCHTL/cop build 234 8.8 cm A. Overlay. Congenital CMV infection VV. Ultrasound of the CNS, coronal section, dilated lateral ventricles with hyperechoic deposits that are compatible with intraventricular hemorrhage, green areas. Arrow equals periventricular calcification. Source, copyright IMPP. Otitis externa. Otitis externa, OE, is an inflammation of the external auditory canal, EAC, which is most often the result of a local bacterial infection. Risk factors for OE include exposure to water and injury to the skin of the EAC. OE is primarily a clinical diagnosis. It is characterized by ear pain, fullness and/or itching, and tenderness of the tragus and/or pinna. Otoscopy may show erythema, edema, debris, and/or otorrhea of the EAC. Treatment typically involves analgesia, keeping the EAC dry, and administering antiseptic, antibiotic, or glucocorticoid ear drops. Systemic antibiotic therapy is indicated in select cases. Example: patients with immunosuppression and/or diabetes who are at risk of a more severe variant, malignant otitis externa. Details on malignant otitis externa are covered in a separate article. GWS. Definition. Sent acute otitis externa, AOE inflammation of the EAC lasting. WA. FO, IEEE. Etiology. Acute otitis externa/31L21. Sent infectious causes. Copyright bacterial infections. Most common cause of otitis externa, equals Pseudomonas aeruginosa, 40% of cases, commonly from swimming activities, equals Staphylococcus aureus, Proteus mirabilis, Escherichia coli. Viral infections, rare herpes zoster, influenza viruses. Copyright fungal infections, less common Aspergillus, accounts for 90% of all fungal otitis externa. Candida. Sent non-infectious causes, less common. Copyright seborrheic otitis externa, associated with seborrheic dermatitis, O. eczematous otitis externa, a hypersensitivity reaction to pathogens or topical antibiotics, E. neurodermatitis, caused by compulsive/psychogenic scratching. Sent risk factors. Copyright injury to the skin of the EAC, example: cleaning, insertion of foreign objects such as hearing aids or earplugs, excessive itching. Copyright increased moisture in the EAC, example: swimming, humid climate. O. immunosuppression, example: diabetes, HIV. O. SH. Clinical features. Symptoms: FL. Sent severe ear pain, particularly at night. Sent otorrhea. Sent intense itching in the EAC. Sent hearing loss. Jaw pain. Eye examination findings /3IL21. Sent tenderness on palpation of the tragus. Sent pulling up and back on the auricle causes pain. The following may also be present. Copyright cruising of otorrhea at the entrance to the EAC. Copyright conductive hearing loss. Copyright clinical features of cellulitis. Copyright regional lymphadenitis. Otoscopy FL. Erythematous and edematous EAC. Sent otorrhea or debris. EAC may be occluded by a furuncle, impacted cerumen, or foreign body. Back collapse. Fine text outline. EAC may be occluded by a furuncle, impacted cerumen, or foreign body. Sent the tympanic membrane may be erythematous but should not bulge. At severe edema of the EAC may prevent otoscopic examination. WACE. Diagnostics. General principles 31. Sent diagnosis is clinical. Sent diagnostic studies are only performed. Copyright in suspected comorbid disease. Copyright to rule out differential diagnoses of otitis externa. O. for refractory disease or suspected subtypes, example: Mo diagnostic studies 31. Sent screening for comorbidities, consider based on clinical features. OAOE, screening for diabetes or screening for HIV plus culture of ear secretions should be obtained if there is. 2. Copyright insufficient response to initial treatment. Copyright 21 risk factor for a fungal or antibiotic resistant pathogen. Copyright concern the infection has extended, i.e., beyond the EAC. OOCE. Differential diagnoses. Condition: otitis media, myringitis, herpes zoster oticus, dermatitis, temporomandibular joint (TMJ) syndrome. Differential diagnosis of otitis externa, ALS. Clinical features: acute otitis media, degree middle ear effusion, degree no pinal or tracheal tenderness, chronic suburative otitis media, O perforated tympanic membrane, degree chronic otorrhea, inflamed tympanic membrane, potentially with bully, severe pain, no edema of the ear canal, severe pain, vesicular rash in ear canal and pinna, possible loss of taste or facial nerve palsy, itching, atopic dermatitis, chronic pruritus, history of atopy, contact dermatitis, potential allergens or irritants on or near the ear, example piercings, hearing aids, earplugs, seborrheic dermatitis, scaly rash extending to the hairline, scalp, ears, and slash or face pain, no signs of inflammation in the ear canal, tenderness over the TMJ, may be accompanied by crepitus. The differential diagnoses listed here are not exhaustive. KBAC equals QAL. Collapse, fine text outline. Exotitis externa. Itching, atopic dermatitis, chronic pruritus, history of atopy, M. dermatitis, contact dermatitis, potential allergens or irritants on or near the ear, example piercings, hearing aids, earplugs, seborrheic dermatitis, scaly rash extending to the hairline, scalp, ears, and slash or face A. Pain, temporomandibular joint, TMJ, syndrome, no signs of inflammation in the ear canal, tenderness over the TMJ, may be accompanied by crepitus. The differential diagnoses listed here are not exhaustive. Exo. Treatment. Approach/LL2. Initiate supportive therapy as needed, example analgesia, earwick, oral toilet. Evaluate for indications for systemic antibiotic therapy in AOE and start if present. Plus for uncomplicated AOE, initiate topical therapy for OE. 1-3, copyright antibiotic, ofloxacin, ciprofloxacin, or gentamicin, or antiseptic ear drops. O preparations may be combined with glucocorticoids. Copyright if patients do not respond to initial topical therapy, consider alternative diagnoses such as allergic contact dermatitis from an ototopical agent, otomycosis, or MO. 3. Systemic antibiotics for OE2-IL2. Scent indications. Copyright topical antimicrobial administration is not possible. Copyright disease extension outside the ear canal, e.g., equals cellulitis of the neck or face, equals suspected MO, equals concomitant AOMO, uncontrolled diabetes. Copyright immunosuppression. Copyright previous local radiotherapy. Scent choice of agent should cover P. aeruginosa and S. aureus, example ciprofloxacin 10. O. CE. Prevention. Indications, 11. Scent recurrent episodes of OE, scent immunosuppression, scent chronic dermatological conditions, example atopic dermatitis, psoriasis, scent frequent participation in water sports. Interventions, 2-2I12. Avoid manipulation of the ear canal, example use of cotton buds to clean the ear. Irregularly remove and clean earrings and in-ear devices, example hearing aids. Scent treat underlying chronic dermatological conditions. Plus frequent swimmers, use a tight-fitting bathing cap or ear plugs. 1L3, scent after bathing or swimming, copyright tilt the head to remove water. O dry the ear with a blow dryer at the lowest heat setting. Back collapse, fine text outline. Otitis externa VV. There is swelling and mild erythema of the external auditory canal and auricle. Purulent discharge from the external auditory canal is visible. The auditory canal appears to be obstructed. These findings are consistent with otitis externa. Source: Otitis externa by Klaus D. Peter, Wikimedia Commons, licensed under CC by 3.0. Acute otitis media. Otoscopic image of the tympanic membrane. There is bulging and erythema of the tympanic membrane, which appears dull and thickened. The light reflex is visible in the posterior upper quadrant, should normally appear in the anterior lower quadrant, and appears widened and heterogeneous due to bulging of the membrane. Source: Otitis media Differential 2 by B. Wells Chick, Wikimedia Commons, licensed under CC by SA 3.0. Chronic suppurative otitis media. Otoscopic image of the middle ear. The tympanic membrane is completely perforated and the tympanic cavity can be seen. The mucous membrane of the tympanic cavity is edematous and covered by clear secretions. These findings are diagnostic of chronic suppurative otitis media, which can develop from acute otitis media with tympanic membrane perforation. Source: Otitis Crohn Mesotype 7 by Wells Chick, Wikimedia Commons, licensed under CC by SA 3.0. Bullous myringitis. Otoscopic image of the left tympanic membrane showing bullae with clear content in the posterior upper and lower quadrants. The tympanic membrane shows erythematous changes with visible isolated hemorrhagic infiltrates, dark spots. This finding indicates bullous myringitis, a rare form of acute otitis media that is triggered by a virus. Source: Otitis media acuta, myringitis bullosa by B. Wells Chick, Wikimedia Commons, licensed under CC by SA 3.0. Otitis externa, 4/6. Herpes zoster oticus. Multiple grouped vesicles filled with clear fluid are visible on the ear. The anterior aspect of the helix is partially crusted. This is the typical appearance of herpes zoster oticus. The additional finding of unilateral facial nerve paralysis is diagnostic of Ramsay-Hunt syndrome. Source: Copyright IMPP. Otitis externa, 5/6. Eczematous dermatitis of the ear VV. The auricle appears mildly swollen. The skin is erythematous with erosions and crusting. These findings are in keeping with atopic dermatitis, a type of eczematous dermatitis. Source: Copyright IMPP. Seborrheic dermatitis of the face VV. There is marked erythema extending from the philtrum to both nasolabial folds, along both sides of the nasal bridge, and on the labiomental groove. There is also minor scaling of the skin on both sides of the nasal bridge. These findings are consistent with seborrheic dermatitis. Source: Seborrheic dermatitis by Roy Micheli, Wikimedia Commons, licensed under CC by 3.0. For acute otitis media. Acute otitis media, AOM, is a painful infection of the middle ear that most commonly results from a bacterial superinfection with Streptococcus pneumoniae, Haemophilus influenza, or Moraxilla catarrhalis following a viral upper respiratory tract infection. AOM is a common infection in children under the age of 2 years and is characterized by an acute onset of symptoms, example otalgia, fever, anorexia, with signs of middle ear inflammation, example bulging tympanic membrane, erythema. Mild unilateral infections can be managed without antibiotics, as they are often self-limiting. Infections in children under 6 months, bilateral AOM, or severe symptoms are usually treated with oral antibiotics. Most children will experience at least one episode before the age of 5. In children with recurrent AOM that causes frequent symptoms, myringotomy and insertion of tympanostomy tubes may be considered. The most common complication is acute mastoiditis, but facial palsy, labyrinthitis, and in rare cases, even intracranial abscesses may also occur. See also otitis media with effusion and chronic suppurative otitis media. OOE. Epidemiology. Highest incidence between 6 to 24 months of age. O approximate 60 to 80% of children. WA. OE. Pathophysiology. Scent. The eustachian tube connects the middle ear with the nasopharynx and is lined with cilia, which drain the middle ear secretions into the nasopharynx. Scent. Obstruction/blockage of the eustachian tube, ET. Lack of ventilation and drainage of the middle ear. Oversorption of the air in the middle ear. Negative middle ear pressure. Retraction of the tympanic membrane. Otalgia and conductive hearing loss. Accumulation of middle ear secretions. Bacterial superinfection. Pus in the middle ear. Bulging tympanic membrane. Severe otalgia. Fever. Scent. Predisposing factors for ET obstruction. Copyright. Inflammation of the ET mucosa. Viral URT. Infection. Most common cause. Allergic rhinitis. Copyright. Mechanical obstruction of the ET enlarged adenoids nasal polyps cleft palate. Infants, shorter, narrower, and more horizontal ET nasopharyngeal secretions easily reflux into the ET, more prone to developing AOM. References, Silel. WA. CE. Etiology. Common pathogens. 21. Scent. General considerations. Copyright. Co-infection with both bacterial and viral pathogens is common, 66% of cases. Less commonly, 27% of cases solely a bacterial infection. Purely viral AOM is rare. Scent. Viral pathogens is O. respiratory syncytial virus. Copyright. Parainfluenza virus. Back collapse. Find text outline. Evifulpathogens. Copyright. Respiratory syncytial virus. Copyright. Parainfluenza virus. Copyright. Influenza virus. Copyright. Rhinovirus. O. adenovirus. Risk factors for AOM. 821. Scent. Passive cigarette smoke. Children who attend daycare centers. Formula feeding/bottle feeding. 9. Pacifier use. Children who have more than one sibling or live in a crowded space. Male sex. Family or personal history of AOM. Anatomic abnormalities plus feeding in a supine position. 110. K. XO. Clinical features. Older children and adults will most frequently report ear pain. In infants and nonverbal children, symptoms can be nonspecific, and may be easily confused with other conditions. General symptoms. 81. Scent. Otalgia/earache, commonly described as throbbing pain. Scent. Hearing loss in the affected ear. Fever. Scent. Otorrhea in the case of a ruptured tympanic membrane, TM. Typical presentation in infants, 1 to 8. Irritability. Incessant crying. Scent. Refusal to feed. Anorexia. Scent. Repeatedly touching the affected ear. Scent. Fever and febrile seizures. Scent. Vomiting. Examination findings. 1. Otoscopy. Plus bulging tympanic membrane, TM, with loss of landmarks. 1 Scent. Opacification and loss of light reflex. Scent. Retracted and hypomobile TM. Purulent/zero sanguineous discharge in the external auditory canal or visible perforation plus distinct erythema of the TMJ is and L. Scent. Additional findings that may be present. Copyright. Yellow spot on the TM. 1. 12 cartwheel TM. 121. Copyright. Blisters or bully on the tympanic membrane. 9. 8115. Tuning fork test. Scent. The Weber test and Rhine test can be performed to verify conductive hearing loss secondary to an effusion. 14. Weber test. Sound localizes to the affected ear. Copyright. Rhine test. Air conduction is impaired in the affected ear, while bone conduction remains intact. Back collapse. Find text outline. Diagnostics. AOM is primarily a clinical diagnosis based on characteristic symptoms and otoscopic findings. Other causes of otalgia and hearing loss should be excluded. See differential diagnoses. Pneumatic otoscopy or tympanometry should be used to confirm the presence of an effusion. 2. Scent. Gram stain and culture of middle ear fluid. 2. Copyright indication. Patients who do not respond to initial therapy, acutely ill patients, and patients with immune deficiencies. 215. Copyright. Typically acquired through tympanocentesis, the extraction of middle ear fluid through a small gauge needle. GVU. 80. Differential diagnoses. Scent. Otitis media with effusion. Scent. Chronic suppurative otitis media. Scent. Trauma. Foreign bodies in the ear canal. Scent. Referred pain from teeth, sinuses, throat, or jaw sent herpes zoster oticus 1. The differential diagnoses listed here are not exhaustive. Now. Treatment. Conservative management. Uncomplicated AOM is self-limiting in most children, 80%. Sent outpatient observation and surveillance of symptoms for 48 to 72 hours plus oral analgesia, 1, 2, acetaminophen o ibuprofen. Many patients with AOM can be treated conservatively. 8. Antibiotic treatment. Systemic antibiotic therapy in AOM is recommended to relieve symptoms and reduce the risk of complications in young infants and patients with severe infections. 2. Copyright. Topical antibiotics are generally ineffective in treating AOM unless tympanostomy tubes are present. Indications. Children, ILSOH. Children with cochlear implants who develop AOM should always be treated with antibiotics. Regimens. Copyright. Amoxicillin is the first-line agent in antibiotic-naive patients. A macrolide can be given if the patient is severely allergic to penicillin. Empiric antibiotic therapy for acute otitis media FF, 26-2. No antibiotic use in previous 30 days, antibiotic use in previous 30 days. Penicillin allergy *type hypersensitivity to penicillin, A. Copyright. A macrolide 1. Empiric antibiotic therapy for acute otitis media A, 26-2. No antibiotic use in previous 30 days, antibiotic use in previous 30 days. Penicillin allergy type hypersensitivity to penicillin, copyright. A macrolide 1. Sent amoxicillin/clavulanic acid #azithromycin or clarithromycin *amoxicillin to 1271. Copyright. Oreganone 6.0 or either trimethoprim/sulfameth. Initial treatment *orofluoroquinolone. Adults only. Consider trimethoprim/sulfamethoxazole or amoxicillin/clavulanic acid I. 2. Copyright. Levofloxacin type IL hypersensitivity to penicillin. Copyright. Or moxifloxacin. Copyright. Cefdinir. Copyright. Or cefuroxim. Copyright. Or cefpodoxim. Copyright. Or cefprozil. Amoxicillin/clavulanic acid or one of the following cephalosporins, degree cefdinir P, *ceftriaxone *clindamycin. Treatment failure. Copyright. Cefpodoxim plus or clindamycin * or /levofloxacin. Copyright. Cefprozil == degree cefuroxim. Copyright. Ceftriaxone. Copyright. H.influenza and S.pneumoniae show limited sensitivity towards macrolides and trimethoprim/sulfamethoxazole. These antibiotics should only be used for patients with a proven history of type hypersensitivity to penicillin. 8. Surgical procedures. Scent indications. Copyright. Not routinely indicated in acute AOM. Copyright. Considered for patients with treatment failure or recurrent infection. Scent procedures. Copyright. Myringotomy, 1L28. Surgical incision into the tympanic membrane to drain fluid to relieve pressure/pain =. Consider as an adjunct to antibiotic therapy for severe otalgia and a bulging tympanic membrane. 1-2. Myringotomy with tympanostomy tube insertion. Trademark. 2. Placement of small tubes into the tympanic membrane to prevent the accumulation of fluid *. Consider for otitis media with effusion and in children with recurrent AOM. 2. OVU. Shared knot. Complications. Otitis media can spread to affect other local structures, example mastoiditis, labyrinthitis, facial nerve palsy, perforated tympanic membrane, or the intracranial cavity, example meningitis, cerebral venous thrombosis, otogenic abscess. Risk factors for complications. Complications are rare and are usually only seen in the following cases: scent highly virulent bacteria, example group A are hemolytic streptococci, immunocompromised patients, inadequate dose/duration of antibiotics, scent bacterial drug resistance. Mastoiditis. 2. Background. Scent definition, inflammation of the mastoid air cells. Scent epidemiology, most commonly occurs in children. Destruction of the air cells, scent mastoiditis, mastoid becomes a pus-filled cavity, empyema mastoid. Clinical features of mastoiditis. Scent signs and symptoms. Copyright recurrence of otalgia and fever after initial improvement. Back collapse. Find text outline. Clinical features of mastoiditis. Scent signs and symptoms. Copyright recurrence of otalgia and fever after initial improvement. Those symptoms persist for 2 weeks. Copyright tender and edematous mastoid. Ear displaced laterally and forward. Copyright in chronic mastoiditis, there may be persistent otorrhea. Scent otoscopy findings, may be normal. EOTM may be bulging and erythematous. O may be perforated with otorrhea. Copyright suspect mastoiditis in patients with recent or persistent otitis media and erythema, swelling, and / or pain behind the ear or protrusion of the pinna. 34. Diagnostics for mastoiditis, 8134-235. Mastoiditis is primarily a clinical diagnosis. Scent indications for imaging. Copyright symptoms that do not improve after 48 hours of treatment. Copyright suspected intracranial complication. Copyright planned surgical interventions. CT scan of the temporal bone, initial imaging study, if indicated. Copyright opacification of the mastoid air cells. Copyright erosion of the air cell walls. Copyright pus in the mastoid cavity, areas of enhancement on CT, plus MRI. Brain and temporal bone. 4. Consider as initial modality in children due to lack of ionizing radiation. 34 LL 35. Copyright more sensitive for intracranial infectious complications. Copyright characteristic findings include increased fluid signal intensity in mastoid air cells, plus X-ray of the mastoid. 371 I38O. Early stage, the air cells appear cloudy and indistinct. O. Advanced stage, a cavity can be seen in the mastoid. Management. Plus acute mastoiditis, 2 degree 1L39. Copyright start empiric antibiotic therapy with levofloxacin or ceftriaxone equals if episode is secondary to an acute exacerbation of chronic otitis media, surgical debridement of auditory canal and start antibiotic treatment with equals vancomycin equals for piperacillin / tazobactam equals for vancomycin and ciprofloxacin equals surgical interventions. Early infection, myringotomy and tympanostomy. Tube insertion to facilitate drainage equals severe or refractory cases, mastoidectomy. The removal of the mastoid air cells via a postauricular incision to facilitate drainage of pus, OA. Scent chronic mastoiditis. Copyright culture ear drainage. Copyright topical fluoroquinolone ear drops, example ciprofloxacin. Copyright consult an otolaryngologist for consideration of surgical interventions. Complications. Untreated, the pus may perforate through the bony walls and cause the following abscesses. Scent postauricular abscess. Copyright most common type. Copyright pus collects under the skin behind the ear. O pushes the auricle forwards and downwards. Scent dissolved abscess. Back collapse. Find text outline. Scent postauricular abscess. EO most common type. Copyright pus collects under the skin behind the ear. O pushes the auricle forwards and downwards. Scent dissolved abscess. O pus breaks the tip of the mastoid and dissects into the neck, often collecting behind the sternocleidomastoid. Degree causes neck pain, torticollis, and fever. Copyright treatment, 4 antibiotics plus mastoidectomy plus drainage of neck abscess and zygomatic abscess. Copyright infection spreads to the zygomatic air cells, located at the zygomatic root. E causes swelling in front of and above the auricle. Scent brain abscess. Bacterial labyrinthitis. Scent etiology, inflammation spreads to the inner ear, labyrinth, through the round window. Scent clinical features. O severe vertigo, nausea, and vomiting. O hearing loss. Copyright nystagmus. Direction can be variable, 1401L41. Scent diagnostics. O change of lateralization in Weber test. O audiometry, sensorineural hearing loss. Scent treatment. Copyright 4 antibiotics plus tympanostomy with insertion of tympanostomy tube plus glucocorticoids. Copyright mastoidectomy, to treat the source of infection in AOM. Otogenic abscess. Scent route of spread, direct spread of infection from the middle ear through the destroyed bone overlying the dura or through an emissary vein. Scent types: O epidural abscess, OE subdural abscess. Copyright cerebral abscess. The ipsilateral temporal lobe is the most common site. Ipsilateral cerebellar abscess is second most common. Scent clinical features: O persistent headache and otorrhea. Copyright signs of raised ICP. Copyright signs of meningeal irritation. Copyright focal neurological deficits. Scent diagnostics: MRI/contrast enhanced CT. Scent treatment: 4 antibiotics plus drainage plus mastoidectomy. Other intracranial complications: Scent C. meningitis. C. cerebral venous thrombosis. We list the most important complications. The selection is not exhaustive. WM. CE. Prevention 2. Recommend: copyright exclusive breastfeeding for at least 6 months. Copyright smoking cessation for caregivers. Scent advise limiting pacifier use and avoiding supine bottle feeding. Encourage adherence to the ACIP immunization schedule. Registered daycare attendance is associated with an increased risk of AOM. 2. O. CE. Tips and links. Sources: Back collapse vine text outline. Acute otitis media, 1/5. Forma acute otitis media. Mastoid bone possible spread to mastoid bone, r/**mastoiditis middle ear. Anatomy /KS. /tympanic /membrane YFEE external /struct TEJ auditory canal eustachian tube. Malleolar prominence opacification erythema. Otoscopic examination. Bulging tympanic membrane loss of light reflex. Acute otitis media VV. Copyright emboss. Acute otitis media, 2/5. Overlay. Healthy tympanic membrane VV. Otoscopic image of the right tympanic membrane. The tympanic membrane is seen as a pearly gray translucent ovoid disc at the end of the auditory canal. The stria malleoris, black line, is raised by the malleus and ends at the umbo, and divides the eardrum into 4 quadrants. The pars flaccida is located at the anterior-most aspect of quadrant 4, while the pars tensa fills the remainder of the 4 quadrants. The cone of light is visible at the edge of quadrants 1 and 2. Copyright emboss. Acute otitis media, 3/5. Acute otitis media VV. Otoscopic image of the tympanic membrane, TM, of the left ear. The TM appears cloudy, thickened, bulging can also be seen. The light reflex is visible in the posterior lower quadrant, normally visible in the anterior lower quadrant. Source: Otitis Media Schalig by B. Wells Chick, Wikimedia Commons, licensed under CC by SA 3.0. Acute otitis media. Otoscopic image of the tympanic membrane. There is bulging and erythema of the tympanic membrane, which appears dull and thickened. The light reflex is visible in the posterior upper quadrant, should normally appear in the anterior lower quadrant, and appears widened and heterogeneous due to bulging of the membrane. Source: Otitis Media and Differential 2 by B. Wells Chick, Wikimedia Commons, licensed under CC by SA 3.0. Bullous myringitis. Otoscopic image of the left tympanic membrane showing bullae with clear content in the posterior upper and lower quadrants. The tympanic membrane shows erythematous changes with visible isolated hemorrhagic infiltrates, dark spots. This finding indicates bullous myringitis, a rare form of acute otitis media that is triggered by a virus. Source: Otitis media acuta, myringitis bullosa by B. Wells Chick, Wikimedia Commons, licensed under CC by SA 3.0. Myringotomy with tympanostomy tube insertion VV. The procedure can be performed under local or general anesthesia. General anesthesia is usually required for children. An operating microscope is preferred, although the procedure can be performed using a handheld operating otoscope. 1. A radial incision is made in the anterior inferior quadrant of the pars tensa using a myringotomy blade. 2. Alligator forceps are used to insert the tympanostomy tube. Short-term tubes, I, are designed to self-extrude after approximately 1 year, whereas long-term tubes, IL, have a longer flange that prevents extrusion. 3. A curved or angled pick can be used to facilitate correct placement. Copyright emboss. Mastoiditis. Left retroauricular region of a child there is pronounced erythema and swelling, with ventral protrusion of the pinna as a result of swelling. The features are typical of mastoiditis, which can occur as a complication of otitis media. Source: Mastoiditis MIT subperiostelepsis by B. Wells Chick, Wikimedia Commons, licensed under CC by SA 3.0. Euroacute otitis media, 1/6. Mastoiditis. 9-year-old boy with right-sided ear pain and fever. Pronounced swelling and erythema can be seen behind the right ear. Copyright emboss. Mastoiditis. 9-year-old boy with right-sided ear pain and fever. The right ear is markedly protruded. This is caused by swelling and erythema behind the ear as a result of mastoiditis. Copyright emboss. Euroacute otitis media, 4/6. Overlay. Mastoiditis, 1/3, VV. MRI head, T1 weighted, without contrast, axial plane, green overlay, mastoiditis, red overlay, sinus vein thrombosis image source of original image, German Society of Pediatric Infectious Diseases, DGPI. Original title, DGPI, Mastoiditis, 1/3. Created by, German Society of Pediatric Infectious Diseases, DGPI. Modifications to original image, image cropped and enlarged, arrows and A removed. Further notes, used with kind permission of the German Society of Pediatric Infectious Diseases. Euroacute otitis media, 4/6. Copyright overlay. Mastoiditis, 1/3, VV MRI head, T1 weighted, without contrast, axial plane, green overlay, mastoiditis, red overlay, sinus vein thrombosis image source of original image, German Society of Pediatric Infectious Diseases, DGPI. Original title, DGPI, Mastoiditis, 1/3. Created by, German Society of Pediatric Infectious Diseases, DGPI. Modifications to original image, image cropped and enlarged, arrows and A removed. Further notes, used with kind permission of the German Society of Pediatric Infectious Diseases. Euroacute otitis media, 5/6. Overlay. Mastoiditis, 2/3, V. MRI head, T1 weighted, with contrast, axial plane, green overlay, mastoiditis, red overlay, thrombosis image source of original image, German Society of Pediatric Infectious Diseases, DGPI. Original title, DGPI, Mastoiditis, 2/3. Created by, German Society of Pediatric Infectious Diseases, DGPI. Modifications to original image, image cropped and enlarged, arrows and B removed. Further notes, used with kind permission of the German Society of Pediatric Infectious Diseases. Euroacute otitis media, 5/6. Copyright overlay. Mastoiditis, 2/3, V MRI head, T1 weighted, with contrast, axial plane, green overlay, mastoiditis, red overlay, thrombosis image source of original image, German Society of Pediatric Infectious Diseases, DGPI. Original title, DGPI, Mastoiditis, 2/3. Created by, German Society of Pediatric Infectious Diseases, DGPI. Modifications to original image, image cropped and enlarged, arrows and be removed. Further notes, used with kind permission of the German Society of Pediatric Infectious Diseases. Overlay. Mastoiditis, 3/3, MRI head, T2 weighted, axial plane, image source of original image, German Society of Pediatric Infectious Diseases, DGPI. Original title, DGPI, Mastoiditis, 3/3. Created by, German Society of Pediatric Infectious Diseases, DGPI. Modifications to original image, image cropped and enlarged, arrows and a removed. Further notes, used with kind permission of the German Society of Pediatric Infectious Diseases. Overlay. Mastoiditis, 3/3, MRI head, T2 weighted, axial plane, image source of original image, German Society of Pediatric Infectious Diseases, DGPI. Original title, DGPI, Mastoiditis, 3/3. Created by, German Society of Pediatric Infectious Diseases, DGPI. Modifications to original image, image cropped and enlarged, arrows and a removed. Further notes, used with kind permission of the German Society of Pediatric Infectious Diseases. X. Non-allergic rhinitis. Rhinitis is the irritation and swelling of the mucous membrane of the nose. There are two main types, allergic rhinitis and non-allergic rhinitis. Allergic rhinitis is caused by a type 1 hypersensitivity reaction that leads to inflammation of the nasal mucous membranes on exposure to certain allergens, example dust, animal dander, mold spores, or plant pollen. Non-allergic rhinitis does not always involve an inflammatory process, and it includes infectious rhinitis, atrophic rhinitis, vasomotor rhinitis, drug-induced rhinitis, occupational rhinitis, gustatory rhinitis, hormonal rhinitis, and non-allergic rhinitis with eosinophilia syndrome, NARES. Infectious rhinitis is most often secondary to an upper respiratory tract infection that manifests as rhinosinusitis. Clinical manifestations of rhinitis include nasal congestion, rhinorrhea, and postnasal drip. Atrophic rhinitis can be primary, idiopathic, or secondary, example due to granulomatous diseases. This form of rhinitis commonly manifests with a foul-smelling crust, filled nasal cavity and anosmia. Patients with NARES might present with nasal polyposis and hyposmia. Initial management of allergic rhinitis involves allergen and irritant avoidance and pharmacotherapy with intranasal corticosteroids or oral or intranasal antihistamines. Nasal lavage and surgical procedures can relieve symptoms in patients with atrophic and vasomotor rhinitis. Allergic rhinitis is covered in detail separately. OC. E. Definition 1. Scent rhinitis, irritation and swelling of the mucous membrane of the nose. Scent allergic rhinitis, acute or chronic rhinitis caused by exposure to an inhaled allergen, example dust, animal dander, mold spores, plant pollen. Scent non-allergic rhinitis, acute or chronic rhinitis syndrome that is not IgE mediated. Types of non-allergic rhinitis. Apart from infectious rhinitis, non-allergic rhinitis includes the following subtypes. Types of non-allergic rhinitis. Type description. Causes. Most common type of inflammatory non-allergic rhinitis. Non-allergic rhinitis with eosinophilia *, chronic eosinophilic rhinitis with development of nasal polyposis and hyposmia syndrome, NARES. 2. Most commonly occurs in middle-aged individuals. Increased eosinophils in the nasal mucosa confirm the diagnosis. Unknown. Aspirin and other NSAIDs antihypertensives, example ACE inhibitors, clonidine, guanethidine, hydralazine, methyldopa, recurrent, non-allergic inflammation of the nasal mucosa associated with certain phosphodiesterase inhibitors, example sildenafil, tadalafil, medications vardenafil, oral contraceptives antipsychotics, example risperidone, chlorpromazine. Drug-induced rhinitis. Antidepressants, example amitriptyline. Rebound nasal congestion that is seen upon discontinuing intranasal sympathomimetics. Discontinuation of intranasal sympathomimetics, example occurs 5 to 7 days after use of topical decongestants phenylephrine, oxymetazoline, xylometazoline, classically leads to increasing dose or frequency of decongestants, vicious cycle. Rhinitis medicamentosa. Pregnancy rhinitis associated with hormonal imbalance 1 menstruation hormonal rhinitis rhinitis of pregnancy usually starts during the 2nd month of pregnancy and stops at puberty after the delivery. OCP's hypothyroidism. 1. Irritants, example fur, flour, paints, pesticides, dust, talc, detergents, chemicals, allergenic substances, example rodent allergens, latex, goo or gum. Rhinitis as a result of exposure to irritants in a particular work environment most commonly seen in furriers, followed by bakers, breeders, veterinarians, farmers, cleaners, assemblers of electrical products, and laboratory employees. Occupational rhinitis cilium. Episodic rhinitis with diffuse watery rhinorrhea that is associated with certain foods. Spicy food gustatory stati rhinitis hinati, alcohol. Primary form, idiopathic. Secondary form copyright granulomatous diseases of the nasal cavity. Atrophic rhinitis. Chronic rhinitis associated with atrophy and sclerosis of nasal mucosa. Infectious, example syphilis, leprosy, equals non-infectious, example SLE, granulomatosis with polyangiitis, copyright radiotherapy and/or operations involving the nasal cavity. Most often idiopathic plus irritant odors, example cigarette smoke, perfumes, car exhaust. 2. Temperature change, example cold and dry air, changes in a type of non-allergic rhinitis that is caused by an increase in blood flow to the nasal and C equals AA. Back collapse. Fine text outline. Ivivil verse 4 po irritant odors, example cigarette smoke, perfumes, car exhaust, scent. Temperature change, example cold and dry air, changes in humidity, certain drugs, example aspirin, NSAIDs, alpha-1 blockers, beta blockers, OCPs, emotional stimuli, example anxiety, excitement. A type of non-allergic rhinitis that is caused by an increase in blood flow to the nasal mucosa. Vasomotor rhinitis. And both allergic and non-allergic rhinitis manifest with post-nasal drainage and nasal congestion. However, nasal itching and sneezing are only seen in allergic rhinitis. Atrophic rhinitis. Scent definition. Chronic rhinitis associated with atrophy and sclerosis of the nasal mucosa. Etiology. Copyright primary atrophic rhinitis, ozona, an idiopathic condition, which primarily affects middle-aged women in tropical regions, example in India, China, Latin America, the Mediterranean, associated with mucosal colonization with Klebsiella ozoni. 3. Copyright secondary atrophic rhinitis occurs following equals granulomatous diseases of the nasal cavity equals infectious causes include syphilis, leprosy. Rhinoscleroma equals non-infectious causes include SLE, granulomatosis with polyangiitis equals radiotherapy and/or operations involving the nasal cavity. Scent clinical features. Merciful anosmia, extremely foul-smelling nasal cavity but the patient is unaware of the foul smell. Anosmia. Copyright nasal cavity is spacious, lacks turbinates, and is covered in yellowish-green crusts. Epistaxis. Scent diagnostics. Copyright no specific diagnostic test is indicated. Copyright rhinoscopy, nasal cultures, and/or CT scans may be performed to evaluate the extent of the disease. Treatment, aims to decrease the size and improve the blood flow of the nasal cavities and to promote regeneration and increase lubrication of the dry nasal mucosa, but no form of treatment can completely eliminate the symptoms. Copyright removal of nasal crusts, irrigation of the nasal cavity with warm saline equals application of 25% glucose in glycerin, antibiotic solutions, and or estradiol to the wall of the nasal mucosa. 1. Systemic antibiotics, example fluoroquinolones, rifampicin, streptomycin. Copyright surgical procedures that decrease the volume of the nasal cavity. 3. Modified Young's procedure, equals insertion of Teflon paste, fat, or bone underneath the mucosa of the nasal cavity. No randomized clinical trials are available to confirm the efficacy of these measures. Copyright topical sympathomimetic drugs, example xylomtazoline, are contraindicated in atrophic rhinitis since they may decrease vascular perfusion of the nasal cavity and worsen symptoms. VA. O. LS vasomotor rhinitis. Plus definition, a type of non-allergic rhinitis that is caused by an increase in blood flow to the nasal mucosa. Plus etiology, copyright most often idiopathic O irritant odors, example cigarette smoke, perfumes, car exhaust, O temperature change, example cold and dry air, changes in humidity. Copyright certain drugs, example aspirin, NSAIDs, alpha-1 blockers, beta blockers, OCPs. Copyright emotional stimuli, example anxiety, excitement, scent. Pathophysiology. E1 parasympathetic activity, parasympathetic stimulation. Causes vasodilatation of blood vessels in the nasal mucosa and increases mucus secretion. OJ sympathetic activity, sympathetic stimulation causes vasoconstriction of the nasal blood vessels. Scent clinical features. O sneezing. Copyright nasal congestion, rhinorrhea, post-nasal drip. Copyright hypertrophic turbinates may be seen in chronic vasomotor rhinitis. Scent treatment of vasomotor rhinitis. O address the underlying cause of rhinitis. Back collapse. Fine text outline. EJ sympathetic activity, sympathetic stimulation causes vasoconstriction of the nasal blood vessels. Scent clinical features. O sneezing. E nasal congestion, rhinorrhea, post-nasal drip. O hypertrophic turbinates may be seen in chronic vasomotor rhinitis. Scent treatment of vasomotor rhinitis. O address the underlying cause of rhinitis. O medical therapy. Intranasal installation of hypertonic NaCl solution. 5. Intranasal antihistamines, example azelastine and or intranasal glucocorticoids, example fluticasone, equals nasal decongestants, example phenylephrine, oxymetazoline. Copyright surgical therapy equals resection of hypertrophic nasal turbinates in order to relieve nasal obstruction. Endoscopic Vidian neurectomy. Differential diagnoses. Epidemiology. Degree. Scent. Causes. Onset. Clinical features. Nasal obstruction. Olfactory function. Allergic rhinitis 10 to 30% usually starts in childhood, before the age of 20 years. Exposure to an inhaled allergen type hypersensitivity reaction. Gradual. Sneezing, nasal congestion, rhinorrhea, post-nasal drip, temporary hypertrophic turbinates that are pink or violaceous, hard, sensitive to probing, and immobile. Bilateral. Normal. CC. Diptynasal polyps. More common in those 40 years old. Chronic mucosal inflammation. Gradual. Post-nasal drip, pale, soft, mobile, and insensitive lesions of the nasal mucosa or paranasal sinuses. Bilateral. Frequently impaired. Of nasal deviated nasal septum. Very common, 80%. Trauma, example nasal injury during motor vehicle accidents, birth trauma, example compression, congenital disorders, example Marfan syndrome. Gradual sudden in case of trauma. Difficulty breathing, snoring or noisy breathing during sleep, headaches or facial pain. Usually partial and unilateral. Normal. Adenoid hypertrophy. Mostly young children, 2 to 6 years. Adenoidal inflammation due to viral/bacterial infections or allergens. Gradual. Mouth breathing, mucopurulent nasal discharge, snoring, impaired hearing. Posterior. Normal. For more info on nasal polyps, deviated nasal septum, adenoid hypertrophy, and foreign nasal body, see their respective articles. The differential diagnoses listed here are not exhaustive. OTWYT. OB Sharik. Treatment. Avoidance of triggers, example medications, tobacco smoke, alcohol, scent, nasal irrigation, example with small amounts of saline solution, intranasal glucocorticoids and/or intranasal antihistamines 1 for severe symptoms, oral decongestants, example pseudoephedrine, scent for gustatory rhinitis, nasal ipratropium. Sources. Back. Last updated January 29, 2024. Equals a collapse. A. Find text. Foreign nasal body * mostly young. Children, median ages 3 years. Insertion of foreign bodies into the nose. Sudden. Epistaxis unilateral, foul-smelling, purulent rhinorrhea. Unilateral. Normal. O. Outline. X. Sinusitis. Rhinosinusitis is a mucosal inflammation of both the paranasal sinuses and adjacent nasal cavities. Viral infection is the most common cause of acute rhinosinusitis, RS. Bacterial and fungal infections also occur. The characteristic symptoms of rhinosinusitis are purulent rhinorrhea, nasal obstruction, and facial pain. RS is often self-limiting, but antibiotic therapy may be indicated in the case of suspected or diagnosed bacterial superinfection. Imaging and endoscopy are reserved for patients with recurrent sinusitis, red flags for rhinosinusitis, or certain risk factors, example immunosuppression. Rarely, the infection may spread to the soft tissues, bone, vascular system, and/or central nervous system. Chronic rhinosinusitis, CRS, a chronic inflammatory state similar to asthma, lasts at least 12 weeks and may be complicated by bacterial exacerbations or chronic fungal infections. Diagnosis is confirmed by findings of inflammation on imaging, anterior rhinoscopy, or nasal endoscopy. Underlying comorbidities, such as allergy, cystic fibrosis, and immunodeficiency, should be ruled out. First-line treatment of CRS is intranasal steroids and nasal irrigation for symptomatic relief. Patients with persistent symptoms may require surgery. O. CE. Definition. Scent sinusitis, inflammation of all sinuses on one or both sides. Scent acute sinusitis, inflammation of the sinuses for 12 weeks. Scent recurrent acute sinusitis, 4 or more separate episodes of acute sinusitis that occur within 1 year, with at least 8 weeks of symptom resolution between episodes. Scent rhinosinusitis, simultaneous inflammation of the nasal mucosa and sinuses. References 1I 2I. WA. FA, IEEE. Epidemiology. Scent incidence. Sinusitis is one of the most commonly diagnosed conditions in the USA, affecting an estimated 35 million individuals per year. Scent peak incidence, early fall to early spring. Sex, 2A. References 3. Epidemiological data refers to the US, unless otherwise specified. WA. CE. Etiology. Scent pathogens. Copyright viral, most common rhinovirus, coronavirus, adenovirus, influenza, and parainfluenza viruses. O bacterial, particularly S. pneumoniae, H. influenza, M. catarrhalis, S. aureus, E. coli, and Klebsiella. O fungal, example Aspergillus, Rhizopus oryzae. 1. Scent route of transmission, droplet transmission, particularly in winter months. Scent risk factors. O pre-existing viral upper respiratory tract infection, URTI most common, leads to superimposed bacterial infections. Copyright ventilation disorders of the sinuses equals hypertrophy of nasal turbinates, nasal polyps, deviation of nasal septum, impairments of ciliary function such as cystic fibrosis, primary ciliary dyskinesia, granulomatosis with polyangiitis, allergic inflammation, and immunodeficiency equals concha bullosa, also known as a middle turbinate pneumatization. Copyright foreign body lodged in the nasal cavity, particularly seen in children. Copyright odontogenic infection, leads to unilateral maxillary sinusitis. Copyright rhinitis, spread of pathogens via nasal mucosa. Bronchial asthma. Copyright analgesic, NSAIDs, aspirin, intolerance. References. Back collapse. Fine text outline. Pathophysiology. Sinusitis is triggered by 3 factors: obstruction of sinus drainage pathways, sinus ostia, due to mucosal edema, ciliary impairment, and altered mucus quantity and quality, stasis of secretions inside the sinuses, proliferation of various pathogens / sinusitis. Scent recurrent, untreated / complicated acute sinusitis may lead to chronic sinusitis. References. WA. OE. Clinical features. Acute rhinosinusitis, 6. Rhinitis. Scent sneezing, nasal congestion, rhinorrhea, and postnasal drip. Scent hyposmia / anosmia. Sinusitis. Unspecific symptoms: fever, 50% of cases, headaches, general malaise, myalgia plus facial pain / pressure, erythema, and swelling over the affected area due to inflammation. Maxillary sinuses are most commonly affected. Since maxillary ostium, which drains the maxillary sinuses, is located posteriorly and medially near the roof of the maxillary sinus, secretions are drained against the pull of gravity, i.e., upwards, causing secretions to accumulate and increasing the susceptibility to infection. Inflammation of mucosa sinus ostial blockage, drainage into the osteometal complex. Mucus production by the nasal mucosa, congestion and swelling of the nasal passages, sinus cavity, hypoxia and mucus retention, function of nasal cilia, transportation of mucus and debris from the nose, creation of ideal conditions for bacterial growth. 1. Susceptibility to infection manifests with pain in jaw region, mimics dental pain. Frontal sinuses, pain in the lower forehead. Ethmoidal sinuses, pain in the nasal bridge region or retroorbital pain. Copyright sphenoid sinuses, located in the sphenoid bones near the optic nerve and pituitary gland. 1. Scent transillumination may show opacification. 1. Subtypes. Scent acute viral rhinosinusitis. May occur with acute otitis media. May manifest with other symptoms of URTI, example sore throat, cough. Scent acute bacterial rhinosinusitis. Copyright severe symptoms, including fever 39 degrees Celsius, facial pain, purulent nasal discharge. Symptoms typically remain stable or improve for 5 to 6 days and then worsen, double worsening. Fungal rhinosinusitis, see fungal rhinosinusitis. 4. Chronic rhinosinusitis. Chronic rhinosinusitis can manifest acutely with exacerbation of symptoms or take an insidious course with low-grade symptoms persisting over months to years. Scent symptoms. Copyright facial pain. Mucopurulent drainage, anterior, posterior, or both, anosmia or hyposmia. Nasal congestion scent signs of inflammation. Copyright purulent mucus or edema in the middle meatus/anterior ethmoidal area seen in anterior rhinoscopy. Polyps in the nasal cavity/middle meatus. Subtypes. Scent chronic fungal rhinosinusitis, see fungal rhinosinusitis below. Scent chronic rhinosinusitis with nasal polyps, pathogenesis is not fully understood, but there is an association with asthma, allergic rhinitis, and cystic fibrosis. 7. Scent chronic rhinosinusitis without nasal polyps, pathogenesis is associated with anatomical abnormalities, example septal deviation, tumors, and dental disease, i.e., sinusitis of dental origin. AO. Subtypes and variants. Back collapse. Fine text outline. Subtypes and variants. Nasal polyps, 7 to 8. Scent definition, benign lesions of the nasal mucosa or paranasal sinuses due to chronic mucosal inflammation. Scent risk factors. Copyright chronic rhinosinusitis. Copyright cystic fibrosis, cf. Aspirin. Exacerbated respiratory disease, AERD, aspirin or NSAID-induced triad of asthma, chronic sinusitis with recurrent nasal polyps, and sensitivity to aspirin and other NSAIDs. 9. Scent clinical features. Copyright post-nasal drip. Bilateral nasal obstruction. Frequently impaired olfactory function, from hyposmia to anosmia. Fever and severe facial pain are uncommon. Scent special form, choanal polyp. Copyright definition, isolated, soft nasal polyp that originates in the mucous membrane of the maxillary sinus, rarely in ethmoidal cells, and grows from the middle nasal meatus into the nasopharynx. Copyright clinical features, nasal obstruction or features of sinusitis. Copyright treatment, complete endoscopic excision. Scent diagnostics. Nasal cytology for eosinophilia. Evaluate for associated conditions, example sweat chloride test for CF. Nasal endoscopy, bilateral gray. Polypoid mucosa hypertrophy. Degree. CT determines the exact location and extent of polyps. Also useful to exclude other causes of nasal obstruction. Scent differential diagnosis, nasal papilloma. Scent treatment. Copyright topical or systemic glucocorticoids. Copyright resection of polyps if symptomatic despite medical therapy. Primary ciliary dyskinesia, LL11. But recurrence is common. Scent definition, rare autosomal recessive disorder characterized by absent or dysmotile cilia caused by a defect in the dynean arm of microtubules. Scent clinical features. Degree. Chronic productive cough, recurrent otitis, sinusitis, and nasal polyps. Bronchiectasis. Conductive hearing loss, displaced heart sounds, as a result of dextrocardia. Degree. Scent diagnostics. Infertility in men due to decreased sperm motility as a result of defective flagella. Reduced fertility in women, and rarely ectopic pregnancy, due to defective cilia in fallopian tubes. Cartagener syndrome, classic triad of situs inversus, recurrent sinusitis, and bronchiectasis. Nasal nitric oxide test, reduced nasal nitric oxide, screening test, copyright genetic tests for dynean arm mutations. Chest X-ray, bronchiectasis, dextrocardia, and situs inversus, suggests Cartagener syndrome, copyright electron microscopy, abnormal cilia. Scent treatment, depends on individual clinical presentation and course. And you can memorize the cause of Cartagener syndrome by thinking of Cartagener's restaurant that only has takeout service because there is no dine-in. C2, Cartagener syndrome is a subtype of primary ciliary dyskinesia characterized by the triad of situs inversus, chronic sinusitis, and bronchiectasis. Fungal rhinosinusitis, FRS, 12-131I4. Scent definition, rhinosinusitis caused by a fungal pathogen, 12. Scent classified by K. Back equals QL. Collapse. Fine text outline. Fungal rhinosinusitis, FRS, 12I1324. Asterisk definition, rhinosinusitis caused by a fungal pathogen, 121 cent classified by, copyright duration, acute. Copyright CT, possible findings include fungal balls, bony erosions, and extrasinonasal spread. 415. OMRI, may be indicated to assess for cranial or orbital spread, especially in acute invasive fungal rhinosinusitis. Copyright nasal endoscopy, findings indicating acute invasive fungal rhinosinusitis include pale mucosa, dark necrotic areas, and crusting/ulcers. Copyright fungal culture, copyright biopsy B-. Management ON specialist should manage all cases of suspected fungal rhinosinusitis. Copyright patients with acute invasive fungal rhinosinusitis admit as an inpatient and consult ENT and ID services immediately. Treatment may include surgical debridement of necrotic tissue, systemic antifungal therapy, example amphotericin B, and reversal of immunosuppression if possible. 5. Copyright acute invasive fungal rhinosinusitis is a life-threatening diagnosis with a mortality rate of 50 to 80%. If suspected, immediately admit the patient and consult ENT. 13. WA. CE. Diagnostics. General principles, ILL-14. Acute viral/bacterial rhinosinusitis is a clinical diagnosis. Assess patients using diagnostic criteria for acute rhinosinusitis. Copyright imaging is only required for patients with any of the following, red flags for rhinosinusitis. Risk factors for complications, example immunosuppression, diabetes, history of facial trauma, recurrent recent chronic rhinosinusitis. Diagnosis is confirmed by findings of inflammation on one of the following, OCT scan. Copyright direct visualization. Copyright a clinical diagnosis of chronic sinusitis should be confirmed with objective documentation of sinonasal inflammation, which can be accomplished via anterior rhinoscopy, nasal endoscopy, or CT scan. 6. Imaging, 6/17/14. Sent CT maxillofacial with or without 4 contrast. Copyright findings may include signs of rhinosinusitis, opacification, mucosal thickening, air fluid levels, soft tissue swelling. A15 complications, spread beyond the sinuses. Underlying causes of CRS, example anatomic abnormalities, osteometal obstruction, polyposis. 5 aggressive fungal infection or neoplasm, example osseous destruction, extrasinus extension, local invasion. SIL 13. Sent MRI with and without 4 contrast, can be used to evaluate for intracranial or intraorbital involvement or to differentiate polyps from tumors. FEL 14, T17, sent X-ray sinuses. Copyright no longer recommended due to limited sensitivity and specificity. Copyright may show sinus opacification and air fluid levels. 9, 5. Co equals AOO. Back collapse. Fine text outline. Direct visualization. Sent indications, evaluation of complicated rhinosinusitis, recurrent RS or CRS. Modalities. Copyright nasal endoscopy, preferred. 1 Copyright anterior rhinoscopy. Sent findings. Degree signs of rhinosinusitis, mucosal erythema, edema, osteometal blockage with purulent drainage. 6 Copyright detection of structural abnormalities or masses, if present. 7 Copyright signs of fungal rhinosinusitis, necrosis. Pale or dark necrotic mucosa with crusting or ulcers indicates acute invasive fungal rhinosinusitis, which is a medical emergency. 18. Additional studies. Sent evaluation for comorbid conditions, perform for patients with recurrent RS and CRS. 6. Sent bacterial/fungal cultures, request in cases of treatment failure. Biopsy, endoscopic or surgical to identify an underlying condition, including malignancies, and to enable classification fates. O. OE. Treatment. Approach to treatment of rhinosinusitis. Scent acute rhinosinusitis or uncomplicated viral rhinosinusitis is usually self-limiting. Copyright uncomplicated ABRS treat with antibiotics or, if follow-up is assured, observe for up to 7 days before initiating antibiotics. AA equals if symptoms worsen at any time or fail to improve with treatment, reconsider the diagnosis and initiate or switch antibiotic treatment. CA copyright acute invasive fungal rhinosinusitis, antifungal therapy, example amphotericin B, and surgery. Scent chronic rhinosinusitis O advise nasal saline irrigation for symptomatic relief. Copyright treat the underlying inflammation with corticosteroids. Copyright in patients with CRS, do not prescribe antifungals, topical or systemic, and only use systemic antibiotics for the treatment of acute exacerbations. Registered LL20 LL14L. Symptomatic treatment, L1. The following options may be offered to all patients with rhinosinusitis. Nasal saline irrigation scent oral analgesics, example ibuprofen, or acetaminophen scent intranasal steroids, example mometasone decongestants, example oxymetazoline antibiotic treatment, 61. Indications copyright acute bacterial rhinosinusitis, initially or if symptoms worsen or do not improve during observation, copyright episode of recurrent bacterial rhinosinusitis copyright acute exacerbation of chronic rhinosinusitis regimens O first-line antibiotic therapy, amoxicillin, with or without clavulanate copyright usual oral treatment duration for adults, 5 to 10 days WG, copyright consider risk factors for treatment failure when choosing an appropriate antibiotic. Equals increased risk of bacterial resistance equals severity of infection I equals patient factors, including smoke exposure, age 65 years, and comorbidities, example diabetes, or cardiac/hepatic/renal disease copyright in case of treatment failure, switch to one of the recommended antibiotic regimens from a different class with broader coverage. Antibiotic treatment in acute bacterial rhinosinusitis, ABRS, L2I1T1 adults children. Asterisk non-type hypersensitivity to penicillin 2I, 22 copyright clindamycin asterisk any type of hypersensitivity to penicillin copyright plus a third-generation cephalosporin P penicillin allergy GP2 copyright second or third-generation cephalosporins A, asterisk T hypersensitivity to penicillin M1. Back collapse fine text outline. Antibiotic treatment in acute bacterial rhinosinusitis, ABRS, L2121 adults children. Amoxicillin first-line treatment or amoxicillin/clavulanate or amoxicillin/clavulanate. Non-type hypersensitivity to penicillin 4-3, copyright clindamycin 22 any type of hypersensitivity to penicillin E plus a third-generation cephalosporin penicillin allergy copyright second or third-generation cephalosporin CF type hypersensitivity to penicillin BSID tie to pi degree or clindamycin plus cefixime 1 copyright doxycycline degree or a respiratory fluoroquinolone A. Ampicillin/sulbactam levofloxacin ampicillin/sulbactam inpatient treatment asterisk moxifloxacin asterisk ceftriaxone asterisk ceftriaxone asterisk cefotaxime asterisk cefotaxime. Surgery 11623. Scent indications copyright evidence of structural abnormalities, example polyps, masses, or anatomical obstructions copyright treatment failure or complications of rhinosinusitis copyright acute invasive fungal rhinosinusitis scent objective copyright improving aeration through sinus opening and drainage copyright debridement of necrotic tissue or abscess drainage copyright correction/removal of anatomic obstructions 1 copyright obtaining intraoperative cultures and biopsy for histopathology if the diagnosis remains unclear. 7 CG, Char. Complications. Scent local spread copyright mucoceles. Copyright osteomyelitis, especially of the frontal bone, also known as Pott's puffy tumor subperiosteal abscess with local pain and edema that requires antibiotic treatment and surgery. Scent spread to the orbit o preceptal/orbital cellulitis o orbital abscess o cavernous sinus thrombosis o cavernous sinus syndrome. Scent intracranial spread o subdural abscess, most common copyright meningitis o brain abscess. Systemic complications copyright bacteremia/sepsis o pneumonia. Copyright multiple organ failure o untreated chronic sinusitis can lead to life-threatening complications, as may be seen in patients with cystic fibrosis. Copyright orbital and intracranial necrotic spread is especially common in invasive fungal sinusitis. References, 24ll25. We list the most important complications. The selection is not exhaustive. OS. OFOS. Related 1-minute telegram. Sent 1-minute telegram 80-2023-2/3, acute sinusitis, the color of nasal discharge is not important. Interested in the newest medical research, distilled to just 1 minute? Sign up for the 1-minute telegram in the tips and links below. Back collapse fine text outline. Copyright overlay. Concha bullosa VVCT paranasal sinuses, without contrast, coronal plane, pneumatization of the left middle turbinate, or concha bullosa, CB, green overlay, is accompanied by rightward deviation of the nasal septum, S. MT, middle turbinate, IT, inferior turbinate, MS, maxillary sinus, ES, ethmoid sinus source, copyright IMPP. Overlay. Chronic rhinosinusitis CT paranasal sinuses, without contrast, coronal plane, the ethmoid sinuses are opacified, hatched green overlay, and there is lobulated thickening of the walls of the maxillary sinuses, green overlay. The findings indicate nasal polyps and retention cysts. Source, copyright IMPP. Urosinusitis, 1/7. MDMG. Overlay. Chronic rhinosinusitis CT paranasal sinuses, without contrast, coronal plane, the ethmoid sinuses are opacified, hatched green overlay, and there is lobulated thickening of the walls of the maxillary sinuses, green overlay. The findings indicate nasal polyps and retention cysts. Source, copyright IMPP. Urosinusitis, 2/7. IY.3 mm-04.5 degree 3 mm 25 at cmx equals plus 80.66 cm y equals plus 8.99 cm h. Overlay. Nasal polyposis VV. CT scan of the paranasal sinuses, axial view, polypoid mucosal swelling in the right sphenoidal sinus in close proximity of the internal carotid artery, the arrow. Source, copyright IMPP. Urosinusitis, 2/7. V4Y.5 mm-04.5 degree 3 mm 25 at cmx equals plus 80.866 cm y equals plus 6.99 cm h. Overlay. Nasal polyposis VV. CT scan of the paranasal sinuses, axial view, polypoid mucosal swelling in the right sphenoidal sinus in close proximity of the internal carotid artery, the arrow. Source, copyright IMPP. Overlay. Chronic rhinosinusitis with polyposis. CT facial bones, bone window, coronal plane, extensive polyp formation has caused circumferential thickening of both maxillary sinuses, green overlay, and widening of the ostia. Mucosal thickening and opacification also involve the nasal cavity, blue overlay, ethmoid sinuses, yellow overlay, and frontal sinuses, red overlay. Source, Fig 1, in Recent advances in the surgical management of rhinosinusitis by Jaksha A.F., Weitzel E.K., Lori A.M., F1000 Research, licensed under CC by 4.0. Copyright. Overlay. Chronic rhinosinusitis with polyposis. CT facial bones, bone window, coronal plane. Extensive polyp formation has caused circumferential thickening of both maxillary sinuses, green overlay, and widening of the ostia. Mucosal thickening and opacification also involve the nasal cavity, blue overlay, ethmoid sinuses, yellow overlay, and frontal sinuses, red overlay. Source: Fig 1, in Recent Advances in the Surgical Management of Rhinosinusitis by Jaksha A.F., Weitzel E.K., Lori A.M., F1000 Research, licensed under CC by 4.0. Autosomal recessive dynean-arm defect immotile cilia dysfunctional epithelia, example respiratory epithelium. Cartagener syndrome. Copyright Emboss. Cartagener syndrome. Classic triad. AMAC recurrent otitis media, hearing loss recurrent sinusitis situs inversus, example dextrocardia. Subfertility due to dysfunctional fallopian tube cilia. 3 Infertility due to immotile sperm. Bronchiectasis. Sinusitis, 5/7. Overlay. Situs inversus with dextrocardia, situs inversus totalis, VV X-ray chest, PA view, the aortic arch, dotted line, cardiac apex, arrow, and gastric bubble, red overlay, are seen on the right side of the body. Opacification in the left upper abdominal quadrant, green overlay, is the result of a left-sided liver. Source: Situs inversus chest Nevid by Nevid, Wikimedia Commons, licensed under CC by 3.0. Sinusitis, 5/7. Overlay. Situs inversus with dextrocardia, situs inversus totalis, VV X-ray chest, PA view, the aortic arch, dotted line, cardiac apex, arrow, and gastric bubble, red overlay, are seen on the right side of the body. Opacification in the left upper abdominal quadrant, green overlay, is the result of a left-sided liver. Source: Situs inversus chest Nevid by Nevid, Wikimedia Commons, licensed under CC by 3.0. 10.00 RMM/DIVA 10.00 RM/DIV equals 6. Overlay. Situs inversus due to Cartagener syndrome. CT abdomen, with contrast, axial plane, mirror image reversal of abdominal organs, situs inversus, is present, with the liver, L, located on the patient's left and the spleen, S, on the right. Situs inversus is one of the clinical features seen in Cartagener syndrome. K, kidney. This image is an adaptation. Source of original image, Wikimedia Commons. Original title, Primary Ciliary Dyskinesia. Created by John S. 2, MD. Licensed under public domain. Modifications to original image, upscaled. 10.00 mm/DIV. EEOEILIE equals 10.00 mm/DIV. Copyright overlay. Dextrocardia in Cartagener syndrome. CT chest, with contrast, axial plane, the base to apex cardiac axis is directed to the patient's right, dextrocardia. The right ventricle, RV, and left ventricle, LV, are reversed. This patient also presented with right to left reversal of the morphologic atria and abdominal organs, situs inversus, not shown. Dextrocardia with situs inversus is part of the triad of manifestations seen in Cartagener syndrome, which also includes chronic sinusitis and bronchiectasis. Source: primary ciliary dyskinesia, John S. 2, MD, Wikimedia Commons licensed under public domain. Overlay. Maxillary sinusitis VV. X-ray of the paranasal sinuses, occipitomental view or Waters view, an air fluid level, white dashed line, is visible within the right maxillary sinus, red hatched overlay, air within the right maxilla, green overlay, fluid within the right maxilla. This is a typical radiological feature of sinusitis. Our great thanks to Dr. Kissig, Center for Diagnostic and Interventional Radiology, Hedwig, St. Hedwig, Berlin, and St. Joseph's Hospital, Potsdam, for kindly providing this image. Overlay. Maxillary sinusitis VV. X-ray of the paranasal sinuses, occipitomental view or Waters view, an air fluid level, white dashed line, is visible within the right maxillary sinus, red hatched overlay, air within the right maxilla, green overlay, fluid within the right maxilla. This is a typical radiological feature of sinusitis. Our great thanks to Dr. Kissig, Center for Diagnostic and Interventional Radiology, Hedwig, St. Hedwig, Berlin, and St. Joseph's Hospital, Potsdam, for kindly providing this image. Euro__sinusitis, 5/6. Overlay. Nasal septal deviation and sinus retention cyst VV. CT paranasal sinuses, without contrast, coronal plane, the nasal septum is deviated to the left, green overlay, and the nasal turbinates, T, are enlarged on the right. The medial wall of the right maxillary sinus is thickened, and a retention cyst, red overlay, arises from the floor. Our great thanks to PD Dr. M. Jergas, Center for Diagnostic and Interventional Radiology, St. Elizabeth Hospital, Cologne, for kindly providing this image. Eurosinusitis, 5/6. Copyright overlay. Nasal septal deviation and sinus retention cyst VVCT paranasal sinuses, without contrast, coronal plane, the nasal septum is deviated to the left, green overlay, and the nasal turbinates, T, are enlarged on the right. The medial wall of the right maxillary sinus is thickened, and a retention cyst, red overlay, arises from the floor. Our great thanks to PD Dr. M. Jergas, Center for Diagnostic and Interventional Radiology, St. Elizabeth Hospital, Cologne, for kindly providing this image. Overlay. Opacified right paranasal sinuses CT paranasal sinuses, coronal plane, of a patient with acute sinusitis. The right maxillary sinus, green overlay, is completely opacified. Extensive soft tissue density material, red overlay, is also present in the ipsilateral nasal cavity, and the right ethmoid sinus is nearly completely opacified. Source: Odontogenic sinusitis.jpg by Rian Little Temd, Wikimedia Commons, licensed under CC by 4.0. Modifications: removed circle. Copyright overlay. Opacified right paranasal sinuses CT paranasal sinuses, coronal plane, of a patient with acute sinusitis. The right maxillary sinus, green overlay, is completely opacified. Extensive soft tissue density material, red overlay, is also present in the ipsilateral nasal cavity, and the right ethmoid sinus is nearly completely opacified. Source: Odontogenic sinusitis.jpg by Rian Little Temd, Wikimedia Commons, licensed under CC by 4.0. Modifications: removed circle. Eurosinusitis, 3/6. Overlay. Maxillary sinusitis VV. X-ray of the paranasal sinuses. The left maxillary sinus appears less translucent than the right side. Clinical features determine whether this finding is interpreted as a maxillary sinusitis or a hematoma. Source: copyright IMPP. Eurosinusitis, 3/6. Copyright overlay. Maxillary sinusitis VV X-ray of the paranasal sinuses. The left maxillary sinus appears less translucent than the right side. Clinical features determine whether this finding is interpreted as a maxillary sinusitis or a hematoma. Source: Copyright IMPP. Overlay. Chronic rhinosinusitis CT paranasal sinuses, without contrast, coronal plane, the ethmoid sinuses are opacified, hatched green overlay, and there is lobulated thickening of the walls of the maxillary sinuses, green overlay. The findings indicate nasal polyps and retention cysts. Source: Copyright IMPP. Urosinusitis, 2/6. MDMG. Overlay. Chronic rhinosinusitis CT paranasal sinuses, without contrast, coronal plane, the ethmoid sinuses are opacified, hatched green overlay, and there is lobulated thickening of the walls of the maxillary sinuses, green overlay. The findings indicate nasal polyps and retention cysts. Source: Copyright IMPP. Overlay. Ethmoid sinusitis with orbital involvement VV. CT orbits, with contrast, axial plane, right ethmoid sinusitis, S, is accompanied by periorbital edema, cellulitis, yellow overlay, and proptoses, red line and arrow. A low-density abscess, red overlay, in the medial extracondyl orbital space displaces the medial rectus muscle, green overlay, laterally. Source: Copyright IMPP. Copyright Overlay. Ethmoid sinusitis with orbital involvement VVCT orbits, with contrast, axial plane, right ethmoid sinusitis, S, is accompanied by periorbital edema, cellulitis, yellow overlay, and proptoses, red line and arrow. A low-density abscess, red overlay, in the medial extracondyl orbital space displaces the medial rectus muscle, green overlay, laterally. Source: Copyright IMPP. Acute tonsillitis and pharyngitis. Acute tonsillitis is an inflammation of the tonsils that frequently occurs in combination with an inflammation of the pharynx, tonsillopharyngitis. The terms tonsillitis and pharyngitis are often used interchangeably, but they refer to distinct sites of inflammation. Acute tonsillitis and pharyngitis are particularly common in children and young adults and are primarily caused by viruses or group A streptococci, GAS. They are characterized by the sudden onset of fever, sore throat, and painful swallowing. Patients may also have tender, swollen cervical lymph nodes and tonsillar exudates. The disease is normally self-limited. However, if gas infection is confirmed via rapid antigen detection test and/or throat culture, treatment with antibiotics, most often penicillin, should be initiated to prevent rheumatic fever. Tonsillectomy is a treatment option for recurrent and chronic tonsillitis, especially in patients with tonsillar hypertrophy that causes obstructive sleep disordered breathing. Peritonsillar abscess and parapharyngeal abscess are serious suppurative complications of acute bacterial tonsillitis and require immediate treatment. O2. Epidemiology. Plus peak incidence. I copyright acute viral tonsillopharyngitis, children. OCE. Etiology. Cent acute tonsillopharyngitis copyright viral, 50 to 80% of cases adenovirus, EBV, CMV, HSV, rhinovirus, coronavirus, influenza, and parainfluenza viruses, HIV/CJ, ALS, copyright bacterial, 15 to 30% of cases. Most common, acute gas tonsillopharyngitis caused by Streptococcus pyogenes, also known as Group A Streptococcus, gas. 2 Others, Neisseria gonorrhoeae, Corynebacterium diphtheriae, Mycoplasma pneumonia, Fusobacterium necrophorum, Group C, and Group G Streptococcus. 2. 4 Necrotizing, or anaerobic, Tonsillopharyngitis, sometimes referred to as Vincent angina, a rare anaerobic and/or mixed organism infection that may overlap with necrotizing periodontal disease. SLIL 71L8 recurrent tonsillopharyngitis and chronic tonsillitis, polymicrobial infections with aerobic bacteria, typically streptococci, staphylococci, Haemophilus influenza, and anaerobic bacteria. Clinical features. Acute bacterial tonsillopharyngitis 21. Sudden onset of symptoms, fever, sore throat, dysphagia and significantly inflamed pharynx, opharyngeal and/or tonsillar erythema and edema. Copyright pharyngeal and/or tonsillar exudates, rare in children. Copyright children. Acute viral tonsillopharyngitis. 2231. Cough coryza. Back collapse. Find text outline. Acute viral tonsillopharyngitis equals 213. Scent cough, scent coryza, scent rhinorrhea, scent oral ulcers, anterior stomatitis, scent conjunctivitis, scent diarrhea, absence of fever. Red flags for tonsillopharyngitis. The presence of any of the red flag features listed below may indicate suppurative and/or invasive complications of acute tonsillitis and/or pharyngitis, such as deep neck infections, example peritonsillar abscess, retropharyngeal abscess, cervical lymphadenitis, mastoiditis, and rarely, sepsis. 2. Scent trismus, scent drooling plus asymmetric tonsils, displaced uvula, unilateral facial swelling, scent muffled or hot potato voice. Clinical features of sepsis, immunosuppression. Copyright trismus and change in voice quality indicate the formation of potentially life-threatening peritonsillar abscess. of Diagnostics. Recommendations in this section are consistent with the 2012 Infectious Disease Society of America, IDSA, and the 2009 American Heart Association, AHA/American Academy of Pediatrics, AAP, Guidelines on Gas Pharyngitis. Olily 112. Approach 8 pounds 2 IL-13. The diagnosis of acute tonsillitis or acute pharyngitis is primarily clinical. Scent clinical evaluation. Copyright assess for clinical features of acute bacterial tonsillopharyngitis, acute viral tonsillopharyngitis, and differential diagnoses of acute tonsillopharyngitis. Proceed to immediate treatment if red flags for tonsillopharyngitis or clinical features of airway compromise are present. Suspected acute bacterial tonsillopharyngitis, consider diagnostic testing to identify and treat gas infection and minimize its transmission and complications, example acute rheumatic fever. Copyright consider deferring diagnostic testing based on a clinical scoring system, example no testing if modified Centair score. Scent suspected acute viral tonsillopharyngitis, diagnostic testing is not routinely recommended. Degree suspected infectious mononucleosis, start with heterophile antibody test. FF13 degree suspected COVID-19, see COVID-19 testing for details. Copyright routine testing for gas is not recommended for children. Testing for gas infection is not recommended in patients with clinical features that strongly suggest acute viral tonsillopharyngitis. 2. Rapid strep test 2. Scent modality, rapid antigen detection test, RADT, specific for gas antigens. Indications, first-line test in suspected acute bacterial tonsillopharyngitis. Back collapse. Find text outline. Rapid strep test 2. Scent modality, rapid antigen detection test, RADT, specific for gas antigens. Indications, first-line test in suspected acute bacterial tonsillopharyngitis. Copyright all symptomatic children equals 3 years of age and adults, unless symptoms are suggestive of acute viral tonsillopharyngitis, copyright consider in symptomatic children. Throat culture. Scent indications. Copyright confirmatory test to definitively rule out gas infection in symptomatic children and adolescents with a negative RADT. Copyright recurrent or chronic tonsillitis, 2I15. Findings. Copyright causative bacteria and their antibiotic susceptibility, see etiology for details. Copyright time to result, 24 to 48 hours. Clinical scoring systems 22141. Plus rationale, estimate the likelihood of acute bacterial pharyngitis based on clinical features alone. One example, the modified Scent score. Scent clinical applications. Copyright identifying patients with a low likelihood of gas infection, thereby minimizing unnecessary diagnostic tests and antibiotic therapy. Copyright the use of scoring systems to identify patients with a high likelihood of bacterial pharyngitis in order to treat empirically without testing is controversial. Modified Scent score 9, 7 to 18 I191, criteria points 3 to 14 years plus 1 age 15 to 44 years 0 44 years 1 yes plus 1 exudate or swelling on tonsils number 0 yes plus 1 tender or swollen anterior cervical lymph nodes number 0 yes plus 1 temperature 100.4 degrees Fahrenheit 38 degrees Celsius number 0 absent plus 1 cough present 0. Interpretation. Score. Q. Think of M center to remember the modified Scent score criteria. M equals must be older than 3 years, C equals cough absent, E equals exudate on the tonsils, N equals node enlargement, T equals temperature elevation, or equals young or old. At empiric antibiotic therapy for patients with a modified Scent score equals 4 is not routinely recommended. 2. Additional laboratory tests. Not routinely indicated, can be obtained as supportive diagnostic evidence. Degree CBC4 plus inflammatory markers, CRP, ESR anti-streptolysin O, ASO, titer. Copyright elevated levels suggest a previous gas infection, not helpful to diagnose acute pharyngitis. Copyright indicated in the workup of non-suppurative complications of gas tonsillopharyngitis, example acute rheumatic fever, PSGN. 1, 2. Imaging, degree 1. Scent not routinely indicated. Scent consider CT of head and neck if there is clinical suspicion of suppurative complications. Back collapse. Find text outline. Differential diagnoses. Differential diagnoses of acute tonsillopharyngitis disease. Etiology. Clinical features. Ulcers on anterior oral mucosa. Usually no systemic symptoms. Aphthous stomatitis A unknown. Herpes-like oral lesions, multiple 1 mm vesicles located on the posterior oropharynx and tonsils. Pharyngeal and tonsillar redness. Fibrin-covered ulcerations appear in later stages. Sore throat and high fever may occur as a component of hand, foot, and mouth disease. Herpangina. A Coxsackie virus EA. Herpetic pharyngotonsillitis/herpetic gingivostomatitis. A multiple small oral lesions located in the anterior oropharynx and lips. Fever, sore throat, pharyngeal redness. Unilateral ulcers on the pharyngeal tonsils. Features of dental disorders and/or periodontal disease, e.g. gingivitis. Constitutional symptoms. Dysphagia. Halitosis. Vincent angina. Acute necrotizing ulcerative synergistic mixed infection that can include anaerobes and gingivitis, ANUG, SIL 6 Li 7281_Spirochetes 1. Mixed infection, viridans streptococci and anaerobes, 20 usually arising from an infected mandibular molar, an infection Ludwig angina of the upper airways, or acute lingual tonsillitis. Predisposing factors, diabetes mellitus, alcohol use disorder. Submandibular space infection 1. Fever, mouth pain, stiff neck, difficulty swallowing, trismus 120 * airway obstruction may occur. And other immunocompromising conditions, 21. Oral thrush, fungal tonsillitis, Candida albicans 1. Pseudomembranous stomatitis with white plagues. Primary syphilis chancre in the posterior pharynx. BZ pharyngeal syphilis treponema pallidum. Early stages are often asymptomatic, sore throat may occur. 22. Fever, pharyngitis, and enlarged erythematous tonsils with white and gray deposits, a generalized lymphadenitis. Possible involvement of liver, spleen, and skin. Tonsillitis in infectious mononucleosis Epstein-Barr virus, EBV. Pseudomembranes, inflammation often exceeds the tonsils, mucosal bleeding. Tonsillitis in diphtheria, diphtheritic croup, Ocorynebacterium diphtheriae. Triad of aphthous stomatitis, sore throat, and fever. Dirty necrosis of pharyngeal tonsils. A granulocytic angina appears in the context of a granulocytosis. The differential diagnoses listed here are not exhaustive. Your notes. 9st. Treatment. Recommendations in this section are consistent with the 2012 IDSA and the 2009 AHA/AAP guidelines on gas pharyngitis. 2. OLL2 ITT 1121. Approach 9 pounds 2 IL13. Sent all patients. Provide supportive care, example analgesia, antipyretics. Copyright if red flags for tonsillopharyngitis are present. Consult and urgently. Identify and treat deep neck infections. Gas pharyngitis and/or tonsillitis, typically self-limited, prescribe antibiotics to prevent complications, example peritonsillar abscess, rheumatic fever, and decreased transmission, 21-23. Copyright positive rapid strep test or throat culture, initiate antibiotic therapy for acute gas pharyngitis. Negative rapid strep test, wait for throat culture results, treat if culture positive. 218 Copyright empiric treatment, example for patients with modified Centaur score equals 4, is controversial and not routinely recommended. 1 Lalt 112. Copyright advise isolation and droplet precautions until patients are afebrile and have received equals 12 hours of antibiotic therapy. 24. Back collapse. Find text outline. Empiric treatment, example for patients with modified Centaur score 2-4, is controversial and not routinely recommended. 4I*HTIH. Copyright amoxicillin therapy in patients with infectious mononucleosis can trigger a maculopapular and/or morbilliform rash. Reserve antibiotics for patients with confirmed bacterial tonsillopharyngitis, example positive rapid strep test or throat culture, whenever possible. 25. Supportive care 2. Ensure adequate hydration. Consider household remedies such as salt water gargles. Consider oral topical local anesthetics, example benzocaine lozenges, phenol throat sprays, compounded mouthwash. Copyright, 226 Analgesics and antipyretics 2. Avoid aspirin in children due to the risk of Reye syndrome. Antibiotic therapy 21. Indication, patients with laboratory confirmation of gas infection, 210. Recommended antibiotic regimens for acute gas pharyngitis, 2 drug duration penicillin V, treatment of choice 10 days no penicillin allergy amoxicillin 10 days benzathine penicillin G single dose cephalexin 10 days penicillin allergy 7 cefadroxil 10 days clindamycin 10 days history of 2 penicillin, clindamycin or macrolide azithromycin 5 days clarithromycin 10 days. Copyright mistakenly treating an EBV infection, infectious mononucleosis, with amoxicillin can lead to a maculopapular rash. OR note. AEY note man. Tonsillectomy. Indications, I31L2. Plus extreme hypertrophy of the tonsils, kissing tonsils, causing obstructive sleep disordered breathing. Number 21 plus documented recurrent throat infection sent suspected tonsillar neoplasm sent chronic tonsillitis sent consider in patients with any of the following: copyright history of peritonsillar abscess, copyright allergy or intolerance to multiple antibiotics, OPFA syndrome procedure, I-34 I-135. Sent total tonsillectomy, copyright tonsils are removed with their surrounding capsule. Copyright dissection is lateral to the tonsil in the plane between the tonsillar capsule and pharyngeal muscles. 1 cent subtotal tonsillectomy, copyright subtotal removal of tonsillar tissue, leaving a margin of tissue on the tonsillar capsule. Copyright dissection is from medial to lateral in a stepwise approach to preserve the capsule fa. Complications. 1. Back collapse, fine text outline. X. Acute tonsillitis and pharyngitis. Procedure, 34-1-135. V. Sent total tonsillectomy, copyright tonsils are removed with their surrounding capsule. Copyright dissection is lateral to the tonsil in the plane between the tonsillar capsule and pharyngeal muscles. 1 cent subtotal tonsillectomy, copyright subtotal removal of tonsillar tissue, leaving a margin of tissue on the tonsillar capsule. Copyright dissection is from medial to lateral in a stepwise approach to preserve the capsule. 1. Complications. Sent intraoperative, injury to adjacent structures, example the carotid artery. A. Sent postoperative, copyright pain, referred otalgia, nasopharyngeal stenosis. O. Dehydration from decreased oral intake, copyright respiratory compromise. 5-4. Bleeding, C. Post-tonsillectomy hemorrhage. Do not use acetyl salicylic acid for postoperative pain relief after tonsillectomy because of the increased risk of bleeding. Recommended analgesics after copyright tonsillectomy are ibuprofen and acetaminophen. 137. Post-tonsillectomy hemorrhage. 38 I-39. Background: the risk of bleeding increases with age, reaching up to 20% in adults. 401L41. Copyright primary bleeding occurs 24 hours after surgery. Sent clinical features: copyright bleeding can range from clot formation and oozing to active profuse hemorrhage. Copyright clinical features of airway compromise may be present. Secondary post-tonsillectomy hemorrhage typically presents 1 week after surgery, around the time the eschar, fibrin clot, detaches. 43. Complications. Suppurative complications. Sent peritonsillar abscess, parapharyngeal abscess, sent otitis media, sent sinusitis, sent cervical lymphadenitis, sent mastoiditis, sent infectious thrombophlebitis of the internal jugular vein, Lemierre syndrome. Copyright definition: a severe, potentially fatal condition usually resulting from oropharyngeal infections characterized by infection of the carotid sheath vessels and bacteremia. Copyright etiology: most commonly caused by oropharyngeal flora, example Fusobacterium necrophorum. Copyright clinical features: fever, respiratory distress, neck pain, throat pain. Non-suppurative complications. Rheumatic fever, sent scarlet fever, post-streptococcal glomerulonephritis, PSGN. Antibiotic therapy for gas-pharyngitis can decrease the risk of rheumatic fever but does not affect the risk of PSGN. 2. And Streptococcus pyogenes is the most common cause of bacterial pharyngitis, which can result in rheumatic fever and post-streptococcal glomerulonephritis. Back collapse, fine text outline. Acute tonsillitis and pharyngitis, 5/9. Acute tonsillopharyngitis VV. There is tonsillar erythema and edema bilaterally and a petechial enanthem of the soft palate. Source: ID #3183, CDC/Heinz F. Eichenwald, MD, Centers for Disease Control and Prevention, licensed under public domain. Acute tonsillitis and pharyngitis, 6/9. Strawberry tongue VV. Bright red tongue with papillary hyperplasia. Strawberry tongue may be seen in various conditions, example scarlet fever, Kawasaki disease, and toxic shock syndrome. Source: Scarlatina tongue by Synt Grisha, Wikimedia Commons, licensed under CC by SA 4.0. Acute tonsillitis and pharyngitis, 7/9. Scarlet fever. Upper body of a child showing an elevated, maculopapular, fine exanthem, which is spread evenly over the patient's torso. Combined with characteristic findings such as tonsillopharyngitis, flushed cheeks with perioral pallor, and a strawberry tongue, this finding indicates scarlet fever. The disease is caused by exotoxins produced by group A B hemolytic streptococci. Source: courtesy of Dr. Gary M. White MD. Acute tonsillitis and pharyngitis, 8/9. Skin manifestations in scarlet fever VV. The typical scarlet-colored, fine, maculopapular exanthem of scarlet fever is seen on the right arm. Flushed cheeks and perioral pallor are also evident. Source: Scarlet fever by Beto Badop, Wikimedia Commons, licensed under CC by SA 3.0. Modifications: pixelated eyes. Peritonsillar abscess. Redness and swelling can be seen on the right side of the anterior palatal arch and of the soft palate. There is a slight left-sided deviation of the soft palate. The uvula shows a distinct redness and is slightly swollen. These findings are suggestive of a peritonsillar abscess on the right side. Source: Peritonsillar abscess by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Acute tonsillitis and pharyngitis, 4/9. Acute tonsillitis VV. The tonsils are bilaterally enlarged and gray-white exudates are visible at the openings of the tonsillar crypts as well as on the posterior aspect of the tongue. The soft palate, anterior tonsillar pillars, and the uvula are erythematous and edematous. Tonsillar inflammation and exudates are characteristic features of acute bacterial tonsillitis, which is most commonly caused by Streptococcus pyogenes, group A beta hemolytic streptococcus. Source: copyright IMPP. Acute tonsillitis. Oral cavity of a child presenting with fever, dysphagia, and tender anterior cervical lymphadenopathy. The pharyngeal tonsils are enlarged, erythematous, edematous, and have streaks of mucopurulent discharge bilaterally. This is the typical appearance of bilateral acute tonsillitis. Source: POS Strep by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Acute tonsillitis and pharyngitis, 2/9. Acute tonsillitis VV. Oropharynx of a child presenting with fever and sore throat. The tonsils are bilaterally enlarged and yellow-white exudates are visible at the openings of the tonsillar crypts. The soft palate, anterior tonsillar pillars, and the uvula are erythematous and edematous. Tonsillar inflammation and exudates are characteristic features of acute bacterial tonsillitis, which is most commonly caused by Streptococcus pyogenes, group A beta hemolytic streptococcus. Source: copyright IMPP. Acute tonsillitis and pharyngitis, 1/9. Acute pharyngitis VV. Multiple dilated blood vessels are visible on the posterior pharyngeal wall, anterior tonsillar pillars, and the uvula. Lymphoid hyperplasia is visible, identifiable as multiple small nodules on the pharyngeal mucosa. The tonsils are not enlarged. These are the typical features of acute pharyngitis, which is most commonly caused by a viral infection. Source: Pharyngitis by Dake Commons Wiki, Wikimedia Commons, licensed under CC by SA 2.5. Acute tonsillitis and pharyn. Sore throat. VFO trademark presence of red flags. Jawlock, drooling, unilateral neck swelling. Cuttest, 1/1. Urgent CT head and neck to rule out peritonsillar abscess. Urgent and consult plus yes. XK4. Fever, dry cough, anosmia, known. Features of COVID-19. Exposure to COVID-19. Features, bacterial tonsillopharyngitis. If CT is abnormal. Yes, nasopharyngeal swab. Fever, pharyngeal and/or negative. Positive tonsillar exudates, scarlatiniform rash, cervical lymphadenitis, lay rapid strep antigen absence or cough Saha test. Negative positive. A viral. Endian equals on a conjunctivitis, diarrhea, or iecitis absence of fever. Yes. No. Features equals infectious mononucleosis age, adolescents or young adults, splenomegaly, Me consider a monospot test negative. Positive and AV infectious mononucleosis 4 poser 5 COVID-19 supportive treatment, advise pays me EI supportive to avoid physical activity PPPPCS treatment according only treat with antibiotics, risk of splenic rupture, to local policies. Diagnosis of tonsillopharyngitis. Copyright emboss. Acute tonsillitis and pharyngitis, 8/11. Acute pharyngitis VV. Multiple dilated blood vessels are visible on the posterior pharyngeal wall, anterior tonsillar pillars, and the uvula. Lymphoid hyperplasia is visible, identifiable as multiple small nodules on the pharyngeal mucosa. The tonsils are not enlarged. These are the typical features of acute pharyngitis, which is most commonly caused by a viral infection. Source: Pharyngitis by Dake Commons Wiki, Wikimedia Commons, licensed under CC by SA 2.5. Acute tonsillitis and pharyngitis, 9/11. Acute tonsillopharyngitis VV. There is tonsillar erythema and edema bilaterally and a petechial enanthem of the soft palate. Source: ID hashtag 3183, CDC/Heinz F. Eichenwald, MD, Centers for Disease Control and Prevention licensed under public domain. Acute tonsillitis and pharyngitis, 10/11. Acute tonsillitis VV. Oropharynx of a child presenting with fever and sore throat. The tonsils are bilaterally enlarged and yellow-white exudates are visible at the openings of the tonsillar crypts. The soft palate, anterior tonsillar pillars, and the uvula are erythematous and edematous. Tonsillar inflammation and exudates are characteristic features of acute bacterial tonsillitis, which is most commonly caused by Streptococcus pyogenes, group A beta hemolytic Streptococcus. Source: Copyright IMPP. Acute tonsillitis and pharyngitis, 11/11. Acute tonsillitis VV. The tonsils are bilaterally enlarged and gray-white exudates are visible at the openings of the tonsillar crypts as well as on the posterior aspect of the tongue. The soft palate, anterior tonsillar pillars, and the uvula are erythematous and edematous. Tonsillar inflammation and exudates are characteristic features of acute bacterial tonsillitis, which is most commonly caused by Streptococcus pyogenes, group A beta hemolytic Streptococcus. Source: Copyright IMPP. Uroacute tonsillitis and pharyngitis, 7/11. Tonsillar and pharyngeal diphtheria VV. A gray-white pseudomembrane extends from the left palatine tonsil over the uvula to the hard palate. The pseudomembrane consists of fibrinous exudate as well as immune and epithelial cells and is characteristic of tonsillar and pharyngeal diphtheria. Source: Dirty white pseudomembrane classically seen in diphtheria by Diliapunacri, Wikimedia Commons, licensed under CC by SA 3.0. Acute tonsillitis and pharyngitis, 6/11. Infectious mononucleosis V. The tonsils are significantly enlarged. A thick, Yellow-white membrane is visible over the tonsils and uvula. The palatal mucosa appears inflamed, especially in the midline. This is the typical appearance of tonsillitis in infectious mononucleosis, which is caused by the Epstein-Barr virus. Source: Copyright IMPP. Acute tonsillitis and pharyngitis, 5/11. Oral candidiasis VV. Yellow-white cottage cheese-like plagues are visible on the inflamed oropharyngeal mucosa. These white plagues are pathognomonic of oral candidiasis, oral thrush, an opportunistic infection caused by Candida albicans. Source: ID #1217, CDC, Centers for Disease Control and Prevention, licensed under public domain. Acute tonsillitis and pharyngitis, 4/11. Herpetic pharyngotonsillitis VV. The posterior oropharynx is acutely inflamed, as evidenced by the erythema and edema. Several shallow ulcers with yellow-white exudates are visible over the soft palate, uvula, and tonsillar surface. These features are consistent with herpetic pharyngotonsillitis, which, in adults, is caused by oropharyngeal infection by the HSV-1 virus. In children, HSV-1 viral infection causes herpetic gingivostomatitis, wherein the inflammation predominantly affects the anterior oropharynx, i.e., gums, lips, tongue. Source: Stomatitis herpetica by Klaus D. Peter, Wikimedia Commons, licensed under CC by 3.0. Acute tonsillitis and pharyngitis, 3/11. Herpangina VV. Oral cavity of a female with fever and odynophagia, multiple white vesicles 1 to 2 mm in diameter, and an erythematous rim can be seen on the uvula, soft palate, and tonsillar pillars. These herpes-like vesicles on the posterior oropharynx are characteristic of herpangina, a Coxsackie virus infection mostly seen in young children. Source: Herpangina 2016 by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 4.0. Acute tonsillitis and pharyngitis, 2/11. Herpangina. Several small vesicles and partially confluent yellow-white ulcers with an erythematous rim are visible on the inflamed soft palate. This is the typical appearance of herpangina, an infection caused by the Coxsackie A virus. The ananthem typically starts as painful, herpes-like vesicles on the oropharynx that then break down to form shallow, painful ulcers. Source: Copyright IMPP. Aphthous stomatitis VV. Two shallow spherical ulcers are visible on the buccal mucosa of the lower lip. The borders of the ulcer are erythematous and well defined. Healthy granulation tissue is visible on the floor of the ulcers. These aphthous ulcers are typically painful and resolve spontaneously without scarring. Aphthous stomatitis is a condition characterized by recurrent episodes of aphthous ulcer formation. Source: ID #12620, CDC/Robert E. Sumter, Centers for Disease Control and Prevention, CDC, licensed under public domain. Acute tonsillitis and pharyngitis, 1/1. Sore throat. Presence of red flags. Jawlock, drooling, unilateral neck swelling. Urgent CT head and neck to rule out peritonsillar abscess. Urgent and consult if CT is abnormal. Features of COVID-19: fever, dry cough, anosmia, known exposure to COVID-19. No V. Features of bacterial, tonsillopharyngitis. VES nasopharyngeal swab. Scent negative. Positive fever, pharyngeal and/or tonsillar exudates, scarlatiniform rash, cervical lymphadenitis, yes. Rapid strep antigen S. Absence of cough. Y. Detection test no negative positive. Features of viral Y tonsillopharyngitis. Gidron equals A and cough, coryza, oral ulcers. STDP adolescence conjunctivitis, diarrhea, absence of fever. Yes no no yes. Features of infectious throat mononucleosis: culture, age, adolescents or young adults, splenomegaly, negative L_positive hepatomegaly. Yes, yen consider a monospot test J have I positive. VVVY_AEAVV renerios slali viatintection, Grupa, /SOMDT8PP, supportive treatment Streptococcus pp to avoid physical activity, risk of splenic rupture, only treat with antibiotics treatment according to local policies. Diagnosis of tonsillopharyngitis. Acute tonsillitis and pharyngitis, 1/3. Tonsillectomy VV. Intraoperative photograph of a tonsillectomy under general anesthesia. The airway is protected by an endotracheal tube. An alternative technique is to use the laryngeal mask airway. The Boyle-Davis mouth gag helps keep the oral cavity patent without obstructing the operating field. The tonsil is gripped using tonsil holding forceps and dissected out from the tonsillar bed. Source: Tonsillectomy 1 by Wells-Chick, Wikimedia Commons, licensed under CC by SA 3.0. Overlay. Tonsillectomy. Mouth of a patient 3 days after tonsillectomy. The empty tonsillar bed/fosse, gray color, green overlay, are partially covered with eschar/slough, white color, purple overlay. This is a characteristic appearance of normal healing post-tonsillectomy. Source: Tonsillectomy 09 by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Copyright overlay. Tonsillectomy. Mouth of a patient 3 days after tonsillectomy. The empty tonsillar bed/fosse, gray color, green overlay, are partially covered with eschar/slough, white color, purple overlay. This is a characteristic appearance of normal healing post-tonsillectomy. Source: Tonsillectomy 09 by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Tonsil specimen. Tonsil specimens following bilateral tonsillectomy. Both palatine tonsils are enlarged and cryptic, indicating a history of recurring tonsillitis. Source: Pair of removed tonsils by Dury James, Wikimedia Commons, licensed under CC by SA 3.0. XX deep neck infections. Deep neck infections include peritonsillar abscess, parapharyngeal abscess, PPA, and retropharyngeal abscess, RPA. While uncommon, deep neck infections are clinically significant because of their potentially life-threatening complications, including the spread of infection to vital nearby structures and airway compromise. Consultation with airway specialists is recommended if there are clinical features of airway compromise. Early recognition, aggressive airway management, broad spectrum for antibiotic therapy, and urgent end consultation for abscess drainage and/or other surgical interventions reduce the risk of complications and death from sepsis or airway compromise. OC. OIEEE. Overview. Peritonsillar abscess: an accumulation of pus between the definition muscles of the pharynx and the palatine tonsillar capsule. 3. Most common in adolescents and young. Epidemiology: adults *. Most common deep neck infection. Etiology: scent. Acute tonsillitis. Features of tonsillitis: scent, hot potato voice, acentrismus, clinical uvula shifted to the contralateral side. Features: scent, inflamed ipsilateral tonsil, fluctuant, swollen, erythematous with exudates, ipsilateral bulging of the palatine arch. Diagnosis *. Clinical diagnosis. Airway management treatment: scent for antibiotics, scent surgical drainage. OIEEE. Peritonsillar abscess. Epidemiology 1. Scent most frequently occurs in adults aged 20 to 40 years. Scent the most common deep neck infection. Overview of deep neck infections. 2. Parapharyngeal abscess. A collection of pus lateral to the peritonsillar space and divided anteriorly and posteriorly into pre- and post-styloid compartments. 2. Most common in children. Dental infections, most common, acute tonsillitis, peritonsillar abscess, pharyngeal or salivary gland infections. Features of tonsillitis: sometimes trismus, medial displacement of the lateral pharyngeal wall and tonsil, posterior space abscess, or indurated swelling below the angle of the mandible down to the hyoid bone, anterior space abscess. CT. Scent: increased risk of airway obstruction in children with peritonsillar abscess. Etiology: 7IL8. Retropharyngeal abscess. A collection of pus anterior to the deep cervical fascia and posterior to the pharynx. 2. Most common in children. Contiguous or lymphatic spread from upper respiratory tract infections, most common, or other nearby infections. Local penetrating pharyngeal trauma. Features of tonsillitis: sometimes trismus, unilateral swelling of the posterior pharyngeal wall, possible fluctuance, neck asymmetry, with neck swelling and anterior cervical lymphadenopathy, inability to extend neck. Lateral X-ray, widened prevertebral, soft tissue, space CT. Pathogens: Streptococcus pyogenes, most common, Streptococcus aeruginosus, viridans streptococci, Staphylococcus aureus, and Haemophilus species, often in a polymicrobial environment, plus acute bacterial tonsillitis. See acute tonsillitis. 1. Clinical features: 8IL, L. Trismus. Ipsilateral ear pain. Uvula shifted to the contralateral side, with inferior and medial displacement of tonsil, unilateral fluctuant, swollen, erythematous tonsil with exudates, ipsilateral bulging of the palatine arch. Ipsilateral cervical lymphadenopathy, and neck swelling. Features of tonsillitis: fever, malaise, severe sore throat, dysphagia and odynophagia, hot potato voice, muffled speech, drooling, or halitosis. Collapse. A. Find text. O. Outline. Diagnostics. 8. Peritonsillar abscess is typically a clinical diagnosis. Obtain imaging if there is diagnostic uncertainty and/or concern for complications. Microbiological studies. Scent: bacterial culture of abscess ASPI rate can help to direct therapy for the causative pathogen. Scent: obtain a rapid group A Streptococcus antigen detection test. 12. Scent: consider a monospot test to rule out infectious mononucleosis. Add: evidence of pus on needle aspiration confirms the diagnosis. Imaging. 31. Plus ultrasound neck. 13. Plus CT or MRI neck with 4 contrast. 4. Treatment. 3IL11. Scent: patients with respiratory distress, prompt airway management, antibiotic therapy. 1. Scent: start empiric antibiotic therapy for deep neck infections. Copyright: target coverage for aerobes, example Streptococcus species, and anaerobes. Copyright e.g., clindamycin or ampicillin/sulbactam, abscess drainage. 3. Asterisk indications. 14. Copyright: obvious abscess e suspected abscess with signs of sepsis or signs of airway compromise e method. Copyright: preferred, needle aspiration or incision and drainage. Copyright: tonsillectomy, may be indicated in certain groups of children and/or for recurrent or treatment-resistant abscesses. 16. 3 complications, 171,181. Scent can become life-threatening due to airway compromise. Scent: further spread of infection into the parapharyngeal space, PPA, retropharyngeal space, RPA, mediastinum, mediastinitis, or fascia, necrotizing fasciitis. Scent: aspiration pneumonia. Scent: internal jugular vein thrombosis or thrombophlebitis. Scent: bacteremia and sepsis. WACE. Parapharyngeal abscess. Epidemiology 2 degrees. Most common in children. Etiology 71. Pathogens: Streptococci, viridans streptococci, S. pneumoniae, staphylococci, including MRSA, Haemophilus influenza, oral anaerobes, peptostreptococci, Bacteroides species, often in a polymicrobial environment. Oropharyngeal infections. Copyright dental infections, most commonly, copyright acute tonsillitis. Copyright peritonsillar abscess through the superior constrictor muscle into the parapharyngeal space. Opharyngeal or salivary gland infections. Clinical features 21. Features of peritonsillar abscess, especially trismus. Clinical features 21. Features of peritonsillar abscess, especially trismus plus posterior space abscess: medial displacement of the lateral pharyngeal wall and tonsil. Anterior space abscess, indurated swelling below the angle of the mandible down to the hyoid bone plus respiratory distress, dyspnea, stridor, limited cervical neck extension. Diagnostics 21. I-15. Imaging, required for diagnostic confirmation. 22. Copyright CT neck with 4 contrast, preferred, may show, 9-21. I-23 equals hypodense collection with rim enhancement in the lateral pharyngeal space. Single or multiloculated lesion with central fluid and / or air. MRI neck 2. Indication, concern for complications. Findings, similar to CT but with better visualization of soft tissue, example for cellulitis. 15. Microbiological studies, example bacterial culture of abscess. ASPI rate can help to direct therapy for the causative pathogen. Treatment 231,241. Systemic 4 antibiotics with abscess drainage and supportive care are the mainstays of therapy. Patients with respiratory distress, prompt airway management. Start empiric LV broad-spectrum antibiotics. Most patients require surgical drainage or image-guided drainage. Conservative treatment with 4 antibiotics alone may be considered in select patients, example clinically stable patients with a small abscess. Complications, 71. Airway obstruction. Spread of infection to retropharyngeal space, carotid sheath, presents with torticollis, and then mediastinum, internal carotid artery erosion. Jugular vein thrombophlebitis and mediastinitis or cranial nerves, Horner syndrome, hoarseness, unilateral paresis of the tongue, and other neurologic deficits. Ca. Aspiration. Pneumonia with spontaneous pus drainage. Bacteremia and sepsis. Parapharyngeal infections can become life-threatening because of their proximity to the retropharyngeal space, carotid sheath, and airway. Ooisis. Retropharyngeal abscess. Epidemiology 2 degree 1L25. Generally the most dangerous deep neck infection most common in children. Overall incidence in the U.S. has increased. Etiology 261. Pathogen, Streptococci, viridans streptococci, S. pneumoniae, staphylococci, including MRSA, Haemophilus influenza, oral anaerobes, peptostreptococci, Bacteroides species, often in a polymicrobial environment, direct or indirect causes. Copyright contiguous or lymphatic spread from oral, most common, or upper respiratory tract infections. Copyright local penetrating pharyngeal trauma, example from small bones such as a fish or chicken, or medical instruments, spread from other deep neck infections, nasopharynx, sinuses, adenoids. Clinical features 271. Features of tonsillitis and trismus, minimal, plus neck asymmetry with unilateral swelling of the posterior pharyngeal wall, possible fluctuance, equals inability to extend neck. Torticollis. Anterior cervical lymphadenopathy. Respiratory distress. Back collapse. Fine text outline. Infants may also present with lethargy, cough, poor intake, rhinorrhea, and agitation. Diagnostics 28. Imaging is required for diagnostic confirmation. Microbiological studies can help identify the causative pathogen. *CT neck with 4 contrast, preferred study, 221 copyright indication, suspicion of RPA with a negative X-ray copyright findings 29 equals hypodense fluid collection with ring enhancement in the retropharyngeal space equals posterior pharynx wall with anterior displacement may detect spread of infection to other spaces and the presence of foreign bodies equals differentiates between cellulitis and abscess plus lateral X-ray neck 980129 copyright indication, initial screening study in patients with airway compromise or if there is a low level of suspicion for RPA copyright findings widened prevertebral, soft tissue, space with gas or air fluid levels, equals lordosis equals evidence of foreign body, if present sent MRI neck 215 copyright indication, contraindication to CT copyright findings are similar to CT with improved detection of, equals soft tissue changes, example necrosis. Equals complications, example extension of abscess to prevertebral space. Sent microbiological studies, example bacterial culture of abscess ASPI rate can help to direct therapy for the causative pathogen. Treatment 28-151-19. Systemic 4 antibiotics with abscess drainage and supportive care are the mainstays of therapy. Patients with respiratory distress, prompt airway management start broad-spectrum empiric antibiotics, example clindamycin or ampicillin/sulbactam. Adult patients usually require needle aspiration or surgical drainage. Airway management is always the first step if the patient has signs of respiratory distress. Complications 32. Airway obstruction spread of infection to carotid sheath including internal carotid artery erosion and jugular vein thrombophlebitis, Lemierre syndrome, descending mediastinitis, acute necrotizing mediastinitis. May be visible on chest X-ray as a widened mediastinum plus/bilateral pleural effusion. Ca infection can spread and enter the skull base, epidural abscess, or the posterior mediastinum, pericarditis. Aspiration pneumonia atlantoaxial dislocation bacteremia and sepsis. OES. Differential diagnoses. Sent throat pain copyright tonsillitis copyright pharyngitis copyright epiglottitis plus painful neck mass 33, copyright cervical adenitis copyright cat scratch disease acute purulent sialadenitis sent neck swelling or respiratory distress anaphylaxis or angioedema copyright retropharyngeal tumors sent neck stiffness copyright meningitis copyright cervical spine osteomyelitis copyright dystonia. Back collapse fine text outline. Peritonsillar abscess. Redness and swelling can be seen on the right side of the anterior palatal arch and of the soft palate. There is a slight left-sided deviation of the soft palate. The uvula shows a distinct redness and is slightly swollen. These findings are suggestive of a peritonsillar abscess on the right side. Source: Peritonsillar abscess by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Deep neck infections, 3/3. EKIE, E. Peritonsillar abscess on the left side. Axial CT scan of the neck. 1. Molar, hyperdense. 2. Posterior area of the oral cavity, transition to the laryngopharynx. 3. Peritonsillar abscess, hypodense lesion in the nasopharynx. 4. Internal carotid artery filled with contrast medium. 5. Articular process of a cervical vertebrae. Source: Copyright IMPP. A. WO. NN. OM. Overlay. Deep neck infections, 3/3. AMS Reway. SAT. Peritonsillar abscess on the left side. Axial CT scan of the neck. 1. Molar, hyperdense. 2. posterior area of the oral cavity, transition to the laryngopharynx. 3. Peritonsillar abscess, hypodense lesion in the nasopharynx. 4. Internal carotid artery filled with contrast medium. 5. Articular process of a cervical vertebrae. Source: copyright IMPP. Whoa. No. OM. Copyright. Overlay. Retropharyngeal space, prevertebral space. Retropharyngeal abscess, peritonsillar abscess. Danger space, anatomy, palatine tonsil. Epiglottis. Pharynx. Uvula, oral examination, palatine tonsil, posterior pharyngeal swelling. Uvular deviation. Retropharyngeal abscess and peritonsillar abscess. Copyright emboss. Uro deep neck infections, 1/1. Overlay. Parapharyngeal inflammation with abscess. CT neck, with contrast, axial plane, a patient with history of fever and progressive dysphagia for 2 days. The parapharyngeal soft tissues, green overlay, show contrast enhancement and mass effect narrowing the airway. On the right, a hypodense fluid collection, red overlay, with rim enhancement, white overlay, represents an abscess. Blue overlay, carotid artery, green hatched overlay, sternocleidomastoid muscle, M, mandible, red hatched overlay, jugular vein, yellow overlay, lymph node source, copyright IMPP. Uro deep neck infections, 1/1. Copyright. Overlay. Parapharyngeal inflammation with abscess. CT neck, with contrast, axial plane, a patient with history of fever and progressive dysphagia for 2 days. The parapharyngeal soft tissues, green overlay, show contrast enhancement and mass effect narrowing the airway. On the right, a hypodense fluid collection, red overlay, with rim enhancement, white overlay, represents an abscess. Blue overlay, carotid artery, green hatched overlay, sternocleidomastoid muscle, M, mandible, red hatched overlay, jugular vein, yellow overlay, lymph node source, copyright IMPP. Copyright overlay. Deep neck infection, X-ray neck, lateral view, of a patient with a retropharyngeal abscess. Retropharyngeal soft tissue swelling has produced widening, indicated by left-right arrows, of the prevertebral soft tissues. Source: Retro-Obsessed 10 by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Modifications: original arrow removed. Retropharyngeal space, prevertebral space. Retropharyngeal abscess, peritonsillar abscess. Danger space, anatomy, palatine tonsil. Epiglottis. Pharynx. Uvula, oral examination, palatine tonsil, posterior pharyngeal swelling. Uvular deviation. Retropharyngeal abscess and peritonsillar abscess. Copyright emboss. X. Infectious mononucleosis. Infectious mononucleosis, IM, also called mono or the kissing disease, is an acute condition caused by the Epstein-Barr virus, EBV. The disease is highly contagious and spreads via bodily secretions, especially saliva. Infection frequently goes unnoticed in children, mainly adolescents and young adults exhibit symptoms. Symptomatic individuals typically first experience fever, malaise, and fatigue, which is later accompanied by acute pharyngitis, tonsillitis, lymphadenopathy, and/or splenomegaly lasting up to a month. IM is also sometimes associated with a measles-like exanthem, especially in individuals who are falsely diagnosed with bacterial tonsillitis and given ampicillin or amoxicillin. To avoid misdiagnosis, suspected cases are confirmed with a heterophile antibody test, monospot test, or in some cases, positive serology. Patients exhibit lymphocytosis, often with atypical T lymphocytes on a peripheral smear. IM is treated symptomatically, as it is usually self-limiting. Although complications are rare, IM is associated with a traumatic splenic rupture due to splenomegaly and multiple malignancies, example Hodgkin's lymphoma, Burkitt lymphoma. OMT. S and epidemiology. Scent general, approximate 90 to 95% of adults are EBV seropositive worldwide. IU scent peak incidence of symptomatic disease 15 to 24 years of age 2 plus incidence 5/1000 per year. 3. Epidemiological data refers to the US, unless otherwise specified. WA and etiology. Pathogen, Epstein-Barr virus, EBV, also called human herpes virus 4, HHV4, *, transmission, infectious mononucleosis spreads via bodily secretions, especially saliva. Therefore, it is also called kissing disease. References /4. WACE. Pathophysiology. EBV infects B lymphocytes in mucosal epithelium, example oropharynx, cervix, via the CD21 receptor. Infected B lymphocytes induce a humoral, B cell, as well as a cellular, T cell, immune response, an increased concentration of atypical lymphocytes in the bloodstream, which are CD8+ cytotoxic T cells that fight infected B lymphocytes. You must be B lymphocytes, 21, CD21, to drink in a bar, Epstein-Barr virus. WACE. Clinical features. Scent incubation period, 6 weeks. 5 scent clinical course. O symptoms typically occur in adolescents and young adults and last for 2 to 4 weeks. Copyright young children are often asymptomatic. Scent signs and symptoms. O splenomegaly, fever, fatigue, malaise. Copyright pharyngitis and / or tonsillitis, reddened, enlarged tonsils covered in pus, palatal petechiae. O bilateral cervical lymphadenopathy, especially posterior, that may become generalized and can, in severe cases, lead to airway obstruction. Copyright abdominal pain. Copyright possibly hepatomegaly and jaundice. O maculopapular rash, similar to measles. The rash is caused by the infection itself in about 5% of cases but is most commonly associated with the O maculopapular rash, similar to measles. The rash is caused by the infection itself in about 5% of cases but is most commonly associated with the administration of aminopenicillin, example ampicillin, amoxicillin, S1L7. Copyright splenomegaly can lead to a potentially life-threatening splenic rupture. Copyright in most cases, a maculopapular rash occurs due to empiric administration of aminopenicillins, and not due to EBV infection. Diagnostics. Clinical suspicion of IM is confirmed via antibody testing. Scent monospot test. Copyright detects heterophile antibodies produced in response to EBV infection using RBCs from sheep or horses. Copyright patient's serum is mixed with a solution of sheep/horse RBC in vitro equals positive test. Cross-reaction between heterophile antibodies and sheep/horse RBCs. Agglutination equals negative test equals no heterophile antibodies present. No cross-reaction. No agglutination equals in some cases, the test can show negative results if it is performed too soon, i.e. within the first 1 to 2 weeks after symptom onset, and antibodies have not developed yet. Copyright specificity of 100%, sensitivity of 85%. Scent laboratory analysis, elevated LDH and liver transaminases. CF scent peripheral smear, lymphocytosis with 10% atypical lymphocytes, in some cases, up to 90%, scent serology, indicated if IM is suspected but monospot testing is negative. Copyright antiviral capsid antigen antibodies, anti-VCA, anti-VCA IgM, appears early and vanishes 3 months after infection equals anti-VCA IgG, appears after 2 to 4 weeks and persists for life. Copyright anti-EBV nuclear antigen antibody, anti-EBNA1, IgG. Serology: past infection, primary infection, anti-VCA IgM negative positive, anti-VCA IgG positive positive, anti-EBNA1 IgG positive, negative. Pathology. Plus lymph nodes show 6-LLSI-10-LL11O reactive follicular hyperplasia due to increased activation of B lymphocytes. Copyright paracortical expansion through numerous, large immunoblasts, B cells and T cells, later expanding throughout the entire node. Copyright atypical Reed-Sternberg-like cells may be observed, which is why the disease is sometimes mistaken for Hodgkin disease. O shared knot. Differential diagnoses. Scent mononucleosis-like syndromes. 12 Copyright streptococcal pharyngitis, tonsillitis. O acute HIV infection. Back collapse. Fine text outline. Differential diagnoses. Asterisk mononucleosis-like syndromes, 12. Copyright streptococcal pharyngitis, tonsillitis. Copyright acute HIV infection. O CMV infection, CMV mononucleosis. Copyright viral hepatitis. Copyright toxoplasmosis. Scent diphtheria. Scent acute leukemia. And tonsillitis is an important differential diagnosis that is often treated with aminopenicillins, example ampicillin. However, if given to a patient with IM, the patient often develops a macular erythematous rash after 5 to 9 days. OMEX. The differential diagnoses listed here are not exhaustive. FOA2 shared knot man. Treatment. Therapy of IM is mainly symptomatic. Avoid physical activity because of the risk of splenic rupture. Copyright patients should avoid strenuous physical activities for at least 21 days after initial symptoms develop. 1. 5 Copyright patients should avoid high-contact sports, example football, wrestling, for at least 4 weeks. Scent fluids, for administration if necessary, asterisk analgesics/antipyretics, example acetaminophen, viscous lidocaine for throat pain. 1 Scent steroids are not recommended for routine use but may be considered in complicated cases. Contact persons should avoid direct contact to the patient's bodily fluids, example no sharing of food, drinks, personal items, no kissing. Your st. Of shared knot man. Complications. Immunocompromised patients have a higher risk of developing complications. 4. Nervous system. Copyright Guillain-Barré syndrome. O meningoencephalitis. Copyright cranial nerve disorders, especially CN7, copyright primary CNS lymphoma. O multiple sclerosis. 5. Hematological system. O hemophagocytic lymphohistiocytosis, HLH, a life-threatening hematologic disorder involving pancytopenia and severe inflammation due to increased activity of cytotoxic T cells and macrophages. 6. Other secondary causes, malignancy, example colon cancer. 117 clinical features, fever, hepatosplenomegaly, weight loss. Laboratory findings, pancytopenia, T serum ferritin, cholestasis. Bone marrow biopsy, phagocytosis of hematopoietic cells. Trademark. Copyright autoimmune hemolytic anemia, thrombocytopenia. OTTP Hus degree Dick. Scent other organ systems. O upper airway obstruction due to oropharyngeal inflammation and enlarged lymph nodes. Copyright splenic rupture. Copyright oral hairy leukoplakia, typically in HIV patients. Copyright acute renal failure. Copyright pericarditis/myocarditis. EO pneumonia. Copyright otitis media. Scent associated malign. Back collapse. Fine text outline. X infectious mononucleosis. Copyright patients should avoid strenuous physical activities for at least 21 days after initial symptoms develop. 13 Copyright patients should avoid high-contact sports, example football, wrestling, for at least 4 weeks. Scent fluids, for administration if necessary, analgesics/antipyretics, Example acetaminophen, viscous lidocaine for throat pain. Scent steroids are not recommended for routine use but may be considered in complicated cases. Contact persons should avoid direct contact to the patient's bodily fluids, example no sharing of food, drinks, personal items, no kissing. VA. CE. Complications. Immunocompromised patients have a higher risk of developing complications. 4. Nervous system copyright Guillain-Barré syndrome o meningoencephalitis copyright cranial nerve disorders, especially CN7, O primary CNS lymphoma copyright multiple sclerosis 15. Scent hematological system O hemophagocytic lymphohistiocytosis, HLH a life-threatening hematologic disorder involving pancytopenia and severe inflammation due to increased activity of cytotoxic T cells and macrophages 61. Other secondary causes, malignancy, example colon cancer, clinical features, fever, hepatosplenomegaly, weight loss laboratory findings, pancytopenia, T serum ferritin, cholestasis 1 bone marrow biopsy, phagocytosis of hematopoietic cells. Degree TTP whose copyright Dick * other organ systems. O upper airway obstruction due to oropharyngeal inflammation and enlarged lymph nodes copyright splenic rupture copyright oral hairy leukoplakia, typically in HIV patients, copyright acute renal failure O pericarditis/myocarditis O pneumonia copyright otitis media. Scent-associated malignancies O Burkitt lymphoma, BL, a non-Hodgkin lymphoma. Associated with EBV infection, EBNA1 antigen, 18 endemic BL occurs mainly in Africa typically affects the jaw and facial bones sporadic BL, manifests with abdominal masses or bone marrow involvement immunodeficiency related BL, similar to sporadic BL, typically in HIV patients, Hodgkin lymphoma O nasopharyngeal carcinoma, common in Asian adult population, O post-transplant lymphoproliferative disorder, a group of aggressive and rapidly progressive complications of solid organ transplantation and allogeneic hematopoietic stem cell transplantation associated with EBV reactivation in patients with severe immunosuppression, example post-transplantation medications, clinical features, fever, weight loss, fatigue, lymphadenopathy, hepatosplenomegaly commonly progresses to B-cell lymphoma, poor prognosis treatment, reduce immunosuppressive therapy. Back collapse find text outline. Infectious mononucleosis. Etiology pathogen, predominantly Epstein-Barr virus, EBV, transmission, mainly via saliva, hence the common name kissing disease. Epidemiology incidence, US 5:1000 population/year peak age, 15 to 24 years prevalence, worldwide 90% adult population EBV antibody positive. Clinical course incubation period, 6 weeks symptoms usually last 2 to 4 weeks often asymptomatic in young children. Diagnosis monospot test, heterophile antibody testing, if suspicion persists despite negative monospot test, EBV-specific antibody serology peripheral smear, lymphocytosis with atypical lymphocytes. Treatment mainly symptomatic avoid strenuous physical activity for 3 to 4 weeks due to risk of splenic rupture. Complications upper airway obstruction splenic rupture wide range of rare complications in other organ systems, higher risk in immunocompromised individuals. Infectious mononucleosis fact sheet. Copyright emboss. Fever, fatigue, malaise, headache. Bilateral upper eyelid edema, Hoagland sign. DDA, OE. Jaundice pharyngitis, tonsillitis, palatal petechiae. Maculopapular rash usually due to /aminopenicillin i.e., treatment, cervical lymphadenopathy hepatomegaly. Splenomegaly abdominal pain. 6. La. BSS. Infectious mononucleosis, 1/4. Hepatosplenomegaly. CT abdomen, coronal section, of a patient with HIV-associated visceral leishmaniasis. The liver and the spleen are enlarged. Multiple, nodular hypodense lesions are visible throughout the spleen. This image is an adaptation. Source of original image, plus neglected tropical diseases. Original title, Figure 2, A, Abdominal Computerized Tomography, CT, scanning conducted in May 2012. Created by Nicholas J. Gao, Robert N. Davidson, Rob Ticehurst, Andrew Burns, and Mark G. Thomas. Licensed under public domain. Modifications to original image, image cropped. Infectious mononucleosis v. The tonsils are significantly enlarged. A thick, yellow-white membrane is visible over the tonsils and uvula. The palatal mucosa appears inflamed, especially in the midline. This is the typical appearance of tonsillitis in infectious mononucleosis, which is caused by the Epstein-Barr virus. Source, copyright IMPP. Overlay. Membranous tonsillitis VV. Enlarged, inflamed tonsil, green overlay, with gray-white deposits, white outline, in a patient with infectious mononucleosis. Source, copyright IMPP. Overlay. Membranous tonsillitis VV. Enlarged, inflamed tonsil, green overlay, with gray-white deposits, white outline, in a patient with infectious mononucleosis. Source, copyright IMPP. Exudative tonsillopharyngitis in infectious mononucleosis VV. Tonsillopharyngitis caused by Epstein-Barr virus. Both tonsils are so massively enlarged that they touch, which is called kissing. Tonsils. They are covered with the characteristic white-grayish deposits, pus. Source, Mononucleosis by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Uroinfectious mononucleosis, 1/3. Atypical lymphocytosis in infectious mononucleosis VV. A 22-year-old patient presents with lymphadenopathy and absolute lymphocytosis in the differential blood count. The blood smear shows atypical lymphocytes. 1. Atypical lymphocytes are activated T cells with a polymorphic nucleus and abundant basophilic cytoplasm. An inactive lymphocyte, 2, is comparatively smaller with a spherical nucleus and a thin basophilic cytoplasmic layer. Despite being activated T cells, atypical lymphocytes strongly resemble monocytes, 3, in terms of their appearance, hence the name infectious mononucleosis. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Uroinfectious mononucleosis, 2/3. Infectious mononucleosis, peripheral blood smear. Click on the microscope icon to view the entire specimen through a virtual microscope. Source, copyright Smart Zoom, Smart in Media. Image and annotations in digital microscopy, Professor Dr. Karl Anton Kreutzer, Facharzt für Innere Medizin. Hematology und Oncology. X Smart Zoom Viewer. Powered by Smart Zoom. Copyright 2023 Smart in Media. Be re on ENA. Copyright, E090 Debo OSEE at and ACE 5, AE Cent Euro FDOC and at, Parisio Etwis J. EQWIOVOCG. F. OS. Co. O20. Infectious mononucleosis, 3/3. Overlay. Reactive lymphocytes in infectious mononucleosis VV. Photomicrograph of a peripheral blood smear, H&E staining, high magnification, 2 reactive lymphocytes, example indicated by arrowhead, are visible in the center of the image. These lymphocytes are abnormally large and have an irregular border, black dashed outline, due to their increased friability. They also have deeply basophilic cytoplasm and large nuclei, yellow overlay, which may be clefted. Reactive lymphocytes are typically seen in viral infections such as infectious mononucleosis, most common, CMV infection, and HIV, but they can be seen in bacterial infections and drug reactions as well. Source: Infectious Mononucleosis by Ed Uthman, Flickr, licensed under CC by 2.0. Infectious mononucleosis, 3/3. Overlay. Reactive lymphocytes in infectious mononucleosis VV. Photomicrograph of a peripheral blood smear, H&E staining, high magnification, 2 reactive lymphocytes, example indicated by arrowhead, are visible in the center of the image. These lymphocytes are abnormally large and have an irregular border, black dashed outline, due to their increased friability. They also have deeply basophilic cytoplasm and large nuclei, yellow overlay, which may be clefted. Reactive lymphocytes are typically seen in viral infections such as infectious mononucleosis, most common, CMV infection, and HIV, but they can be seen in bacterial infections and drug reactions as well. Source: Infectious mononucleosis by Ed Uthman, Flickr, licensed under CC by 2.0. Infectious mononucleosis, 1/1. Aminopenicillin-related exanthem in infectious mononucleosis VV. Ventral upper body of a patient with a pruritic rash associated with the administration of an aminopenicillin in a patient erroneously diagnosed with bacterial tonsillitis. There is a erythematous, patchy, partly confluent, and pruritic exanthema. This appearance is typical of an aminopenicillin-related exanthema as a drug reaction in infectious mononucleosis. Source: Copyright IMPP. Infectious mononucleosis, 1/3. Overlay. Hemophagocytosis VV. Photomicrograph of a splenic biopsy, H&E stain, very high magnification, macrophages with ingested red blood cells, example indicated by green overlay, can be seen. There is also an increased number of lymphocytes visible. These findings are consistent with hemophagocytic lymphohistiocytosis. Source: Hemophagocytic syndrome, cropped, very high mag by nephron, Wikimedia Commons, licensed under CC by SA 3.0. Infectious mononucleosis, 2/3. HIV patient with oral hairy leukoplakia VV. A 3 to 5 cm confluent, white plaque with a hairy appearance is seen across the left lateral side of the tongue that, in this case, could not be scraped off using a spatula. This clinical finding is characteristic of oral hairy leukoplakia. Source: ID #6061, CDC/JS Greenspan, BDS, University of California, San Francisco, Sol Silverman, Jr., D.D.S., Centers for Disease Control and Prevention, CDC, licensed under public domain. Infectious mononucleosis, 3/3. Overlay. Anterior mediastinal mass in Hodgkin lymphoma VV. X-ray chest, A, PA view, B, left lateral view, and CT chest, C with contrast, coronal plane, of a patient with nodular sclerosing Hodgkin lymphoma. The PA radiograph shows an abnormal superior mediastinum that is dense, markedly widened, and lobulated, green overlay. On the lateral radiograph, there is opacification of the retrosternal space, which should normally be a clear area. CT confirms the presence of a large anterior locally invasive mediastinal soft tissue mass, arrows. Liver, LV, left ventricle source, Fig 1.3, in A Systematic Approach to Chest Radiographic Analysis by Jeffrey S. Klein, Melissa L. Rosado de Christensen, Springer Link, licensed under CC by 4.0. Infectious mononucleosis, 3/3. Copyright. Overlay. Anterior mediastinal mass in Hodgkin lymphoma VV. X-ray chest, A, PA view, B, left lateral view, and CT chest, C with contrast, coronal plane, of a patient with nodular sclerosing Hodgkin lymphoma. The PA radiograph shows an abnormal superior mediastinum that is dense, markedly widened, and lobulated, green overlay. On the lateral radiograph, there is opacification of the retrosternal space, which should normally be a clear area. CT confirms the presence of a large anterior locally invasive mediastinal soft tissue mass, arrows. Liver, LV, left ventricle source, Fig 1.3, in A Systematic Approach to Chest Radiographic Analysis by Jeffrey S. Klein, Melissa L. Rosado de Christensen, Springer Link, licensed under CC by 4.0. Viral croup, i.e., acute laryngotracheobronchitis, is an inflammation of the upper airway that occurs in young children. It is most often caused by the parainfluenza virus. This condition is characterized by a barking cough, hoarse voice, and inspiratory stridor, all of which often worsen at night. More severe symptoms are associated with higher degrees of airway obstruction and include signs of respiratory distress, which can rarely progress to respiratory failure. Croup is primarily a clinical diagnosis, and diagnostic studies are only performed for severe disease, diagnostic uncertainty, or recurrent episodes of croup. All patients with viral croup should receive glucocorticoids, preferably dexamethasone, and supportive treatment. Patients with moderate or severe croup should also be evaluated for admission and receive nebulized racemic epinephrine and supplemental oxygen. The prognosis of uncomplicated croup is good, and complete recovery typically occurs within 7 days of onset. WA. OES. Epidemiology. Cent peak incidence, 6 months to 3 years, most common in fall and winter. References L. Epidemiological data refers to the U.S., unless otherwise specified. WAOE. Etiology. Most common pathogen, parainfluenza viruses, 75% of cases, 2 * other pathogens, respiratory syncytial virus, RSV, adenovirus, influenza virus, SARS-CoV-2, COVID-19, 3I4. VA. OXO. Pathophysiology. Cent important membrane-bound virulence factors of parainfluenza virus include, eohemagglutinin, binds sialic acid, viral entry o neuraminidase, release and spread of virion, cent viral infection, inflammation of the upper airway with edema formation and infiltration of inflammatory cells, narrowing of subglottic airway, inspiratory stridor, and increased work of breathing. WA. CE. Clinical features. Cent prodromal phase, 1 to 2 days of upper respiratory tract infection symptoms, rhinitis, low-grade fever, sore throat, 3 to 5, symptoms of croup last 2 to 7 days and typically manifest in the late evening/night. 3 cent characteristic features include seal-like barking cough, hoarseness, and inspiratory stridor due to subglottic narrowing. 3150 mild croup, stridor may be absent or only manifest in agitated individuals. Moderate croup equals stridor and dyspnea may be present at rest. Thoracic retractions are typically visible. Affected individuals may be tachycardic or tachypneic. Severe croup equals severe stridor and dyspnea are present at rest. Air entry is decreased. Hypoxemia, an altered mental state, and or other signs of impending respiratory failure may be present. Upper airway obstruction can cause pulsus paradocus. 6 agitation can worsen symptoms and precipitate complete airway obstruction. Do not examine the throat of a child with significant stridor because the resulting agitation may precipitate complete airway obstruction. 7. V. Back collapse. Find text outline. Diagnostics. General principles /LL9 LL3. Scent croup is most commonly diagnosed based on the presence of characteristic clinical features of croup. Scent diagnostic studies are not routinely required. Do not delay treatment in unstable patients to obtain studies. Scent indications for diagnostic studies include copyright atypical presentation or diagnostic uncertainty, to rule out differential diagnoses of pediatric stridor or severe disease or recurrent episodes of croup. Do not delay treatment of stridor to perform diagnostic studies. Imaging. Scent X-ray chest and neck, anteroposterior and lateral. 9. Copyright may identify subglottic narrowing on anteroposterior view, steeple sign. IO may show concurrent lower airway involvement. 10. The steeple sign is not specific to croup. It may also be present with bacterial tracheitis, epiglottitis, and non-infectious etiologies such as thermal injuries and copyright neoplasms. And laboratory studies. Scent respiratory viral panel usually reserved for patients who do not respond to initial treatment. 3. Most commonly shows parainfluenza. Co-infections are common. 5. Scent CBC may help distinguish between bacterial and viral infections. 3. Blood gas. 3. Copyright indicated for severe respiratory symptoms. Example signs of impending respiratory failure. May show hypoxemia and/or retention. Management. Scent keep the patient calm and minimize distress. 1. Copyright allow the patient to maintain a comfortable position, usually semi-upright. M70 examine the child in the parent's lap. 41. Copyright avoid examining the throat as this may precipitate airway obstruction. 7. Hypoxemia/signs of impending respiratory failure, initiate immediate stabilization, example supplemental oxygenation, intubation. Perform a croup severity assessment to guide treatment, consider using a scoring system, example Westley croup score. All patients, dexamethasone and supportive care as needed, example antipyretics. 4. Fluids, copyright patients with moderate/severe croup, add nebulized racemic epinephrine. Regularly reassess patients. Admit patients with admission criteria for croup, example severe croup, age. Copyright nebulized racemic epinephrine rapidly relieves symptoms of respiratory distress. Dexamethasone provides longer symptom relief but takes up to 6 hours to reduce airway swelling. 3. 6. Humidified air, both in the hospital and as a home remedy, example steam inhalation, has been used to treat croup, but there is no evidence that it is effective. SV6LTS. OOE. Differential diagnoses. Overview. Overview of differential diagnoses of stridor S2123. Back collapse. Find text outline. Croup IC laryngitis, istics. Cause. Onset. General condition. Cough. Voice. Difficulty swallowing/drooling. X-ray neck and chest findings. Response to therapy for croup. Management. Laryngotracheitis. Scent viral, primarily human parainfluenza viruses. Slow, 12 to 48 hours. Well appearing. Barking. Hoarse. Absent. Steeple sign, subglottic narrowing on chest X-ray. Improvement after treatment with nebulized epinephrine. Treatment degree dexamethasone. Copyright nebulized epinephrine prevention, no vaccine is available. Additional differential diagnoses. 3. pneumonia, tracheomalacia, laryngomalacia, anaphylaxis, asthma/virus-induced wheeze, retropharyngeal abscess, bacterial tracheitis, subglottic stenosis, subglottic hemangioma. Overview of etiological diagnoses of Stryer trademark. Spasmodic croup, atypical croup, 12. Genetic predisposition may be triggered by an allergic reaction or GERD. Sudden onset during nighttime with resolution of symptoms during the day may recur on subsequent nights. Well appearing, no fever. Barking. Hoarse. Absent. Steeple sign, subglottic narrowing on chest X-ray. Improvement after treatment with nebulized epinephrine. Treatment degree: dexamethasone OE, nebulized epinephrine prevention, management of potential underlying causes, example GERD. The differential diagnoses listed here are not exhaustive. OE. Complications: respiratory failure, rare, pulmonary edema, pneumothorax, sent pneumomediastinum. Back. Epiglottitis, supraglottic laryngitis. Bacterial copyright H. influenza type B or non-type E, able degree S. pyogenes copyright S. pneumoniae degree S. aureus. Sudden, 4 to 12 hours. Acutely ill appearing, infectious state with lethargy, poor perfusion, cyanosis, hypoventilation or hyperventilation, high fever, drooling, breathing, positions of comfort copyright tripod posture copyright sniffing position. Absent. Muffled. Present. Thumbprint sign, thickening of epiglottis on lateral neck X-ray. No improvement. Treatment: antibiotics. See treatment of epiglottitis. Prevention: a vaccine is available for H. influenza type B and S. pneumoniae. Wea collapse. Laryngeal diphtheria. Bacterial, C. diphtheriae. Initially slow, then sudden onset of symptoms after 4 to 5 days. Acutely ill appearing, possible swollen neck. Barking. Hoarse. Present. Sent subglottic narrowing. No improvement. Treatment: diphtheria, antitoxin copyright antibiotics degree airway management prevention, a vaccine is available. A. Find text. Foreign body, FB, aspiration. Accidental aspiration of a foreign body, example nuts, raisins, pieces of toys. Sudden if the initial aspiration and choking episode is not witnessed, onset of symptoms, persistent or recurrent cough, days or weeks later. Depending on the degree of obstruction, signs of partial airway obstruction or signs of complete airway obstruction may be present. Choking. Hoarseness or inability to speak indicate a laryngotracheal FB. Depends on the location of the FB. Most FB are radiolucent and not visible on X-ray. Indirect findings of FB include copyright chest, focal hyperinflation of the distal lung on the affected side, copyright neck, widened prevertebral shadow and loss of cervical lordosis. No improvement. Treatment: removal of FB via rigid bronchoscopy, copyright Heimlich maneuver for suspected complete airway obstruction prevention, education for caregivers on child safety. Outline. Difficulty swallowing/drooling. A. X-ray neck and chest findings. Response to therapy for croup. Management. Absent. Steeple sign, subglottic narrowing on chest X-ray. Improvement after treatment with nebulized epinephrine. Treatment: dexamethasone OE, nebulized epinephrine prevention, no vaccine is available. Absent. Steeple sign, subglottic narrowing on chest X-ray. Improvement after treatment with nebulized epinephrine 4. Treatment copyright dexamethasone degree nebulized epinephrine prevention, management of potential underlying causes, example GERD. Present plus present asterisk depends on the location of the FB. Asterisk most FB are radiolucent and not visible on X-ray. Asterisk indirect findings of FB include, copyright chest, focal hyperinflation of the distal lung on the affected thumbprint sign, thickening of scent subglottic narrowing epiglottis on lateral neck X-ray. Eye-side copyright neck, widened prevertebral shadow and loss of cervical lordosis. No improvement asterisk no improvement asterisk no improvement. Asterisk treatment scent treatment copyright removal of FB via rigid bronchoscopy treatment, antibiotics, see copyright diphtheria antitoxin treatment of epiglottitis, copyright antibiotics AHA degree Heimlich maneuver for scent prevention, a vaccine is O airway X suspected complete airway available for H influenza type management equals obstruction 1B and S pneumonia I asterisk prevention, a vaccine is asterisk prevention, education for available. Phi caregivers on child safety. Additional differential diagnoses, 31. Asthma/virus-induced wheeze pneumonia. Retropharyngeal abscess bacterial tracheitis tracheomalacia laryngomalacia subglottic stenosis subglottic hemangioma scent anaphylaxis. The differential diagnoses listed here are not exhaustive. OI. Of choracesis rives man AO1 notes onage. Complications. Scent respiratory failure, rare, pulmonary edema scent pneumothorax scent pneumomediastinum scent secondary bacterial infection, example bacterial tracheitis, cardiac arrest and death. We list the most important complications. The selection is not exhaustive. Prognosis. Scent the prognosis in uncomplicated cases is good, with full recovery. Parents should be aware that croup tends to recur. Most often within a week after recovery or if croup recurs within the peak incidence age, 6 months to 3 years, airway abnormalities should be suspected. Copyright if croup recurs outside the peak incidence age, atopic conditions, airway lesions or gastroesophageal reflux should be suspected. Tips and links. Psoriac. Back collapse find text. Outline. Eurocroup, 1/1, A. Overlay. Steeple sign. X-ray neck of a young child, AP view, the upper tracheal air column, which normally appears with a square-shouldered configuration, has assumed a conical shape, green overlay, reminiscent of a church steeple, steeple sign, cf illustration. The steeple sign indicates subglottic airway narrowing and is most commonly seen in croup. However, it may also appear in other conditions, example bacterial tracheitis, tumors. An accompanying lateral radiograph might additionally show inspiratory overdistension of the hypopharynx. Source: Croup steeple sign by Dr. Frank Gaillard, Wikimedia Foundation, licensed under CC by SA 3.0. Modifications, arrow removed. Eurocroup, 1/1, 7. Ali. Overlay. Steeple sign. X-ray neck of a young child, AP view, the upper tracheal air column, which normally appears with a square-shouldered configuration, has assumed a conical shape, green overlay, reminiscent of a church steeple, steeple sign, cf illustration. The steeple sign indicates subglottic airway narrowing and is most commonly seen in croup. However, it may also appear in other conditions, example bacterial tracheitis, tumors. An accompanying lateral radiograph might additionally show inspiratory overdistension of the hypopharynx. Source: Croup steeple sign by Dr. Frank Gaillard, Wikimedia Foundation, licensed under CC by SA 3.0. Modifications, arrow removed. X. Bacterial tracheitis. Bacterial tracheitis is a condition characterized by profuse exudates and pseudomembranes due to severe bacterial infection of the trachea. It can occur as a primary bacterial infection or following a viral illness. The most common manifestation is stridor in young children. Bacterial tracheitis is similar to viral croup and epiglottitis, however, affected individuals typically have higher fevers, are ill-appearing, and have severe respiratory symptoms that do not respond to treatments, example with nebulized epinephrine. Patients usually require immediate stabilization and airway management before proceeding to bronchoscopy for diagnostic confirmation and treatment. Additional treatment includes broad-spectrum antibiotics and ICU management. If left untreated, bacterial tracheitis may progress to complete airway obstruction, sepsis, and death. This article only addresses bacterial tracheitis in patients with native airways. Disease characteristics and management are different in patients with artificial airways. A7CE. Epidemiology. Scent rare, primarily occurs in children QLS, plus more common during the fall and winter. 21 epidemiological data refers to the U.S., unless otherwise specified. 2E. Etiology. Staphylococcus aureus, most common, ALS, scent others, H. influenza, S. pneumoniae, S. pyogenes, M. catarrhalis, ALTS. Clinical features. Scent preceding viral upper respiratory tract infection, productive cough, hoarseness, sore throat. 6. Severe rapidly progressing symptoms, within 2 to 10 hours. 5. Unwell appearance. Copyright high fever. Copyright signs of respiratory distress. Copyright life-threatening airway obstruction, signs of impending respiratory failure. In contrast to croup, the symptoms of bacterial tracheitis do not improve with nebulized epinephrine. 7. OSAE. Management. 6. Bacterial tracheitis is an airway emergency. Do not delay treatment to obtain diagnostic studies. Immediate stabilization. 6IL8 Li 71I9. Most patients, 75%, have severe airway compromise requiring intubation and intensive care management. LEL 7-9, scent respiratory support. If there are signs of airway compromise and/or signs of respiratory distress, scent prepare for difficult intubation. If patients are hypoxic and/or in severe distress, scent immediate hemodynamic support. If there are clinical features of shock. Copyright in children with signs of airway compromise, minimize any agitation, as this can worsen airway obstruction. Medical therapy. 7.3 Allele 6. Scent empiric for antibiotics with anti-streptococcal and anti-staphylococcal coverage for 7 to 10 days. 1. Copyright vancomycin. Medical therapy. 131 Latil. Scent empiric for antibiotics with anti-streptococcal and anti-staphylococcal coverage for 7 to 10 days. E. Vancomycin O plus 1 of the following, equals ceftriaxone ampicillin/sulbactam. Scent supportive treatment, example antipyretics, for fluids, as needed. Direct visualization. 6L7. Scent goals. Copyright diagnostic confirmation. O. Relief of airway obstruction equals debridement, example stripping pseudomembranes, suctioning exudates, equals repeated treatments may be necessary. Copyright collection of microbiological studies, example gram stain, culture, plus modalities, bronchoscopy, flexible laryngoscopy. 17 findings include, 6. O. Inflamed trachea and subglottis. E. Thick mucopurulent exudates. O. Pseudomembrane. O. Mucosal necrosis. Additional studies. Copyright, Scent 1. Scent laboratory studies. 6 OCBC, may show nonspecific findings, left shift is common. Copyright blood cultures, typically negative, consider for patients with severe infection, example signs of sepsis, * imaging. Copyright X-ray neck, AP and lateral may show subglottic narrowing, steeple sign, and slash or tracheal wall irregularities. MS 5-degree X-ray chest, AP and lateral may show focal infiltrates. 6. Row shared note. Differential diagnoses. Sense C. Differential diagnoses of pediatric inspiratory stridor. The differential diagnoses listed here are not exhaustive. WA. FS haired N. Complications. Sepsis and septic shock and toxic shock syndrome, acute respiratory distress syndrome and residual subglottic stenosis, post-obstructive pulmonary edema. We list the most important complications. The selection is not exhaustive. V. Back collapse. A. Find text. Al. Outline. Bacterial tracheitis, 1/2. Pseudomembranous bacterial tracheitis VV. Bronchoscopy of the upper trachea. The tracheal mucosa is erythematous and swollen, with an irregular, lumpy appearance, cobblestoning. Thick white exudate forms a pseudomembrane over the mucosa. Source: Fig 2, in pseudomembranous tracheobronchitis due to Mycobacterium tuberculosis by Froissel L.J., Abdeen Y., Curious, licensed under CC by 4.0. Urobacterial tracheitis, 2/2, A. Overlay. Steeple sign. X-ray neck of a young child, AP view. The upper tracheal air column, which normally appears with a square-shouldered configuration, has assumed a conical shape, green overlay, reminiscent of a church steeple, steeple sign, cf. illustration. The steeple sign indicates subglottic airway narrowing and is most commonly seen in croup. However, it may also appear in other conditions, example bacterial tracheitis, tumors. An accompanying lateral radiograph might additionally show inspiratory overdistension of the hypopharynx. Source: Croup steeple sign by Dr. Frank Gaillard, Wikimedia Foundation, licensed under CC by SA 3.0. Modifications: arrow removed. Urobacterial tracheitis, 2/2. Steeple sign. X-ray neck of a young child, AP view. The upper tracheal air column, which normally appears with a square-shouldered configuration, has assumed a conical shape, green overlay, reminiscent of a church steeple, steeple sign, cf. illustration. The steeple sign indicates subglottic airway narrowing and is most commonly seen in croup. However, it may also appear in other conditions, example bacterial tracheitis, tumors. An accompanying lateral radiograph might additionally show inspiratory overdistension of the hypopharynx. Source: Croup steeple sign by Dr. Frank Gaillard, Wikimedia Foundation, licensed under CC by SA 3.0. Modifications: arrow removed. X. Epiglottitis. Epiglottitis is the rapid progressive inflammation of the epiglottis and surrounding supraglottis that was historically primarily caused by Haemophilus influenza type B, HIB. Since the introduction of the HIB vaccine in 1985, the incidence of HIB epiglottitis has significantly decreased. Epiglottitis is now more common in adults than in children and is usually caused by other bacteria, example Streptococci and Staphylococci. Children with epiglottitis typically appear acutely ill and position themselves in a tripod stance, sitting and leaning forward, in an attempt to improve their airway diameter. The disease is characterized by the acute onset of fever, drooling, sore throat, dysphagia, and, in severe cases, respiratory distress accompanied by inspiratory retractions and cyanosis. Impending airway obstruction is also accompanied by a muffled voice and restlessness. Epiglottitis is diagnosed based on clinical presentation. If the diagnosis is unclear and the patient is stable, a lateral cervical X-ray may be considered, on which a thumb sign may be seen. If the patient is unstable, their airway should first be secured, after which direct laryngeal examination may be performed. Patients should be closely monitored in a hospital and receive 4 antibiotics. Most patients make a full recovery after prompt and adequate treatment. WA. OES. Epidemiology. Asterisk more common in adults than children, 2% peak incidence in children, 6 to 12 years AE2E peak incidence in adults, 40 to 50 years. 1 epidemiological data refers to the US, unless otherwise specified. OSFA, CES. Etiology. Pathogens. Copyright. Traditionally, Haemophilus influenza type B, HIB, most cases now involve, equals Streptococcus pyogenes equals Streptococcus pneumoniae equals Staphylococcus aureus equals non-type Abel H. Influenza. Scent risk factors. Not immunized against HIB. Immunodeficiency. References 3. Y. 2 shared not. Pathophysiology. Bacteria invades tissue, directly or through hematogenous spreading, of the epiglottis and/or surrounding supraglottic structures, i.e., arytenoids, aryepiglottic folds, and vallecula, supraglottic inflammation and edema. Narrowing of the airway obstruction, partial or complete. 13. A. 5. Clinical features. Respiratory distress, inspiratory retractions, cyanosis, inspiratory stridor. 1 tripod position, eases respiration as the airway diameter is increased by leaning forward and extending the neck in a seated position. 1 sore throat. Dysphagia and odynophagia. Drooling muffled voice, i.e., resembling a hot potato voice, with painful speech. Acute onset of high fever, 39 to 40 degrees Celsius, 102 to 104 degrees Fahrenheit, toxic appearance. Restlessness and/or anxiety. Absence of cough. Tenderness to palpation over larynx/throat. 4. Back collapse. Fine text outline. GB. The hallmarks of epiglottitis are the 3 Ds, dysphagia, drooling, and distress. F. References, Sil 5i. 7 OES. Airway management. In young children, airway management is a higher priority than diagnostic evaluation. 1. Advanced airway placement is rarely required in adults. 4. Approach 6-7-14. Keep the patient sitting upright to prevent further airway compromise. Minimize external stressors and stimuli that could worsen respiratory distress and airway edema. Consult an airway specialist early. Provide supplemental oxygen as needed. Assess for, copyright clinical features of airway obstruction, example stridor, tachypnea, retractions, hypercapnia, cyanosis, loss of air movement, altered mental state, risk factors for acute deterioration, example immunocompromise or diabetes, epiglottic abscess, rapid onset of symptoms, or rapid progression of severe symptoms. 41 patients with clinical features of airway obstruction or risk factors for acute deterioration. Copyright if there are signs of acute respiratory distress, begin bag mask. Ventilation with 100% oxygen. SAO secure the airway with emergency endotracheal intubation in a controlled setting by an experienced practitioner. Copyright prepare to perform an emergency surgical airway if endotracheal intubation is unsuccessful. Patients without severe airway obstruction or risk factors for acute deterioration, intubation may not be required. Copyright consider careful visualization of the epiglottis or imaging to confirm the diagnosis. Copyright start treatment for epiglottitis. Copyright monitor in an ICU setting for at least 12 hours. 15. Acute epiglottitis is an airway emergency. Urgently consult a physician experienced in difficult airway management, example an emergency physician, anesthesiologist, or otolaryngologist. Endotracheal intubation /91I71I5. Asterisk indications of respiratory distress O. Altered mental status. 1. Copyright inability to swallow. Copyright stridor. Copyright drooling. O. Voice changes. Procedure. Copyright ensure difficult airway. Cart is at the bedside. Copyright prepare for difficult intubation with a backup plan, example emergency surgical airway. Equals use video assisted laryngoscopy, if available. Equals consider flexible fiber optic intubation or rigid bronchoscopy, if available and trained. Copyright consider rapid sequence induction if there is rapid clinical deterioration. Confirm and check the adequacy of ventilation. Copyright extubation should be performed 2 to 3 days, at the earliest, after starting antibiotic treatment. Emergency surgical airway, 110. Indicated if intubation is unsuccessful. Sent children. OCES. Diagnostics. Approach 11 6 12 13 14. Back collapse. Find text outline. Diagnostics. Approach 11 F 6 12 13 14. Sent epiglottitis is primarily a clinical diagnosis. Copyright. See also differential diagnoses of stridor and overview of deep neck infections for the evaluation of alternate diagnoses. If the diagnosis is uncertain and there are no signs of impending airway obstruction, copyright visualize the epiglottis to confirm the diagnosis. Copyright consider imaging to confirm the diagnosis if visualization of the epiglottis is unclear or unsuccessful. Alternate diagnoses need to be ruled out, example croup, abscess, foreign body aspiration. 3. Secure the airway before initiating diagnostic studies or procedures in patients with impending airway compromise, especially in children. Visualization of the epiglottis. 1 Mel 12213 if 14. Asterisk indication, there is suspicion for epiglottitis but no clinical features of airway obstruction. Asterisk procedure. Copyright direct pharyngoscopy, oropharyngeal examination with a tongue blade. Copyright direct laryngoscopy, can be performed during or after intubation. Copyright indirect laryngoscopy, mirror examination, or flexible fiber optic laryngoscopy. Copyright perform in an ICU, or emergency department. Plus additional considerations. Copyright avoid increasing anxiety, especially in children. Keep the patient comfortable and in a calm setting. Keep the patient in a sitting position at all times, do not force the patient to lie supine. Characteristic findings. Copyright direct pharyngoscopy, often normal, epiglottis is often not seen. Copyright indirect laryngoscopy or flexible fiber optic laryngoscopy cherry red epiglottis, pooled secretions, inflammation and edema of the supraglottic structure. Imaging, 11 6 12 13 14. Soft tissue lateral neck X-ray, 15. Indication, mainly performed in children if the clinical presentation in early cases is inconclusive. Asterisk procedure, should be carried out under the supervision of an experienced physician. Characteristic findings. O thumb sign, also referred to as thumbprint sign, enlarged epiglottis and supraglottic narrowing. Copyright narrowing or complete loss of the normal pre-epiglottic air shadow, vallecula sign. Copyright thick aryepiglottic folds. CT of the neck with 4 contrast, 14. Scent indication, only performed in adults, mainly to exclude other diagnoses. Procedure, requires the supine position, which can compromise the airway. Asterisk characteristic findings. Copyright thickening of any of the following may be present, epiglottis aryepiglottic folds false vocal cords and true vocal cords platysma muscle and prevertebral fascia. Copyright loss of vallecular air space. Copyright obliteration of preepiglottic fat. Back collapse. Find text. A. Outline. So additional diagnostic studies, 11 blood cultures, 2 sets, plus swab of the epiglottis and epiglottic culture, to guide antibiotic therapy. Sent HIV immunization status of the patient, and close contacts, if applicable. WAOCES. Treatment. Empiric for antibiotics, 1127. There are no guidelines on specific empiric antibiotic recommendations. All patients should receive 4 antibiotics that are active against HIV, S. aureus, S. pyogenes, and S. pneumonia. Following cultures, antibiotics can be narrowed according to identified organisms. 1 * Most sources recommend monotherapy with a third-generation cephalosporin, example cefotaxime, ceftriaxone, or a beta-lactam with a beta-lactamase inhibitor, example ampicillin/sulbactam, amoxicillin/clavulanate, piperacillin/tazobactam, 17-IL-8-LL6-LL19. For patients with severe penicillin allergy, consider a fluoroquinolone, example levofloxacin. 71T19 *. Consider the addition of an antibiotic with anti-MRSA activity, example vancomycin, clindamycin. NF6-LL19 adjunctive therapy, 111L20LL14I21. * Consider empiric steroids. 21 copyright dexamethasone, 21 copyright or methylprednisolone, 21 plus 4 fluid resuscitation 1. VAOS. Differential diagnoses. Sense differential diagnoses of pediatric inspiratory stridor and differential diagnosis of dyspnea. Foreign body aspiration, anaphylactic reaction, * chemical injury or thermal injury, burns, laryngitis and peritonsillar abscess or retropharyngeal abscess. The differential diagnoses listed here are not exhaustive. WSACE. Prognosis plus mortality rate. ACE. Prevention. HIV vaccine, C. Immunization schedule, plus post-exposure prophylaxis with rifampin, 23LL1124. WAO SOD. Sources last updated July 31, 2023. Uroepiglottitis, 1/1. Epiglottitis, respiratory distress and associated features: high fever, cyanotic lips, muffled voice, extended neck and chin, AAX, growling SS, due to dysphagia, retractions, inspiratory stridor. Tripod position. Epiglottitis. Copyright emboss. Airflow. Inflamed epiglottis. Lateral neck radiograph, trachea. Thumb sign. Uroepiglottitis, 1/3. Epiglottitis VV. Endoscopy of the epiglottis. Pooled secretions are visible around a swollen epiglottis. This is the typical appearance of epiglottitis. Source: Epiglottitis Endoscopy by Number 4, Wikimedia Commons, licensed under CC by SA 3.0. Uroepiglottitis, 2/3. Overlay. Thumb and vallecula signs, epiglottitis, VV. X-ray soft tissue neck, lateral view. The epiglottis is swollen and rounded in appearance, thumb sign, highlighted by green overlay and black arrow, as a result of inflammation and edema. The normal air space between the tongue base and epiglottis has been almost entirely obliterated and is seen only as a shallow V-shaped space, vallecula sign, highlighted by red line. The thumb and vallecula signs are useful in the radiographic evaluation of epiglottitis. Source: Epiglottitis by Doc James, MedChaos, Wikimedia Commons, licensed under CC 1.0. Modifications: removed white arrow. Uroepiglottitis, 2/3. Copyright. Overlay. Thumb and vallecula signs, epiglottitis, VV. X-ray soft tissue neck, lateral view. The epiglottis is swollen and rounded in appearance, thumb sign, highlighted by green overlay and black arrow, as a result of inflammation and edema. The normal air space between the tongue base and epiglottis has been almost entirely obliterated and is seen only as a shallow V-shaped space, vallecula sign, highlighted by red line. The thumb and vallecula signs are useful in the radiographic evaluation of epiglottitis. Source: Epiglottitis by Doc James, MedChaos, Wikimedia Commons, licensed under CC 01.0. Modifications: removed white arrow. Uroepiglottitis, 3/3. Copyright. Overlay. Epiglottitis, supraglottitis, VV. CT neck, sagittal view, with contrast, and laryngoscopy of a patient with throat pain, hoarse voice, left-sided neck swelling, and a positive rapid strep test. The CT scan reveals edematous mucosal thickening of the oropharynx and supraglottic larynx, including the epiglottis, indicated by red arrowhead. The supraglottic laryngeal lumen appears severely narrowed, indicated by green arrowhead. Bedside flexible laryngoscopy shows edema of the epiglottis, E, vocal cords, V, and arytenoids, A. Clinical findings and imaging suggest acute pharyngitis and supraglottic laryngitis with severe narrowing of the supraglottic laryngeal lumen. Black arrowhead, subglottic larynx. Source: Fig 1 and 3, in Case Report, Acute Supraglottitis by Jamie Robin Chu, Jonathan G. Rogg, J. E. Tem, licensed under CC by 4.0. Modifications: image combines two separate images, both images have been cropped. X. Diphtheria. Diphtheria is an infectious disease caused by Corynebacterium diphtheriae, which is usually transmitted via respiratory droplets. The clinical features of diphtheria are caused by a toxin produced by C. diphtheriae after it colonizes the upper respiratory tract. Patients initially present with fever, malaise, and sore throat. Within a few days, a grayish-white pseudomembrane develops over the tonsils, posterior pharyngeal wall, and / or larynx. Other manifestations include cervical lymphadenopathy, soft tissue swelling of the neck, stridor, and / or difficulty breathing as a result of partial airway obstruction. Systemic absorption of the toxin can result in myocarditis, acute tubular necrosis, and / or polyneuropathy. Even before culture reports come back positive, patients should be promptly treated with penicillin and antitoxins, as untreated. Diphtheria is associated with a high mortality rate. In tropical countries, there is also a cutaneous form of diphtheria without systemic manifestations. Cutaneous diphtheria manifests as a scaly erythematous rash and / or a deep punched-out ulcer following direct entry of C. diphtheriae into the skin. Since the introduction of routine immunization against diphtheria in the 1920s, the incidence of the disease has decreased dramatically in the U.S. WA. OE. Epidemiology. Asterisk incidence, 0 to 2 cases / year, 1. Asterisk most cases occur in patients 20 years of age or older. Epidemiological data refers to the U.S., unless otherwise specified. WA. CE. Etiology. E-pathogen, Corynebacterium diphtheriae degree gram-positive, non-sporulating, club-shaped bacillus, Q. Copyright contains metachromatic granules, volutin granules, stain red with a blue dye, plus route of infection E. Droplet transmission EO less commonly through direct or indirect contact with open lesions. Infectious period, variable. Arigot TAJ references /21. A. CE. Pathophysiology. Since C. diphtheriae colonizes the mucous membrane of the respiratory tract, respiratory diphtheria, and, less commonly, pre-existing skin lesions, cutaneous diphtheria. C. diphtheriae has both toxigenic and non-toxigenic strains. Toxigenic strains contain a beta-prophage gene, TOX, which encodes for the exotoxin diphtheria toxin O. General characteristics: a heat label protein with a molecular weight of 62,000 kDa made of A and B fragments. O. Mechanism of action: The A fragment enters cells and catalyzes the transfer of ADP ribosylation of the elongation factor 2, F2, inhibition of F2 arrested protein translation and synthesis cell death and necrosis. Copyright local effects of the toxin, destruction of the respiratory epithelium with a subsequent inflammatory response equals deposition of necrotic epithelium embedded within fibrinosuppurative inflammatory exudate, pseudomembrane, over the pharynx, tonsils, and/or larynx equals enlargement of the cervical lymph nodes and edema of the soft tissue of the neck. Bull neck appearance, airway obstruction. O systemic effects of the toxin equals fatty changes and focal necrosis of the myocardium and, less commonly, the liver, kidney, and adrenal glands. Equals nerve demyelination. At Q of C diphtheria, ADP ribosylation, beta prophage, club-shaped, diphtheria, elongation factor 2, metachromatic granules. Back collapse. Fine text outline. Clinical features. Respiratory diphtheria. Patients initially present with prodromal symptoms, fever, malaise, and sore throat. 4 to 5 days after the onset of prodromal symptoms, symptoms due to the local and systemic effects of the toxin occur. Scent incubation period, 2 to 5 days. Scent local features. Copyright anterior nasal diphtheria, bloody rhinorrhea. Copyright tonsillar and pharyngeal diphtheria equals grayish-white pseudomembrane over the posterior pharyngeal wall, and/or tonsils. A equals any attempt to scrape off the pseudomembrane exposes the underlying capillaries and results in heavy bleeding. Equals bull neck due to cervical lymphadenopathy and swelling of the soft tissue of the neck. Airway obstruction. J equals foul mouth odor. Olaryngeal diphtheria, difficulty breathing, inspiratory stridor. Systemic features, due to dissemination of toxin. O cardiac equals myocarditis equals arrhythmias equals rarely, endocarditis. O reversible polyneuropathy. Copyright acute tubular necrosis. Copyright adrenal insufficiency. Copyright septic arthritis. Cutaneous diphtheria. Scent. Cutaneous diphtheria is the result of direct inoculation of C. diphtheriae into the skin, example skin abrasions or pre-existing skin lesions. Usually seen in tropical regions, where it is more common than respiratory diphtheria. Scent. Patients present with scaly erythematous rash, impetigo, or deep, punched-out ulcers. 1 * Cutaneous diphtheria does not result in systemic effects. References. Diagnostics. Scent cultures, obtained from all suspected patients, before initiating antibiotic therapy, to confirm the diagnosis. OA, copyright respiratory diphtheria, obtain nasal and pharyngeal cultures. Copyright cutaneous diphtheria, obtain cultures from skin lesions. Copyright microscopic examination, multiple gram-positive club-shaped bacilli clustered in angular arrangements. Copyright culture media of choice equals cystine tellurite agar, C. diphtheriae appears as black colonies. Equals Loeffler medium, shows metachromatic granules. Tests to identify toxigenic strains, if the culture reveals C. diphtheriae. O. ELIC test. An immunoprecipitation test in which C. diphtheriae are grown in an agar culture that is embedded with an antitoxin impregnated filter paper. A equals positive if the strain is toxicogenic. O. Polymerase chain reaction, to identify the tox gene. Therapy, including antitoxin administration, should be started immediately upon clinical suspicion, even before diagnostic confirmation of diphtheria. 5. Back collapse. Fine text outline. Scent. Acute tonsillitis. E-croup. Scent. Oropharyngeal candidiasis. The differential diagnoses listed here are not exhaustive. OOE. Treatment. Scent. The patient should be isolated as soon as diphtheria is suspected. SL2. A respiratory diphtheria, initiate droplet precautions. Cutaneous diphtheria, initiate contact precautions. Copyright continue isolation until 6 equals cultures are negative for toxigenic C. diphtheria equals or, if a toxigenic strain is isolated, Two consecutive cultures taken equals 24 hours apart and equals 24 hours after completing antibiotic therapy are negative. 1. Sent antibiotic therapy, penicillin G, IM injection, or erythromycin, oral/4, for 14 days. 5. Immediate administration of diphtheria antitoxin. The antitoxin can only neutralize the unbound toxin and should therefore be administered early in the course of the disease. 1. Olaryngeal/pharyngeal diphtheria lasting 3 days, 80,000 to 120,000 units for over 60 minutes airway support. Asterisk monitor for myocarditis, conduct multiple ECGs and serial measurement of cardiac markers. Add, diphtheria is a nationally notifiable disease. 5. Q-Add administration of the antitoxin is a critical part of treatment, as the clinical features of diphtheria are not caused by the pathogen itself but rather by the exotoxin that C. diphtheriae produces. Go. OE. Prevention. Immunization, 728I9. Scent. The diphtheria vaccine is a toxoid vaccine. Scent 4 diphtheria vaccines are available in the U.S., copyright diphtheria, tetanus, acellular pertussis vaccine, DTAP, pound copyright tetanus diphtheria acellular pertussis vaccine, Tdap, copyright diphtheria and tetanus vaccine, DT, CA copyright tetanus and diphtheria vaccine, TD, Scent CACIP immunization schedule for details. Exposure control, 10L11. Management of exposed contacts. Scent all exposed contacts copyright obtain cultures for C. diphtheria. 4 copyright provide post-exposure prophylaxis for diphtheria. Copyright quarantine while awaiting culture results. Copyright monitor for clinical features of diphtheria for 7 to 10 days. Scent if cultures are negative, discontinue quarantine and complete chemoprophylaxis. 11 asterisk if cultures are positive, 11 EO asymptomatic individuals, carriers isolate until completion of chemoprophylaxis and 2 cultures are negative. O symptomatic patients, see treatment. Post-exposure prophylaxis for diphtheria, 11L5. All exposed close contacts should receive prophylactic antibiotics and be assessed for immunization. Plus antibiotic chemoprophylaxis, erythromycin or a single IM dose of benzathine penicillin G, IL-12 plus active immunization with a diphtheria vaccine registered IL-11. Back collapse. Find text outline. Eurodiphtheria, 1/1. %S whale. Overlay. Corynebacterium diphtheriae EVV. Photomicrograph, methylene blue stain, numerous gram-positive, rod-shaped bacteria can be seen, examples marked by blue overlay. The pathogens exhibit pleomorphism and do not show a particular arrangement. The bacterial poles appear nodular, exampled indicated by arrowheads. The nodules usually contain granules, which can be made visible with special metachromatic stains, not shown here. Source, ID #7323, Centers for Disease Control and Prevention, Centers for Disease Control and Prevention licensed under public domain. Diphtheric myocarditis VV. HNE stain of infectious myocarditis showing necrotic muscle areas and invading immune cells, e.g. lymphocytes. Source, ID #3157, CDC/Dr. Martin Hicklin, Centers for Disease Control and Prevention, CDC, licensed under public domain. Diphtheria, 1/3. Tonsillar and pharyngeal diphtheria. A gray-white pseudomembrane extends from the left palatine tonsil over the uvula to the hard palate. The pseudomembrane consists of fibrinous exudate as well as immune and epithelial cells and is characteristic of tonsillar and pharyngeal diphtheria. Source, dirty white pseudomembrane classically seen in diphtheria by Dilly Eponacri, Wikimedia Commons, licensed under CC by SA 3.0. Bull neck VV. Source, ID hashtag, 5325, CDC, Centers for Disease Control and Prevention, CDC, licensed under public domain. Urodiphtheria, 3/3. Cutaneous diphtheria VV. Patients with cutaneous diphtheria present with deep, non-healing, and extremely painful ulcers. Source, ID hashtag, 1941, CDC, Centers for Disease Control and Prevention, CDC, licensed under public domain. Mumps is a highly contagious viral infection that is transmitted via airborne droplets. The incidence is now very low in the US because of the combined measles, mumps, and rubella, MMR, vaccine. The condition primarily affects children between the ages of 5 and 14. Classically, it manifests with parotitis, which initially occurs unilaterally, but typically progresses to involve both sides. The lateral cheek and jaw area usually show marked swelling and the ears may protrude. Other symptoms include low-grade fever, malaise, headache, and possible swelling of other salivary glands. The diagnosis of mumps is largely based on clinical findings. Many cases, however, present with nonspecific features and are not easily recognizable as mumps. If possible, diagnosis should be confirmed with laboratory tests. Treatment is symptomatic. Rare complications include orchitis, aseptic meningitis, hearing loss, and pancreatitis. Mumps is a self-limiting disease, followed by lifelong immunity. The prognosis in uncomplicated cases is very good. The mumps vaccine is a combination vaccine that protects against measles, mumps, and rubella, MMR vaccine. The MMRV vaccine also protects against varicella. Immunization is recommended for all children, in addition to adults without evidence of immunity to measles, mumps, and/or rubella. Immunization offers the best protection against future exposure. WA. OAO. Epidemiology. Scent incidence drastically declined in the U.S. since the introduction of the MMR vaccine. L2 peak age, 5 to 14 years of age. Sex, O equals $for parotitis. However, males are 3 times more likely to have CNS complications. 3 Scent risk factors. See risk factors for measles, mumps, and/or rubella. Epidemiological data refers to the U.S., unless otherwise specified. FO. OES. Etiology. Scent pathogen, mumps virus from the Paramyxoviridae family plus transmission 41EO. Humans are the sole host and the virus is transmitted via airborne droplets. Copyright direct contact with contaminated saliva or respiratory secretions. Copyright contaminated fomites. Scent infectivity, SL4. Copyright highly infectious. Affected individuals are contagious 3 days before and up to 9 days after disease onset, when the parotid gland becomes swollen. Asymptomatic cases are also contagious. AES. Pathophysiology. Nasopharyngeal entry. Replication of the virus in the mucous membranes and lymph nodes equals viremia and secondary infection of the salivary glands, particularly the parotid gland, further dissemination possible, lacrimal, thyroid, and mammary glands, pancreas, testes, ovaries, CNS. WA. CE. Clinical features. Scent incubation period, 16 to 18 days. 6. Scent prodrome. Copyright duration, 3 to 4 days. Symptoms, low-grade fever, malaise, headache. Classic course, inflammation of the salivary glands, particularly parotitis. 7. Duration of parotitis, at least 2 days, may persist 10 days. EO symptoms equals may initially present with local tenderness, pain, and earache equals unilateral swelling of the salivary gland, lateral cheek and jaw area, during the course of disease, Both salivary glands are usually swollen. 2. Equals redness in the area of the parotid duct. Back collapse, fine text outline. Equals fossibly protruding eels, a flat, red rash that begins on the face and disseminates to the rest of the body can occur. Copyright chronic courses are rare. Sent subclinical presentation 6.0 nonspecific or predominantly respiratory symptoms o asymptomatic, in 15 to 20% of cases. 4. OS. OSRU. Diagnostics. Laboratory tests, if available, should be conducted to confirm the suspected cases, especially if presentation is atypical or there is a mumps outbreak. It held for scent pathogen detection o real-time reverse transcriptase PCR, RRT-PCR, on serum or buccal or oral swab. Copyright viral culture, example on CSF, urine, or saliva. Serology, positive serum IgM suggests recent infection and confirms the diagnosis. Scent relative lymphocytosis TCRP-TTESRT amylase. VA a 2 shared note. Differential diagnoses. Differential diagnosis of parotid swelling V7 acute purulent sialolithiasis, salivary features mumps latent to sialadenosis, sialosis, stones, tumors of the salivary glands. Parotid usually bilateral, usually unilateral, usually bilateral * partial swelling of usually unilateral swelling yen the gland M. Pain scent painful scent usually painless plus painful while eating usually painless. Fever scent present plus present absent usually absent may be present. Scent non-inflammatory, non-neoplastic swelling * possible redness of other plus possible pus of the parotid glands * sudden pain while scent possible malignant symptoms of infiltrated findings. 9. Discharge systemic causes, example alcoholism, diabetes, eating structures, example facial palsy, scent protruding ears mellitus, equals I. Scent differential diagnosis of orchitis, epididymitis, testicular torsion. Scent differential diagnosis of aseptic meningitis, see meningitis. The differential diagnoses listed here are not exhaustive. Go your notes. OCES. Treatment. Mumps is usually self-limited with a good prognosis, unless complications arise. Treatment is mainly supportive care. Medication for pain and fever, example acetaminophen, scent bed rest, scent adequate fluid intake, avoidance of acidic foods and drinks, ice packs to soothe parotitis plus isolate the patient. All patients, isolate for 5 days from the development of parotid swelling. Copyright hospitalized patients, initiate droplet precautions. Copyright mumps is a nationally notifiable disease, report all cases to the appropriate health departments. 5. Back collapse, fine text outline. Treatment. Mumps is usually self-limited with a good prognosis, unless complications arise. Treatment is mainly supportive care. Scent medication for pain and fever, example acetaminophen, scent bed rest, adequate fluid intake, avoidance of acidic foods and drinks, ice packs to soothe parotitis plus isolate the patient. 6. Copyright all patients, isolate for 5 days from the development of parotid swelling. Copyright hospitalized patients, initiate droplet precautions. Mumps is a nationally notifiable disease, report all cases to the appropriate health departments. 5. OCs. Complications. Orchitis. Scent definition, inflammation of the testis plus epidemiology, most common complication of mumps in postpubertal male individuals, 20 to 30% in unvaccinated postpubertal and 6 to 7% in vaccinated males. Scent clinical features: sudden onset of fever, nausea, vomiting. Copyright swollen and tender affected testicle, primarily unilateral, although bilateral in 15% of cases scent complications, may lead to atrophy and, in rare cases, hypofertility. Other complications, 4. Plus aseptic meningitis, 1 to 10% of cases predominantly mild course and usually no permanent sequelae. Scent encephalitis. Q. The men of the Panamanian Orchestra know how to throw a good party. Meningitis, pancreatitis, orchitis, and parotitis are the most important complications of mumps. We list the most important complications. The selection is not exhaustive. L or prevention. Vaccination 1-1-11-12. Administer a live attenuated mumps vaccine, i.e., MMR vaccine, MMRV vaccine, according to the ACIP immunization schedule. See the following: scent immunizations for measles, mumps, and rubella. ACIP immunization schedule. Contraindications to live vaccines, example pregnancy, immunocompromise, exposure control, 131I8. Asterisk confirmed case of mumps, isolate for 5 days from the development of parotid swelling. Exposed contacts without evidence of immunity to mumps, measles, and/or rubella, copyright quarantine starting from the 10-day after first exposure through to the 25-day after the last exposure. 3IL60 administer a mumps vaccine. Back collapse. Fine text outline. Sialadenitis and lymphadenopathy in mumps VV. The boy has roughly symmetrical, significant swelling of the neck, which is caused by swollen salivary glands and lymph nodes. The parotid gland is also typically swollen in mumps and can result in protruding ears. The left ear of the boy in this image shows slight protrusion. Source: ID #1861, CDC/Patricia Smith, Barbara Rice, Centers for Disease Control and Prevention, CDC, licensed under public domain. Neck swelling in mumps VV. There is symmetrical, imposing, significant swelling of the neck. This is due to swelling of the salivary glands and lymph nodes. In mumps. Source: ID #3168, CDC/Heinz F. Eichenwald, MD, Centers for Disease Control and Prevention, CDC, licensed under public domain. X. Common cold. A common cold is a nonspecific, acute, self-limited infection of the upper respiratory tract. It more commonly occurs in children and most infections occur during fall and winter. Common cold is a viral infection of the upper respiratory tract, causing rhinorrhea, nasal obstruction, and coughing. Diagnosis is usually clinical and treatment is mostly symptomatic. The most important complication of common cold is secondary bacterial infection, example pneumonia. And definition: a nonspecific, acute, self-limited viral infection of the upper respiratory tract. 1. OOORIEEE. Epidemiology. Leading cause of ambulatory care visits in the U.S. U1*, more common in children. 2*, seasonal pattern, most infections occur during the fall and winter. Epidemiological data refers to the U.S., unless otherwise specified. OMC re equals Fu1 note. Etiology. Viral infection 1/4 rhinovirus, most common, copyright other viruses, parainfluenza, influenza, coronavirus, adenovirus, respiratory syncytial virus transmission, direct contact, aerosols, and respiratory droplets. VA and Q shared note. Pathophysiology. Infection of the nasal epithelium triggers the inflammatory response, which leads to 31L47 nasal blood flow and vascular permeability, rhinorrhea, congestion, and post-nasal drip. Foot concentration of leukocytes and their enzymes in the nasal mucosa. Yellow-green nasal discharge. Scent irritation of the upper airways, sneezing and coughing. Your notes OAO. Clinical features. Scent main symptoms, rhinorrhea, nasal obstruction, sneezing, and coughing. 3L40 symptoms typically resolve after 1 week. Copyright cough may persist for 3 weeks. Asterisk other symptoms, sore throat, hoarseness, fever, uncommon, malaise, and fatigue. Physical examination finding lungs are usually clear to auscultation. Copyright typically no prominent localizing features, example facial pressure. WAOO. VN2ST. Clinical features. Scent main symptoms, rhinorrhea, nasal obstruction, sneezing, and coughing. SL40 symptoms typically resolve after 1 week. Copyright cough may persist for 3 weeks. Other symptoms, sore throat, hoarseness, fever, uncommon, malaise, and fatigue. Physical examination finding copyright lungs are usually clear to auscultation. Copyright typically no prominent localizing features, example facial pressure. Your notes a shared note. Diagnostics. Asterisk clinical diagnosis / IL4L scent laboratory studies, viral detection techniques, example antigen detection, PCR assays, and imaging are not routinely recommended. 1. %7 Foo shared note. Differential diagnoses. Allergic rhinitis, bacterial tonsillopharyngitis, infectious mononucleosis, influenza, COVID-19, sinusitis, tonsillitis, laryngitis. See also URTIs. The differential diagnoses listed here are not exhaustive. OECA 2 shared notes. Treatment. Symptomatic treatment, hydration, analgesics, example acetaminophen, NSAIDs, and oral and/or topical decongestants, example oxymetazoline, chlorpheniramine. 31L4E antibiotics are not indicated unless a secondary bacterial infection is suspected. 7 CES. Complications. Extension of the viral infection to surrounding structures, example ear, sinuses, larynx, secondary bacterial infection, i.e., pneumonia, mostly due to S. pneumoniae, H. influenza, M. catarrhalis, S. aureus, C. scent exacerbation of asthma and/or chronic bronchitis. We list the most important complications. The selection is not exhaustive. AOE. Sources. Last updated January 3, 2023. Acute bronchitis. Acute bronchitis is a lower respiratory tract infection, LRT, characterized by inflammation of the bronchi. It often follows an upper respiratory tract infection, URTI, and, in more than 90% of cases, the cause is viral. Acute bronchitis may manifest with cough, runny nose, headache, and malaise. The cough may persist for 2 to 3 weeks and is usually self-limiting. It is often productive and associated with chest pain. The diagnosis is made on the basis of clinical symptoms and auscultation findings. Further diagnostic testing is not routinely necessary. Important differential diagnoses to consider include asthma, acute exacerbation of COPD, and pneumonia. Management of acute bronchitis consists of adequate hydration and symptomatic relief. Treatment with antibiotics is not generally indicated. While chronic bronchitis also involves inflammation of the bronchi, its clinical picture and management are very different. See COPD. O. CES. Etiology. Viral, 90% of cases. O. Influenza A and B. O. Parainfluenza. Copyright adenovirus. O. RSV. Copyright rhinovirus. Copyright coronavirus. Bacterial scent. Environmental. QB. The etiology of acute bronchitis is viral in 90% of cases. References, L223. OO. CE. Clinical features. Asterisk signs and symptoms for copyright cough equals coughing bouts with or without sputum production, 15 equals typically resolves within 2 to 3 weeks, 6. Symptoms of preceding or simultaneous URT equals runny nose and sore throat equals headache malaise myalgias, copyright chest pain mild dyspnea fever, uncommon after first few days, 1 vital signs are usually normal. Copyright LLLs, plus auscultation findings 4. May be clear copyright ronchi wheezing fine crackles, rarely, 110. WA. CE. Diagnostics. Approach. Acute bronchitis is a clinical diagnosis based on typical clinical features and auscultation findings. Diagnostic studies are usually only required to 6. Rule out alternative diagnoses, example CBC, CXR, nasopharyngeal swab. Evaluate for complications, example pneumonia, ECODE, in patients with equals atypical clinical findings. Back collapse. Find text outline. Evaluate for complications, example pneumonia, ECODE, in patients with atypical clinical findings. Increased risk of bacterial infection, example smokers, patients 75 years old, patients with lung disease. Routine laboratory and imaging studies for *CBC, may show mild leukocytosis. 1 chest X-ray. Copyright indication, to evaluate for pneumonia in patients with abnormal examination findings or atypical clinical presentation, is copyright findings, often normal or nonspecific, example peribronchial thickening, 1I12I. Further diagnostic testing for consider targeted testing for alternate diagnoses or complications in patients with the following. High fevers, consider a diagnosis of pneumonia or influenza, see diagnostics in influenza. Prominent coughing fits, consider pertussis testing. 3+ worsening symptoms or cough lasting 3 weeks, consider adding sputum culture, spirometry, or other laboratory studies, example CRP, depending on clinical suspicion. Recurrent episodes of bronchitis, consider diagnostic testing for asthma or COPD. Copyright in otherwise healthy patients with typical clinical findings and normal vital signs, acute bronchitis does not require diagnostic testing. DB. Differential diagnoses. Scent bronchiolitis for cough persisting. 05 shared note. Treatment. Acute bronchitis is generally self-limiting. Treatment is focused on the relief of symptoms. OLL. Supportive management. Recommend rest and adequate hydration. Copyright advise patients to avoid lung irritants, example smoke, incense, 4LL15. Re-evaluate if any of the following, equals worsening typical symptoms, example fever, dyspnea, cough, equals new worrisome symptom, example hemoptysis, equals persistent cough, lasting 3 weeks, plus symptomatic treatment, ILL. Copyright analgesics, NSAIDs or acetaminophen 1, 6. Copyright other symptom relievers, not routinely recommended 1, 17. Equals antitussives, 4 equals expectorants bronchodilators 1 8 steroids 4 antihistamines OC treatment in cough. For more details on symptomatic treatment plus antibiotic treatment, IL 726, generally not recommended. Copyright only consider antibiotics in patients with suspected bacterial complications or an alternate diagnosis, example pneumonia, pertussis, acute exacerbation of COPD. Copyright treatment is focused on symptomatic management. Antibiotics, cough and cold medications, bronchodilators, and steroids have no proven efficacy in uncomplicated acute bronchitis. Back collapse. Find text outline. EEEEEERGREENN, Piers Bainey CBAEIEEOE. WA2 Mana. Treatment. Acute bronchitis is generally self-limiting. Treatment is focused on the relief of symptoms. 6LL4 supportive management. Copyright recommend rest and adequate hydration. Copyright advise patients to avoid lung irritants, example smoke, incense. 1415 re-evaluate if any of the following, worsening typical symptoms, example fever, dyspnea, cough, new worrisome symptom, example hemoptysis, equals persistent cough, lasting 3 weeks, plus symptomatic treatment / 4LL. Copyright analgesics, NSAIDs or acetaminophen 1,61 other symptom relievers, not routinely recommended _ 17 antitussives 1,4, equals expectorants bronchodilators 118 equals steroids 1 antihistamines, OC treatment in cough. For more details on symptomatic treatment plus antibiotic treatment / IL-7 IL-6 generally not recommended. Copyright only consider antibiotics in patients with suspected bacterial complications or an alternate diagnosis, example pneumonia, pertussis, acute exacerbation of COPD. Copyright treatment is focused on symptomatic management. Antibiotics, cough and cold medications, bronchodilators, and steroids have no proven efficacy in uncomplicated acute bronchitis. GU2. Complications. Respiratory failure. Secondary bacterial infections, especially pneumonia, plus protracted bacterial bronchitis. Degree chronic bacterial infection that causes a productive cough. Copyright clinical diagnosis requires all of the following, equals daily cough for 4 weeks equals resolution within 2 to 4 weeks of antibiotic treatment equals absence of alternate diagnosis. We list the most important complications. The selection is not exhaustive. VA Re, OO Ed Note. Prognosis. Generally self-limiting risk factors for complications, advanced age, immunocompromise, pre-existing lung conditions. OCE. Tips and links. Sources. Last updated October 4, 2022. Back collapse. Fine text outline. Overlay. Peribronchial cuffing. X-ray chest, AP view, small, thick-walled, cuffed, bronchi viewed end-on are visible as rounded lucencies outlined by opaque walls, examples highlighted by arrows. This appearance is sometimes termed the donut sign. Peribronchial cuffing may be seen when fluid, inflammation, or infection involves the bronchial wall or surrounding tissues. Source, mild perihilar airway cuffing by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 4.0. Modifications, image cropped. Bronchiolitis is a lower respiratory tract infection, LRT, characterized by inflammation of the bronchioles in children. Hospitalization for additional management, example for fluids, respiratory support, nutritional support, and close monitoring of respiratory status. Bronchiolitis prevention includes RSV vaccination of pregnant individuals in the 3rd trimester and routine passive immunization of all infants. OE. Epidemiology. SENT primarily affects children. FO, EA notes EE1 no. Etiology. SENT most common, respiratory syncytial virus, RSV, a paramyxovirus less common. Copyright parainfluenza virus. Copyright influenza virus. OE adenovirus. Copyright rhinovirus. Copyright coronavirus. EO metapneumovirus. OS. Clinical features. Plus initially, URTI symptoms, example copious rhinorrhea, low-grade fever, cough. L2* followed by LRTI symptoms, 1 L2I degree crackles, wheezes, and / or rhonchi on auscultation. O severe illness, respiratory distress, usually occurs in children. DS. Diagnostics. General principles, L4L. V. Back collapse. A. Find text. O. Outline. General principles, L4L. Scent bronchiolitis is a clinical diagnosis based on the patient's age. Laboratory studies, LL2I. Scent respiratory viral panel copyright findings. Equals 60 to 75% are positive for RSV equals co-infections are present in up to 1/3 of those tested chest X-ray in bronchiolitis. Scent potential findings degree normal copyright nonspecific findings, example peribronchial thickening, hyperinflation of the lungs, interstitial infiltrates, atelectasis OE superimposed complications, example pneumonia. Management. Approach Hill 7. Scent determine the need for immediate respiratory support. Eohypoxemia, oxygen therapy via nasal cannula or refractory hypoxemia, signs of respiratory distress, respiratory failure, intubation, CPAP, or high-flow nasal cannula start supportive measures including adequate hydration, relief of nasal congestion and/or obstruction, and monitoring. Copyright avoid bronchodilators, epinephrine, corticosteroids, antibiotics, and chest physiotherapy unless there are comorbidities, example asthma, croup, cystic fibrosis, acute otitis media. Admission criteria for bronchiolitis I-728. Scent unwell appearance, lethargy moderate to severe signs of respiratory distress, including significantly elevated respiratory rate for age, scent ongoing respiratory support required scent need for supplemental hydration -1 scent history of apnea scent consider if, copyright risk factors for severe bronchiolitis are present copyright supportive care at home is not feasible 1/8. Inpatient management of bronchiolitis 17. Respiratory support. Scent frequently monitor routine vital signs including O2 saturation adjust short-term oxygen therapy as needed. Plus provide regular external nasal suction. 2. Caloric and fluid support. Ensure patients receive the recommended daily intake for their age. Encourage normal oral feeds, example with breast milk, formula, regular diet for age, as tolerated. Copyright respiratory distress increases caloric and fluid requirements but also increases the risk for aspiration during oral feeds. Nutritional and fluid support via a feeding tube, orogastric or nasogastric, and/or intravenously is often necessary. P.E. Back collapse find text outline. Differential diagnoses 2. No URTI symptoms copyright congenital heart disease copyright foreign body aspiration copyright congenital airway abnormalities, example vascular ring, plus wheeze copyright polyphonic asthma equals congestive heart failure secondary to congenital heart disease I copyright monophonic, foreign body aspiration OC also wheezing in children. Asymmetric crackles, bacterial or viral pneumonia cough O pneumonia o pertussis copyright see also differential diagnosis of acute cough and bronchitis. Neonatal fever, neonatal sepsis the differential diagnoses listed here are not exhaustive. OYOES. Complications. Apnea scent respiratory failure scent pneumonia scent dehydration scent otitis media we list the most important complications. The selection is not exhaustive. Prognosis. With timely diagnosis and adequate treatment, the prognosis is good. Scent bronchiolitis in infancy is associated with an increased risk of developing asthma. FO, TOA 6 shared N. Prevention. Administration of respiratory syncytial virus vaccine to pregnant individuals minimizes the risk of bronchiolitis in young infants. 14. ZYOES. Related 1-minute telegram. Sent 1-minute telegram 70-2023-1/3. The efficacy of the RSV vaccine is nothing to sneeze at. Interested in the newest medical research, distilled down to just 1 minute? Sign up for the 1-minute telegram in tips and links below. Oh. Tips and links. Sources. Back collapse. Find text outline. Urobronchiolitis, 1/2. Overlay. Viral bronchiolitis. X-ray chest, PA view, of a child with respiratory syncytial virus, RSV, extensive peribronchial thickening, examples indicated by green circles, has caused the hilar and perihilar regions to appear prominent. Additionally, the lung volumes are large as a result of air trapping. One of the radiographic features suggestive of hyperinflation is the visualization of more than 6 anterior or 10 posterior ribs above the hemidiaphragm, indicated by numbers. Source: RSV by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Modifications: removal of arrows. Urobronchiolitis, 1/2. Copyright. Overlay. Viral bronchiolitis. X-ray chest, PA view, of a child with respiratory syncytial virus, RSV, extensive peribronchial thickening, examples indicated by green circles, has caused the hilar and perihilar regions to appear prominent. Additionally, the lung volumes are large as a result of air trapping. One of the radiographic features suggestive of hyperinflation is the visualization of more than 6 anterior or 10 posterior ribs above the hemidiaphragm, indicated by numbers. Source: RSV by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Modifications: removal of arrows. Bronchiolitis, 2/2. Overlay. Bilateral hyperinflation and right lung consolidation VV. X-ray chest, AP view, of a child with viral bronchiolitis and focal pneumonia. Bilateral perihilar peribronchial thickening, examples of bronchi indicated by green lines, is accompanied by hyperinflation with diaphragmatic depression, indicated by white lines and arrow. In the right lung, a superimposed area of consolidation from pneumonia, red overlay, is associated with atelectasis and ipsilateral mediastinal shift, indicated by black arrow. Black outline, trachea, white dashed line, physiological position of left hemidiaphragm. Source: Fig 2, in, lung ultrasound for the diagnosis of pneumonia in children with acute bronchiolitis by Biaggi C., Pierantoni L., Baldazzi M., Greco L., Dormier, Dondi A., Faldelagi, ETAL, BMC Pulmonary Medicine, licensed under CC by 4.0. Modifications: image was cropped and letter A was removed. Bronchiolitis, 2/2. Overlay. Bilateral hyperinflation and right lung consolidation VV. X-ray chest, AP view, of a child with viral bronchiolitis and focal pneumonia. Bilateral perihilar peribronchial thickening, examples of bronchi indicated by green lines, is accompanied by hyperinflation with diaphragmatic depression, indicated by white lines and arrow. In the right lung, a superimposed area of consolidation from pneumonia, red overlay, is associated with atelectasis and ipsilateral mediastinal shift, indicated by black arrow. Black outline, trachea, white dashed line, physiological position of left hemidiaphragm. Source: Fig 2, in, lung ultrasound for the diagnosis of pneumonia in children with acute bronchiolitis by Biaggi C., Pierantoni L., Baldazzi M., Greco L., Dormier, Dondi A., Faldelagi, ETAL, BMC Pulmonary Medicine, licensed under CC by 4.0. Modifications: image was cropped and letter A was removed. Pertussis. Pertussis, or whooping cough, is a highly infectious disease of the respiratory tract caused by the gram-negative bacterium Bordetella pertussis. This disease spreads via droplet transmission, and to a lesser extent via fomites, and most commonly occurs in children. Typically, pertussis manifests in 3 stages, with the second and third stages characterized by intense paroxysmal coughing that is followed by a distinctive whooping sound on inhalation and, in some cases, vomiting. Young infants may not develop the typical cough, and often present with apnea and cyanosis instead. Patients who meet the suspected case definition for pertussis should be started on antibiotic therapy for pertussis, and confirmatory laboratory studies, usually PCR or culture, should be conducted. Post-exposure prophylaxis for pertussis is recommended for all close contacts and high-risk individuals, example infants, regardless of immunization status. Pertussis immunization is part of the routine. Immunization schedule. While immunization reduces the severity of illness, it does not provide full immunity. WA. OE. Epidemiology. Pertussis is typically a childhood disease, particularly children aged. AOE. Etiology. Scent pathogen. Bordetella pertussis is a gram-negative, obligate aerobic cocobacillus. Scent transmission, droplet transmission, fomite transmission. Tal scent infectivity. Copyright without antibiotic treatment, 4 to 6 weeks. With treatment, 5 days. Copyright highly virulent, scent incubation period, on average 7 to 10 days, range 4 to 21 days. References: IL-6. Y. CE. Pathophysiology. Proliferation of Bordetella pertussis on ciliated epithelial cells of the respiratory mucosa. Production of virulence factors, example tracheal cytotoxin, paralysis of respiratory epithelium cilia and inflammation. Secretion of inflammatory exudate into respiratory tract. Compromise of small airways. Cough, pneumonia, cyanosis. 7. Bordetella pertussis produces pertussis toxin ADP. Ribosylation of the A subunit of GJ protein. Inhibition of GI protein adenylate cyclase disinhibition. CAMP accumulation. Impaired cell signaling pathways. 8. Pertussis toxin is responsible for most of the systemic manifestations associated with whooping cough, example hypoglycemia, lymphocytosis, modulation of host immune response. Neither vaccination nor actual infection confers complete or lifelong immunity. WA. OE. Clinical features. Pertussis classically has 3 stages: catarrhal, paroxysmal, and convalescent. Symptoms may vary, however, based on age and immunization status, vaccinated individuals tending to have a milder illness without characteristic whooping. TLT catarrhal stage, 1 to 2 weeks, degree. Back collapse. Fine text outline. Catarrhal stage, 1 to 2 weeks. Nonspecific symptoms similar to an upper respiratory infection, e.g., degree mild cough or watery nasal discharge or rarely low-grade fever. Copyright possibly conjunctivitis. Patients are highly infectious. Paroxysmal stage, 2 to 6 weeks, *1. Intense paroxysmal coughing, often occurring at night, copyright followed by a deep and loud inhalation or high-pitched whooping sound accompanied by struggling for breath, gagging, and tongue protrusion. MNA copyright possibly accompanied by cyanosis. Copyright increases in frequency and severity throughout the stage. Copyright followed by the expulsion of phlegm or post-tussive vomiting, risk of dehydration, potential bleeding of the conjunctiva, petechiae, and venous congestion. 1+ infants. Convalescent stage, weeks to months. Scent progressive reduction of symptoms. Coughing attacks may persist over several weeks before resolving. Scent patients have an increased susceptibility to respiratory infections. Copyright. The typical pattern of paroxysmal cough with whooping manifests mainly in unvaccinated children. Infants. Diagnostics. Approach, 1I10. Sent perform confirmatory studies for any patient that meets the suspected case definition for pertussis. 9 Sent for infants 20,000 cells/UL is a classic diagnostic finding and suggests a poor prognosis. 119 suspected case definition for pertussis, 12/11/213. Cough is present for any duration, with a low threshold for suspicion in infants, with equals one of the following: 3 IL9 paroxysmal coughing sent whooping on inspiration post-tussive vomiting apnea, 0, 2 11 known contact with confirmed case sent living in an area with a pertussis outbreak. The presence of fever suggests an alternative diagnosis, see differential diagnoses of pertussis. 3 IL9. Confirmatory studies. PCRRM116. Plus preferred test, degree copyright high sensitivity or rapid results. Back collapse fine text outline. Preferred test copyright high sensitivity copyright rapid results copyright unaffected by antibiotic therapy or previous vaccination 1 cent specimen collection preferred, nasopharyngeal swab alternative, saline nasopharyngeal ASPI rate. Bacterial culture 11 if 1 IL6. Asterisk gold standard, degree cent specimen collection method preferred, nasopharyngeal swab alternative, saline nasopharyngeal ASPI rate. OFE, Cs. Differential diagnoses. Sent Bordetella parapertussis infection for respiratory syncytial virus bronchiolitis pneumonia, particularly due to chlamydia trachomatis or mycoplasma pneumoniae sent croup, laryngotracheobronchitis, sent foreign body aspiration. The differential diagnoses listed here are not exhaustive. Treatment. Approach L. Sent start antibiotic therapy in suspected pertussis without waiting for diagnostic confirmation. L. 9-10 assess patients for admission criteria for pertussis and admit if present. Plus provide supportive care, e.g., 171 copyright respiratory support 116 frequent suctioning management of dehydration and hypovolemia copyright nutritional support initiate measures to prevent onward transmission of pertussis. Symptomatic treatment of cough, example with corticosteroids, antihistamines, albuterol, is not recommended, as there is no evidence symptomatic treatments reduce copyright cough or duration of hospitalization. 8LL9. Pertussis is a nationally notifiable disease. 9. Antibiotic therapy for pertussis IL9-LL6. Sent first line, macrolides preferred, azithromycin L2LO alternative equals erythromycin equals clarithromycin allergy/intolerance to macrolides, consider trimethoprim/sulfamethoxazole. Antibiotic therapy decreases transmission of pertussis but may not improve the duration or severity of symptoms, especially if started at a later clinical stage. 11.1. Or complications. C equals 2a. Back collapse fine text outline. Complications. Infection, otitis media respiratory Bordetella pertussis pneumonia hemoptysis, atelectasis, pneumothorax FF sent cardiac, pulmonary hypertension 6 neurologic, seizures, encephalopathy with possible permanent damage, plus sudden infant death, 6. References 211 I22123. We list the most important complications. The selection is not exhaustive. FO, BOD. Prognosis. Sent in children 6 months, usually good, lengthy convalescence, but full recovery in children. A. OOES. Prevention. Primary prevention of pertussis 241-251 I26. Sent vaccine, The acellular pertussis vaccine is available as a combination vaccine that also contains the diphtheria vaccine and tetanus vaccine. Scent choice of vaccine depends on age, copyright children. Uncontrolled or evolving neurological disorders, example Guillain-Barré syndrome or seizures. Arthus reaction. Copyright pertussis vaccination helps reduce severity, but infection can still occur because the immunity from vaccination, as well as infection, is short-lived and there has been a rise in vaccine antigen-deficient strains. 9. Ensure all close contacts, example family members, caregivers, of infants have received all the recommended age-appropriate pertussis vaccines, DTaP, Tdap. Old T6. Prevention of onward transmission of pertussis. Approach 16. Advise isolation precautions for pertussis for suspected or confirmed cases. Copyright for patients in the community. Advise avoiding contact with high-risk individuals, i.e., pregnant women, infants, and children. Children who attend daycare/school and staff in childcare and healthcare settings should remain at home. Copyright for hospitalized patients, place the patient in a side room with droplet precautions. 1. Perform contact tracing to determine who should be offered post-exposure prophylaxis for pertussis. Scent pertussis is a notifiable disease, ensure the state health department has been contacted. Post-exposure prophylaxis for pertussis, 6LL10. AQL. Collapse fine text outline. OE. Prevention. Primary prevention of pertussis 24 IL-251 I-26. Scent vaccine. The acellular pertussis vaccine is available as a combination vaccine that also contains the diphtheria vaccine and tetanus vaccine. Scent choice of vaccine depends on age, copyright children. Uncontrolled or evolving neurological disorders, example Guillain-Barré syndrome or seizures. Arthus reaction. Copyright pertussis vaccination helps reduce severity, but infection can still occur because the immunity from vaccination, as well as infection, is short-lived and there has been a rise in vaccine antigen-deficient strains. 9. Copyright ensure all close contacts, example family members, caregivers, of infants have received all the recommended age-appropriate pertussis vaccines, DTaP Tdap. Olild. Prevention of onward transmission of pertussis. Approach, 1L6. Advise isolation precautions for pertussis for suspected or confirmed cases. O for patients in the community. 6. Advise avoiding contact with high-risk individuals, i.e., pregnant women, infants, and children. Children who attend daycare/school and staff in childcare and healthcare settings should remain at home. Copyright for hospitalized patients, place the patient in a side room with droplet precautions. 111 Perform contact tracing to determine who should be offered post-exposure prophylaxis for pertussis. Scent pertussis is a notifiable disease, ensure the state health department has been contacted. Post-exposure prophylaxis for pertussis, 6LL10. Asterisk indications. Copyright all close contacts of an individual pertussis with, regardless of age and vaccination status. I copyright high-risk individuals with possible exposure, e.g., 1 equals infants equals pregnant women, third trimester, any individual who cares for infants and/or pregnant women, example healthcare or daycare workers, equals immunocompromised individuals. 9 equals individuals with chronic comorbidities, example respiratory conditions. 9 prophylactic measures. Administer antibiotic therapy for pertussis within 21 days of contact exposure. 9 Copyright advise isolation precautions for pertussis until 5 days of antibiotic therapy has been completed. Ensure all asymptomatic individuals are up to date with a cellular pertussis vaccine according to the ACIP immunization schedule. OS. 8 shared N. Tips and links. Sources. Last updated September 11, 2023 equals QL. Collapse find text outline. Pertussis, 1/1. Me percent E4EE. A asterisk SF, 6A degree asterisk F equals hashtag BA, RS4 PA S asterisk A. REOBUD, 4WT6 equals asterisk 4 SEA. Me, E734. Hashtag LouET send plus. EA2JF. Star. 4 euros is, backslash, AEAE degree para TDIP we see asterisk if dollar pa of, asterisk E asterisk OTEAEOP equals. Ori dollar SE nay, asterisk CTSE, re AFL plus asterisk percent SF4 a PS tot, pi, Rs underscore F4 ESAFDOE, RAE asterisk 5 EEE. RAD, cent EEE8 cent AL plus E cent at and E. Euro A equals. Bordella pertussis. Photomicrograph, gram stain, high magnification, of a culture specimen of Bordella pertussis. Numerous gram-negative coccobacilli are visible. Source, ID hashtag 2121, CDC, Centers for Disease Control and Prevention licensed under public domain. X pneumonia in children. Pneumonia, a common infection in children, is a respiratory illness characterized by inflammation of the alveolar space and/or the interstitial tissue of the lungs. The etiology is typically bacterial or viral, with respiratory syncytial virus, RSV, being the most common pathogen overall, particularly in those. Severity and etiology. The first step is to determine whether patients meet the admission criteria for pediatric CAP. All patients require a respiratory viral panel to help. Guide treatment. For children who meet admission criteria, additional diagnostic tests include imaging and blood studies. Empirical treatment consists of supportive measures, example respiratory support, antipyretics, antibiotics for suspected bacterial infection, and antivirals when available, example for influenza, COVID-19. The information in this article does not apply to infants. WA. CE. Etiology. See also pneumonia pathogens according to affected population. Viral 112. Respiratory syncytial virus, RSV most common overall pathogen, particularly in those. Bacterial, 1L2. Streptococcus pneumoniae Streptococcus pyogenes Staphylococcus aureus Haemophilus influenza Chlamydia trachomatis, in infants, 1/4. Chlamydia pneumoniae, in young children and adolescents, 5 Mycoplasma pneumoniae. OXO. Clinical features. Classic presentation. Asterisk similar to clinical features of pneumonia in adults, e.g., L2-IL6. Degree productive cough with yellow-green sputum tachypnea, dyspnea increased work of breathing fever lethargy chest pain crackles on auscultation reduced air entry. Degree may be preceded by symptoms of an upper respiratory tract infection asterisk additional features in children may include, IL-2-IL. E. Abdominal pain copyright difficulties feeding copyright grunting. Features of atypical pediatric pneumonia 17. Scent slow progression. Back collapse find text outline. Features of atypical pediatric pneumonia, 71. Scent slow progression mild disease E malaise sore throat E headache E low-grade fever widespread wheeze development of cough over 3 to 5 days, suggestive of Mycoplasma pneumonia. Differential diagnoses. Sent bronchiolitis E asthma/virus-induced wheeze. Sent croup E influenza. Sent tuberculosis. Sent see also causes of cough and differential diagnoses of acute wheezing in children. The differential diagnoses listed here are not exhaustive. WA. Fe. Sir. Management. Approach. Sent screen for admission criteria for pediatric CAP. Sent order diagnostic studies as indicated. Copyright all children, respiratory viral panel. Copyright children requiring admission, blood studies and imaging. Sent initiate recommended management, inpatient or outpatient. Sent provide supportive therapy for pneumonia, example respiratory support, antipyretics, as needed. Admission criteria for pediatric CAP, 71. Hypoxemia. All patients require a respiratory viral panel. Further studies are usually reserved for patients with refractory disease or those who require hospitalization. Laboratory studies. A respiratory viral panel O helps determine if antibiotics or targeted antiviral therapy is appropriate. Copyright for findings. C. Etiology of pediatric CAP E blood tests OCBCFJ. Copyright CRP/ESRCN, copyright procalcitonin, 1. Copyright blood cultures. Sent sputum samples are not routinely performed because of copyright difficulties obtaining a sample in younger children. Copyright poor yield. Imaging. Asterisk chest X-ray, AP and lateral, indications include hypoxemia, signs of respiratory distress, or refractory disease. O findings, see X-ray findings in pneumonia. Pneumonia. V. Back collapse. A. Find text. O. Outline. X. Pneumonia in children. Additional studies. Sent bronchoscopy and thoracentesis are among the additional studies that may be performed in severe or complicated disease. Sent for further information, see Advanced Diagnostics for Pneumonia. Inpatient Management, 2-7. Sent start supportive therapy for pneumonia including respiratory support. Sent start pathogen-directed management. EOC management of bacterial pneumonia in children. OC management of viral pneumonia in children. Sent tailor treatment to culture results when available. Irregularly reassess patients for complications of pediatric CAP, treat if present. Outpatient management, 1-71. Sent initiate supportive therapy for pneumonia. A sent start pathogen-directed management. OC management of bacterial pneumonia in children. OC management of viral pneumonia in children. Sent educate caregivers on return precautions and arrange for a follow-up in 48 to 72 hours. Sent outpatient oral antibiotic therapy is typically given for a maximum of 7 days. FL. Copyright for preschool-aged children, 2 to 5 years old. Antibiotics are not routinely recommended, as viruses are the most common cause. VA. OXO. Lee management of bacterial pneumonia in children. Overview, 2-7. Sent start empiric antibiotics for all patients with suspected bacterial pneumonia. Copyright patients requiring hospitalization, usually intravenous antibiotic therapy i.e. outpatients, oral antibiotic therapy. Sent if features of atypical pediatric pneumonia are present, cover for atypical pathogens. Sent features of sepsis, initiate treatment of sepsis. Provide supportive treatment for pneumonia. Tailor treatment to culture results if possible. Asterisk switch patients on 4 antibiotics to oral therapy when TNO symptoms improve. O patients can tolerate oral intake. Sent regularly reassess patients, and escalate care as needed. Add, if typical and atypical CAP cannot be distinguished from each other, combine a beta-lactam and a macrolide for empiric therapy. 7. Empiric antibiotic therapy for pediatric CAP. Intravenous antibiotic therapy. Empiric intravenous antibiotics for CAP in children V7 suspected etiology fully immunized sent first line EO ampicillin E or penicillin G co-sent alternative typical bacteria O at cefixlone copyright or cefotaxime asterisk suspected MRSA, add one of the following. Copyright vancomycin E or clindamycin. Sent first line, azithromycin alternative atypical bacteria degree erythromycin. Back collapse. Not fully immunized. Sent first line degree ceftriaxone degree or cefotaxime asterisk suspected MRSA, add one of the following E vancomycin E or clindamycin. AO. Find text outline. Sent first line, azithromycin alternative atypical bacteria copyright erythromycin copyright or doxycycline, children to 9 years of age only. 11. Add, transition to oral antibiotics when patients are clinically improving and can tolerate oral fluids including medications. 0. Oral antibiotics for pediatric pneumonia. Empiric oral antibiotics for CAP in children V7 first line, amoxicillin typical bacteria alternative, amoxicillin/clavulinate. First line, azithromycin alternatives atypical bacteria copyright clarithromycin copyright or erythromycin copyright or doxycycline, children equals 9 years of age only. 1. Add, outpatient oral antibiotic therapy is typically given for a maximum of 7 days. 0. WACES. ES management of viral pneumonia in children. Viral pneumonia is the most common cause of CAP in children. Provide supportive therapy for pneumonia. Sent offer antiviral therapy when indicated. AL regularly reassess, until recovered, for the development of bacterial superinfection. 7. Management of influenza pneumonia in children. Sent specific antiviral therapy for influenza is available and licensed for pediatric use. Sent start antivirals in children with copyright confirmed influenza infection O moderate to severe CAP likely due to influenza. Sent for further information, see treatment of influenza. Add, start antivirals immediately in patients with moderate to severe CAP and suspected influenza, even before confirming influenza infection. 1. Management of COVID-19 pneumonia in children. Depending on the severity, antiviral therapy, example with remdesivir, may be recommended. See COVID-19 in children for more information. Oh. And complications.
It's never enough.
Plus
So
pulmonary complications 71 O parapneumonic effusion O emphysema E lung abscess copyright multilobar heart disease E O pneumothorax copyright bronchopleural fistula sent dissemination of infection causing 7 O sepsis copyright septic arthritis copyright osteomyelitis copyright meningitis copyright cardiac involvement endocarditis or pericarditis OECNS abscess CNA. Back collapse. A. Find text. O. Outline. X pneumonia in children. Lee management of viral pneumonia in children. Viral pneumonia is the most common cause of CAP in children. Provide supportive therapy for pneumonia. Asterisk offer antiviral therapy when indicated. Asterisk regularly reassess, until recovered, for the development of bacterial superinfection. 7. Management of influenza pneumonia in children. Sent specific antiviral therapy for influenza is available and licensed for pediatric use. Sent start antivirals in children with copyright confirmed influenza infection O moderate to severe CAP likely due to influenza 1 sent for further information, see treatment of influenza. Add, start antivirals immediately in patients with moderate to severe CAP and suspected influenza, even before confirming influenza infection. M7. Management of COVID-19 pneumonia in children. Depending on the severity, antiviral therapy, example with remdesivir, may be recommended. See COVID-19 in children for more information. WA. OES. Complications. Pulmonary complications 7 parapneumonic effusion O empyema O lung abscess O multilobar disease O pneumothorax copyright bronchopleural fistula * dissemination of infection, causing, 7. O sepsis copyright septic arthritis copyright osteomyelitis O meningitis copyright cardiac involvement, endocarditis or pericarditis, O CNS abscess. We list the most important complications. The selection is not exhaustive. OOXE. Prevention. Immunizations, 1. * during each pregnancy, advise mothers to get a booster for copyright influenza, diphtheria and tetanus toxoids, acellular pertussis and ensure children receive recommended immunizations. Copyright pneumococcal vaccines, copyright HIV vaccine, copyright pertussis vaccine, copyright annual influenza vaccine, copyright COVID-19 vaccine. Back collapse. Find text outline. Uropneumonia in children, 1/1. Tactile fremitus VV. Findings in pneumonia, left, and pleural effusion, right. Place hands on each side of the thorax. Ask the patient to say "toi vote" repeatedly. 99 is also commonly used. And feel for vibrations transmitted throughout the chest wall. Vibrations are typically decreased over fluid-filled areas, blue area, and increased over areas of dense consolidation, yellow area. Copyright unlocked. Pneumonia in children, 1/1. Bilateral hyperinflation and right lung consolidation. X-ray chest, EP2, of a child with viral bronchiolitis and focal pneumonia. Bilateral perihilar peribronchial thickening. Examples of bronchi indicated by green lines. Is accompanied by hyperinflation with diaphragmatic depression, indicated by white lines and arrows. In the right lung, a superimposed area of consolidation from pneumonia, red overlay, is associated with athleticism and ipsilateral mediastinal shift, indicated by black arrow. Black outline, trachea, white dashed line, etiological position of left hemidiaphragm source. Thing 2, lung ultrasound for the diagnosis of pneumonia in children with acute bronchiolitis by biaxis. Here Antony L. Baldazzi M. Greco L. Dormai, Dundee, Aldelici, DAL, DMC Pulmonary Medicine, licensed under CC 54.0. Modifications, image was cropped and letter A was removed. Pneumonia in children, 1/1. Bilateral hyperinflation and right lung consolidation. X-ray chest, AP view, of a child with viral bronchiolitis and focal pneumonia. Bilateral perihilar peribronchial thickening. Examples of bronchi indicated by green lines. Is accompanied by hyperinflation with diaphragmatic depression, indicated by white lines and arrows. In the right lung, a superimposed area of consolidation from pneumonia, red overlay, is associated with athleticism and ipsilateral mediastinal shift, indicated by black arrows. Black outline, trachea, white dashed line, physiological position of left hemidiaphragm source. Thing 2, lung ultrasound for the diagnosis of pneumonia in children with acute bronchiolitis by biaxis. Here Antony L. Baldazzi M. Greco L. Dormai, Dundee, Aldelici, CTAL, DMC Pulmonary Medicine, licensed under CC 54.0. Modifications, image was cropped and letter A was removed. X. Influenza. Influenza is a highly contagious viral infection that typically occurs during the winter months. It is caused by influenza A, B, and C viruses. There are various subtypes of influenza A viruses, which are classified based on their hemagglutinin, H, and neuraminidase, N, surface antigens. Influenza viruses frequently mutate, resulting in the emergence of new subtypes and strains. Symptomatic patients may present with sudden onset of high fever, headache, myalgias, arthralgias, non-productive cough, and malaise. Inflammatory markers are usually normal or slightly elevated. The diagnosis can often be established based on clinical presentation, but PCR testing may be used to confirm the diagnosis. Usually, symptoms are self-limited and supportive treatment is sufficient. However, antiviral therapy may be considered for patients with early or severe disease, especially in those at high risk for complications. Antiviral therapy may reduce the severity and shorten the duration of symptoms, and reduce the risk of developing complications. Rarely, patients may develop secondary bacterial pneumonia, most commonly caused by Staphylococcus aureus or Streptococcus pneumoniae. Hand hygiene, respiratory hygiene, and vaccination can help prevent the spread of influenza. FOOS. Epidemiology. Scent distribution, worldwide scent seasonal pattern, most infections occur during the fall and winter, influenza season. References L. Epidemiological data refers to the U.S., unless otherwise specified. WA. CE. Etiology. Pathogen, influenza virus A and B, and rarely influenza C, ORNA viruses of the family orthomyxoviruses O enveloped virus with a helical capsid copyright single-stranded, negative-stranded, segmented, 8 segments, copyright replication in cell nucleus sent person-to-person transmission, directly via respiratory droplets, sneezing or coughing, or indirectly through contact with contaminated surfaces. 1. References to VA. CE. Classification. Influenza A, example H1N1, O. The term influenza typically refers to influenza A infections. O viruses are classified into various subtypes based on glycoproteins of the viral envelope. Hemagglutinin, H1, H2, H3, and H5 most relevant equals neuraminidase, N1, N2, and N7 most relevant scent influenza B/C, less common, copyright significantly milder course copyright no evidence of genetic shift in influenza B risk of epidemics is much lower. References. CES. Pathophysiology. Replication cycle /ILSA 7. Back collapse find text outline. Pathophysiology. Replication cycle /ILSA 7. 1. Influenza viruses bind to the respiratory tract epithelium. 2. Viral hemagglutinin, H, binds sialic acid residues, neuraminic acid derivatives, on the host cell membrane. Virus fusion with the membrane entry into the cell. 3. The virus replicates in the nucleus of the cell. 4. The new virus particles travel to the cell membrane. Formation of a membrane bud around the virus particles, budding. 5. Viral neuraminidase, N, cleaves the neuraminic acid virions exit the cell. 6. Host cell dies. Cellular breakdown triggers a strong immune response. Genetic mutations. 81. Scent antigenic shift. Copyright 2 subtypes of viruses, example human and swine influenza, infect the same cell and exchange genetic segments, resortment, to create new subtypes, example H3N1 H2N1. 4. Copyright occurs in particular when human pathogenic and animal pathogenic influenza viruses exchange genetic information. O causes pandemics, limited to a specific time period. Scent antigenic drift. Copyright minor changes in antigenic structure, hemagglutinin and/or neuraminidase, via random point mutation. Copyright does not alter the subtype, example H5N1 or avian flu. Copyright causes epidemics, limited to a specific population or region. B&B small shifts in a panda's habitat can cause epic dread, shifts can cause pandemics and drifts cause epidemics. S. Clinical features. The clinical presentation of influenza infection is asymptomatic or mild in 75% of cases. Influenza presents with very characteristic features, hence the term flu-like symptoms. Scent incubation period, a few hours to several days. Sudden onset of high fever, chills, headache, arthralgia, myalgia, fatigue, and malaise. Patients often develop acute bronchitis with a cough that is usually dry but may produce small amounts of clear or blood-tinged sputum. Hypotension and bradycardia are common, especially among women and older patients. References: OG, CES. Diagnostics. General Principles 111. Scent during periods of high influenza activity. A clinical diagnosis can often be made based on the presence of typical flu-like symptoms. In general, testing should only be carried out in outpatients if the results will influence management. 1. Ad. Influenza can present in atypical ways and can also trigger exacerbations in patients with chronic cardiopulmonary diseases. 10. Laboratory studies. 1. Scent confirmatory studies. Molecular assays are the preferred method for detecting influenza virus infection. 110 equals RT-PCR, preferred test for inpatients equals rapid molecular assay, preferred test for outpatients. A rapid antigen test can detect various influenza A/B antigens, usually via nasal or pharyngeal swabs. High specificity but limited sensitivity, equals only indicated if more sensitive tests are unavailable. Scent additional studies. Copyright serologic testing and viral cultures, not recommended for diagnosis. Back collapse. Find text outline. Scent additional studies. Copyright serologic testing and viral cultures, not recommended for diagnosis. A. Copyright blood tests are not routinely indicated, but if performed, may show, equals normal or slightly elevated inflammatory markers equals relative lymphocytosis. At. Consider bacterial co-infection in patients with elevated inflammatory markers, example CRP. 12. F01. Differential diagnoses. Common cold. COVID-19, acute rhinosinusitis, acute tonsillopharyngitis, laryngitis, epiglottitis, croup pertussis, allergic rhinitis, infectious mononucleosis. Scent. See also URTIs. The differential diagnoses listed here are not exhaustive. GOCE. Treatment. Supportive treatment, 1 degree. Scent oral rehydration therapy *, antipyretics and oral analgesics. 1. Scent antitussives to relieve dry cough. Antiviral therapy for influenza. Most cases of influenza are self-limited and do not require specific treatment. If antiviral treatment is indicated, treatment should be initiated as soon as possible. Indications: 1 degree. All patients with suspected or documented influenza and equals one of the following: A. Severe or progressive illness. Copyright hospitalization required. Copyright high risk for complications of influenza. Scent. Consider treating patients with suspected or confirmed influenza and equals one of the following: copyright onset. Treatment options. Scent neuraminidase inhibitors. Copyright mechanism of action: inhibits the release of viruses from the host cell. 1. O greatest benefit if started within the first 48 hours of symptom onset. 117 Copyright commonly used agents equals oral oseltamivir equals inhaled zanamivir equals intravenous peramivir. Ad. Do not use amantadine to treat influenza because of the risk of antimicrobial resistance. 19. Urnatiarinase. Camnelicatin. Back collapse. Find text outline. Complications. Individuals at high risk for complications of influenza, 19 IL-101 I-20. Adults equals 50 years of age, especially those equals 65 years of age. 19 children. Pneumonia 231 I-241 I-25. Primary influenza pneumonia 26. Scent description. Copyright caused by direct infection of the lung parenchyma by the influenza virus, 2726 co-hemorrhagic pneumonia, associated with a poor prognosis. Epidemiology, less common than secondary bacterial bronchitis or pneumonia. Clinical features. Copyright acute clinical deterioration 2 to 5 days after the onset of flu-like symptoms. 26 Copyright dyspnea, hypoxemia, cyanosis. 24 may progress to acute respiratory distress syndrome, ARDS, and multi-organ failure. Diagnostics. Blood tests may show leukocytosis or leukopenia. ESR is usually normal. Chest X-ray may show perihilar congestion and diffuse or multifocal infiltrates. Management. Antiviral therapy for influenza. Lung protective ventilation is often necessary. 26. Secondary bacterial bronchitis and pneumonia. Etiology. Common causative pathogens include S. pneumoniae, S. aureus, including MRSA, S. pyogenes, and H. influenza. 28 Clinical features. Copyright development of a purulent, productive cough 4 to 14 days after an initial period of improvement. 23 Recurrent fever. Symptoms similar to community-acquired pneumonia. Copyright post-influenza. S. aureus pneumonia can manifest with 29 hyperacute onset of symptoms hypoxemia and cyanosis hemoptysis hypotension. Diagnostics. Laboratory studies may show leukocytosis with left shift or leukopenia. ESR is typically elevated. Copyright in pneumonia caused by S. aureus, a chest X-ray may show cavitations and pneumatoceles. Plus treatment. 28 Empiric antibiotic therapy for community-acquired pneumonia. Copyright should include coverage for MRSA. Other complications. 23 Upper respiratory tract infections. Copyright acute otitis media. Copyright sinusitis. Copyright croup, especially in children, 8 degrees. Copyright parotitis. 31 Exacerbation of chronic diseases, example COPD, asthma, underlying ischemic heart disease, congestive heart failure. Acute kidney injury. Rare complications include cardiac, example pericarditis, myocarditis, musculoskeletal, example myositis, rhabdomyolysis, and neurological complications, example encephalopathy, encephalomyelitis, transverse myelitis, aseptic meningitis, Guillain-Barré syndrome. We list the most important complications. The selection is not exhaustive. Back collapse. Find text. Outline. Prevention. Vaccination, 190-132. Influenza vaccine. There are 3 types of influenza vaccines currently available. All influenza vaccines in the U.S. are quadrivalent, containing influenza hemagglutinin proteins, which are surface glycoproteins, for 2 flu A and 2 flu B strains. Plus, to account for antigenic drift, vaccines are modified prior to each influenza season to include expected circulating strains. Types of influenza vaccines. 1932-33 Minimum age for the first dose. Route of administration. 6 months, can be egg-based or cell culture-based. Intramuscular injection. 18 years, synthetically created without the use of any egg products. 34 lib di5, egg-based, degree 2 years. Intranasal spray. Indications. Plus all individuals 6 months of age, annually, ideally prior to each flu season. 32 plus, especially in the following groups. 91 low individuals at or in close contact with those at high risk for complications of influenza. Copyright close contacts or caregivers of infants. Individuals traveling to areas with influenza activity. 137. Contraindications and precautions. 1 degree 1. ENS 191-1391 CID&P for contraindications, precautions plus history of severe egg allergy, i.e. bronchospasm, angioedema, anaphylaxis. Administer history of anaphylaxis after vaccination for influenza. 44 R139 All flu vaccines. History of severe allergic reaction to any influenza vaccine component, excluding egg protein allergy. 4014-1139 Any egg-based influenza vaccines in a monitored setting. Concurrent acute illness. healthcare personnel, who receive the live attenuated influenza vaccine should avoid contact with severely immunosuppressed individuals for 7 days after vaccination. 39. Immunization schedule. Sent CACIP immunization schedule for details. Infection prevention and control. Sent standard precautions. Educate patients on the importance of hand hygiene and respiratory hygiene. Copyright advise outpatients to stay at home until they have been afebrile for at least 24 hours. Use personal protective equipment, including masks. Back collapse. Fine text outline. Infection prevention and control. Sent standard precautions. Copyright educate patients on the importance of hand hygiene and respiratory hygiene. Advise outpatients to stay at home until they have been afebrile for at least 24 hours. Use personal protective equipment, including masks. Degree clean surfaces with alcohol-based or aldehyde-based disinfectants. Sent isolation precautions. Copyright isolate or cohort patients. See droplet precautions for further details. Chemoprophylaxis 2. Pre-exposure prophylaxis, not routinely recommended. Sent post-exposure prophylaxis, not routinely recommended. Agents equals oseltamivir equals zanamivir equals baloxavir. Copyright post-exposure prophylaxis may be offered in conjunction with influenza vaccination in unvaccinated individuals at very high risk for complications of influenza and unvaccinated close contacts of these individuals. OHPOES 1. Special patient groups. Influenza during pregnancy. Sent maternal effects. Copyright associated with higher rates of hospitalization and admission to intensive care unit, more severe clinical course, and higher mortality. 42-43 increased risk of preterm delivery and spontaneous abortion. 441L451 fetal effects, associated with an increased risk of birth defects, example congenital heart defects, cleft lip, neural tube defects, fetal death, lower mean birth weight, and small size for gestational age. 4 degrees. 2 NEI. Subtypes and variants. A type of influenza that originates from animal strains, most commonly influenza A virus. Influenza B viruses are almost exclusively transmitted between humans. Sent direct transmission of influenza from animals to humans is rare, but sporadic cases and outbreaks of zoonotic influenza viruses, example avian influenza, have occurred. Most types of avian flu, 47 swine flu, 48, etiologies. Sent direct or indirect contact with infected birds or their saliva/feces *, direct or indirect contact with infected pigs or their saliva/feces * clinical features plus see clinical features above. * rapid antigen test J diagnostics. Sent viral culture plus RT-PCR * possibly serology. Treatment * neuraminidase inhibitor, example oseltamivir, peramivir, zanamivir, * neuraminidase inhibitor, example oseltamivir, peramivir, zanamivir, baloxavir. Avoid touching animals directly. Always wash hands after being near animals. * stay away from animals that show symptoms of a cold or flu. Prevention * vaccination against avian flu bell grease. == Sent vaccination against swine flu * preventive antiviral drugs in cases of contact with infected birds. OE. Prognosis. Back collapse. Fine text outline. X influenza. Chemoprophylaxis 0. Pre-exposure prophylaxis, not routinely recommended. Sent post-exposure prophylaxis, not routinely recommended. Agents equals oseltamivir equals zanamivir equals baloxavir. Copyright post-exposure prophylaxis may be offered in conjunction with influenza vaccination in unvaccinated individuals at very high risk for complications of influenza and unvaccinated close contacts of these individuals. ZN shared note. Special patient groups. Influenza during pregnancy. Scent maternal effects copyright associated with higher rates of hospitalization and admission to intensive care unit, more severe clinical course, and higher mortality. 42-43 copyright increased risk of preterm delivery and spontaneous abortion. 41-45 fetal effects, associated with an increased risk of birth defects, example congenital heart defects, cleft lip, neural tube defects, fetal death, lower mean birth weight, and small size for gestational age. 46. Subtypes and variants. A type of influenza that originates from animal strains, most commonly influenza A virus. Influenza B viruses are almost exclusively transmitted between humans. Scent direct transmission of influenza from animals to humans is rare, but sporadic cases and outbreaks of zoonotic influenza viruses, example avian influenza, have occurred. Most types of avian flu. 47 Swine flu. 481 Etiology: direct or indirect contact with infected birds or their saliva/feces. Direct or indirect contact with infected pigs or their saliva/feces. Clinical features plus see clinical features above. Rapid antigen test. Viral culture *, RT-PCR, possibly serology. Diagnostics. Treatment. Scent neuraminidase inhibitor, example oseltamivir, peramivir, zanamivir, *, neuraminidase inhibitor, example oseltamivir, peramivir, zanamivir, baloxavir. Scent. Avoid touching animals directly. Always wash hands after being near animals. Stay away from animals that show symptoms of a cold or flu. Prevention. Scent. Vaccination against avian flu. A. Vaccination against swine flu *, preventive antiviral drugs in cases of contact with infected birds. OSRO. B. Prognosis. * Mortality. 4950 increased in individuals at high risk for influenza-related complications. See complications above. Average number of annual influenza-related deaths in the U.S., 23,000 to 48,000. Back collapse. Find text outline. Influenza, 1/3. Influenza virus, subtype H1N1. Colorized electron micrograph of influenza viruses. The antigens on the outer coat of the influenza virus have a spiky appearance. This occurs as the result of, example, the combination of certain hemagglutinins and neuraminidases, and can be used to distinguish between the different subtypes of influenza viruses, example H1N1 or swine flu, H5N1 or avian influenza. Source: 11214, C.S. Goldsmith and A. Baelish, Centers for Disease Control and Prevention, CDC, licensed under public domain. Influenza virion. Colored electron micrograph of an influenza virion. The central ribonucleoproteins, purple, contains the virus genome and other proteins. Matrix, brown, double lipid membrane of the virus envelope, yellow, and membrane proteins, orange, can be seen. The influenza virus strain type is characterized by the constituents of the membrane proteins, especially hemagglutinins H and neuraminidase N, example H1N1, swine flu. Source: ID #10073, CDC/Erskine. L. Palmer, Ph.D., M. L. Martin, Centers for Disease Control and Prevention, CDC, licensed under public domain. Euroinfluenza, 3/3. H1N1 influenza virus. Colorized transmission electron micrograph of H1N1 influenza virus particles. Surface proteins on the virus particles appear black. These particles are the typical round shape of influenza viruses. Source: H1N1 influenza virus particles by NIAID, Flickr, licensed under CC by 2.0. Euroinfluenza, 1/1. Equals S. Mutation Fe and 5 is Ford. CL+. Copyright AEA 7, //C NAEA, T7, L and /U //75 VAIA /AOEAE, UI. UUWYYW host cell YAMNS, associated with pandemics. Antigenic shift and drift VV. Copyright Boss. MSEAE recommended range of I range of recommended vaccination recommended. 00 no recommended vaccination based on ages 4 _ recommendation / ages for all OA. Can begin in shared clinical. For catch up certain high. Not applicable children I this age group equals decision vaccination risk groups. Making. Birth to 15 months. These recommendations must be read with the notes that follow. For those who fall behind or start late, provide catch-up vaccination at the earliest opportunity as indicated by the green bars. To determine minimum intervals between doses, see the catch-up schedule, Table 2. Vaccine and other 1912 immunizing agents birth MO 2 MOs 4 MOs 6 MOs MOs 15 MOs. Respiratory syncytial virus at 1 dose depending on maternal RSV, RSV-MAB vaccination status, see notes near Sevimab. Hepatitis B1's Osama, Hep B, dose. Rotavirus, RV, E4ST on CRV1, 2-dose series, dose nets RV5, 3-dose series. Diphtheria, tetanus, and acellular pertussis LS2DA at dose, DTAP. Haemophilus, PTLE second C, HIB. Pneumococcal ST second third conjugate at dose SODS equals, PCV15, PCV20. Inactivated poliovirus STQNDE dose EE, IPV. COVID-19 at 1 or more doses of updated, 2023, 1 VCOV mRNA, 2024 formula, vaccine 1 VCOV APS, see notes. Euro immunization schedules 2. Influenza, LAIV4, at. Measles, mumps, rubella at. Varicella at, _E, var, dose. Hepatitis A at. Tetanus, diphtheria, and acellular pertussis at, Tdap, equals 7 YRS. Human papillomavirus at, HPV. Meningococcal at, Menacqui CRM 22 MOs, Menacqui TT 22 years. Meningococcal B at, Men B4C, Men B FHBP. Respiratory syncytial virus vaccine at, RSV Abrisvo. Dengue at. Den4 SID, 9 to 16 YRS. Mpox at. 18 months to 18 years. 16 months to 16 years. Respiratory syncytial virus E, RSV-MAB. Nirsevimab. Hepatitis B at, Hep B. Rotavirus at, RV, RV1, 2-dose series, RV5, 3-dose series. Diphtheria, tetanus, and acellular pertussis at, DTAP. Haemophilus influenza type B at, HIB. Pneumococcal conjugate at, PCV15, PCV20. Inactivated poliovirus at, IPV. COVID-19 at, 1 VCOV mRNA, 1 VCOV APS. 1 or more doses of updated, 2023 to 2024 formula, vaccine, see notes. Influenza, IIV4, at annual vaccination 1 or 2 doses annual vaccination 1 dose on. Euro immunization schedules. Measles, mumps, rubella at, MMR. Varicella at, VAR. Hepatitis A at, HEPA. Tetanus, diphtheria, and acellular pertussis at, Tdap, 27 YRS. Human papillomavirus at, HPV. Meningococcal at, MEN-ACWY. CRM equals 2 MOs, Menaquite 22 years. Meningococcal bo, men B4C, men BFHBP. Respiratory syncytial virus vaccine at, RSV Abrisvo. Dengue at, Denacid, 916YRS. Seropositive in endemic dengue areas, see notes. Box at. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age 4. Review vaccine types, frequencies, intervals, Table 1, by age, and considerations for special situations 2. Determine recommended interval for catch, notes, up vaccination, Table 2, catch up, 5. Review contraindications and precautions for 3. Assess need for additional recommended vaccine types, Appendix, vaccines by medical condition or other 6. Review new or updated ACIP guidance indication, Table 3, by medical indication, Addendum. Recommended by the Advisory Committee on Immunization Practices, ACIP, and approved by the Centers for Disease Control and Prevention, CDC, American Academy of Pediatrics, AAP. 4. American Academy of Family Physicians, AAFP 7, American College of Obstetricians and Gynecologists, ACOG 4, American College of Nurse Midwives, ACNM 4, American Academy of Physician Associates, AAPA 4, and National Association of Pediatric Nurse Practitioners, NAPNAP 7. The comprehensive summary of the ACIP recommended changes made to the child and adolescent immunization schedule can be found in the January 11, 2024 MMWR report. Suspected cases of reportable vaccine-preventable diseases or outbreaks to your state or local health department. Clinically significant adverse events to the Vaccine Adverse Event Reporting System, VAERS, at www.virs.hhs.gov or 800-822-7967. Questions or comments, contact www.cdc.gov/cdc-info or 800-CDC-INFO, 800-232-4636, in English or Spanish, 8 a.m. to 8 p.m. Eastern Time, Monday through Friday, excluding holidays. Helpful information. Sent Complete Advisory Committee on Immunization Practices, ACIP, Recommendations. ACIP Shared Clinical Decision-Making Recommendations. General Best Practice Guidelines for Immunization, including contraindications and precautions. Vaccine Information Statements. Manual for the Surveillance of Vaccine-Preventable Diseases, including case identification and outbreak response. Last reviewed, November 16, 2023. Copyright and in, 45. FN Schedules Home. For healthcare providers. For you and your family. X26cdc.gov. Birth 18 years immunization schedule, by medical condition. CDC. Recommendations for ages 18 years or younger, United States, 2024. Print. Euro Back to Child and Adolescent Immunization Schedule homepage. Vaccines and other immunizing agents in the child. WA Get email updates immunization schedule. Download the How to Use the schedule. To make vaccination recommendations, healthcare providers print the schedule, color should, SSE. 1. Determine recommended vaccine by age, Table 1, by age, print the schedule, black and white. 2. Determine recommended interval for catch-up vaccination, Table 2, catch-up. 3. Assess need for additional recommended vaccines by medical condition or other indication, Table 3, by medical indication. Download the mobile app. Compliant version of the Schedule 4. Review vaccine types, frequencies, intervals, and considerations for special situations, notes, 5. Review contraindications and precautions for vaccine types, Appendix, 6. Review new or updated ACIP guidance, addendum. Legend. Not recommended. Recommended J for all age. Precaution, recommended for all children. 9 eligible children, might be, i.e. for all age but is an additional IR if contraindicated. Eligible children. Recommended doses may be benefit of or not know who lack for some necessary. Recommended. Protection. Guidance / not documentation. Children based on, * vaccinate after, outweighs applicable of a complete on increased medical risk of pregnancy, if vaccination risk for or condition or indicated, adverse series severe other, AAE reaction outcomes from JJ indications. See disease notes. Always use this table in conjunction with Table 1 and the notes that follow. Medical conditions are often not HIV infection CD4 percentage and count, asplenia or CSF leak, persistent heart, immunocompromised or complement disease or vaccine and other status, excluding HIV. RSV mAb at second RSV, nirsevimab, AIA, 4, 1 dose depending on maternal chronic QCD RSV vaccination status, see notes. Lung disease, see notes. Hepatitis B at rotavirus at DBD. DTAP/Tdap at DTAP. GAP/QOSSE at EuroD pregna. HIB at HBO. See notes. Goes. Pneumococcal at IPV at COVID-19 at see notes. LIV4 at LAIV4 at Erie. Measles, mumps, rubella at VAR at Hepatitis A at human papillomavirus G. Meningococcal ACWY at meningococcal. RSV at seasonal, Abrysvo, administration, see notes. Dengue at Mpox at A. For additional information regarding HIV laboratory parameters and use of live vaccines, see the General Best Practice Guidelines for Immunization, Altered Immunocompetence, and Table 4-1, footnote J. B. Severe combined immunodeficiency. CLAIV4 contraindicated for children 2 to 4 years of age with asthma or wheezing during the preceding 12 months. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age 4. Review vaccine types, frequencies, intervals, Table 1, by age, and considerations for special situations. 2. Determine recommended interval for catch, notes, up vaccination, Table 2, catch up. 5. Review contraindications and precautions for 3. Assess need for additional recommended vaccine types, Appendix, vaccines by medical condition or other. 6. Review new or updated ACIP guidance indication, Table 3, by medical indication, addendum. Recommended by the Advisory Committee on Immunization Practices, ACIP, and approved by the Centers for Disease Control and Prevention, CDC, American Academy of Pediatrics, AAP4, American Academy of Family Physicians, AAFP4, American College of Obstetricians and Gynecologists, ACOG4, American College of Nurse Midwives, ACNM4, American Academy of Physician Associates, AAPA4, and National Association of Pediatric Nurse Practitioners, NAPNAP4. The comprehensive summary of the ACIP recommended changes made to the child and adolescent immunization schedule can be found in the January 11, 2024 MMWR report. Suspected cases of reportable vaccine-preventable diseases or outbreaks to your state or local health department. Clinically significant adverse events to the Vaccine Adverse Event Reporting System, VAERS, at www.vaers.hhs.gov or 800-822-7967. Questions or comments, contact www.cdc.gov/cdc-info or 800-CDC-INFO, 800 232-4636, in English or Spanish, 8 a.m. to 8 p.m. Eastern Time, Monday through Friday, excluding holidays. Helpful information. Sent Complete Advisory Committee on Immunization Practices, ACIP, Recommendations. xx25cde.gov. Table 2, Catch Up. United States, 2024. Print. Euro Back to Child and Adolescent Immunization Schedule homepage. Vaccines and other immunizing agents in the Child WA Get Email Updates Immunization Schedule. Download the How to Use the schedule to make vaccination recommendations. Healthcare providers should print the schedule, color. 1. Determine recommended vaccine by age, Table 1, by age, print the schedule, black and white. 2. Determine recommended interval for catch-up vaccination, Table 2, catch-up. 3. Assess need for additional recommended vaccines by download the mobile app Medical Condition or Other Indication, Table 3, by medical indication. 4. Review vaccine types, frequencies, intervals, and considerations for special situations, notes. 5. Review contraindications and precautions for vaccine types, Appendix. 6. Review new or updated ACIP guidance, Addendum. Vaccine Catch-Up Guidance. SCDC has developed catch-up guidance job aids to assist healthcare providers in interpreting Table 2 in the Child and Adolescent Immunization Schedule. Children age 4 months through 6 years. The table below provides catch-up schedules and minimum intervals between doses for children whose vaccinations have been delayed. A vaccine series does not need to be restarted, regardless of the time that has elapsed between doses. Use the section appropriate for the child's age. Always use this table in conjunction with Table 1 and the notes that follow. Hepatitis B at birth 4 weeks, 8 weeks and at least 16 weeks after first dose. Minimum age for the final dose is 24 weeks. Rotavirus at 6 weeks, 4 weeks, 4 weeks maximum age for final dose is 14 is 8 months, 0 weeks, 6 days. Diphtheria, 6 weeks, 4 weeks, 4 weeks, 6 months tetanus, and a 5th dose is acellular not necessary pertussis at if the 4th dose was administered at age 4 years or older and at least 6 months after dose 3. Haemophilus 6 weeks no further 8 weeks, as influenza doses needed final dose, type Hep at if first dose if previous this dose was only administered necessary at age 15 for children months or age 12 older through 59 4 weeks months if first dose if current age who was is younger received 3 administered than 12 doses before the 1 asterisk months and before the birthday. First dose was 1% birthday. 8 weeks, as administered final dose, at younger if first dose than age 7 was months and administered at age 12 through 14 months. At least one previous dose was PRPT, ACT HIV registered, Pentacyl registered, Hybrix registered, Vaxilis registered, or unknown 8 weeks and age 12 through 59 months, as final dose, if current age is younger than 12 months and first dose was administered at age 7 through 11 months, or if current age is 12 through 59 months and first dose was administered before the 1 T birthday, and second dose was administered at younger than 15 months, or if both doses were PEDVAX HIV registered and were administered before the 1% birthday. Pneumococcal conjugate at 6 weeks no further doses needed for healthy children if FERCT. No further doses needed for healthy children if 8 weeks, as final dose, this dose is only. Pneumococcal 6 weeks no further 8 weeks, as conjugate at doses needed final dose, for healthy this dose is children if only dose was previous dose necessary administered was for children at administered age 12 age 24 at age 24 through 59 months older regardless 4 weeks of risk, or if first dose if current age 60 administered is younger through 71 before the then 12 months 1% birthday months and with any 8 weeks, as previous dose risk, who final dose for given at months. Inactivated 6 weeks 4 weeks 4 weeks 6 months poliovirus at if current age, minimum is measles, 12 months 4 weeks mumps. Measles, 12 months 4 weeks mumps, rubella at varicella at 12 months 3 months. Hepatitis A at 12 months 6 months. Meningococcal 2 months 8 weeks see notes ACWY at men ACWY CRM 2 years men ACWY TT. Top of page. Children and adolescents age 7 through 18 years. Minimum age for minimum interval between doses. Vaccine dose 1 to dose 2 to dose 3 to dose 4. Meningococcal not applicable 8 weeks ACWY at N/A. Tetanus, 7 years 4 weeks 6 months diphtheria, if first dose of tetanus, DTAP/DT was diphtheria, and administered acellular before the 1T pertussis at birthday 6 months, as final dose, if first dose of DTAP/DT or Tdap/TD was administered at or after the 1% birthday. Human 9 years routine dosing intervals are recommended. Papillomavirus copyright. Hepatitis A at N/A 6 months. Hepatitis B at N/A 4 weeks 8 weeks and at Hepatitis B at N/A 4 weeks 8 weeks and at least 16 weeks after first dose. Inactivated N/A 4 weeks 6 months. A fourth dose of poliovirus at a fourth dose is IPV is indicated if not necessary if all previous the third doses was administered at measles, N/A 4 weeks mumps, rubella 0. Varicella at N/A 3 months if younger than age 13 years. 4 weeks if age 13 years or older. Dengue at 9 years 6 months. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age, Table 1, by age. 2. Determine recommended interval for catch-up vaccination, Table 2, catch-up. 3. Assess need for additional recommended vaccines by medical condition or other indication, Table 3, by medical indication. 4. Review vaccine types, frequencies, intervals, and considerations for special situations, notes. 5. Review contraindications and precautions for vaccine types, appendix. 6. Review new or updated ACIP guidance, addendum. Recommended by the Advisory Committee on Immunization Practices, ACIP, and approved by the Centers for Disease Control and Prevention, CDC, American Academy of Pediatrics, AAP4, American Academy of Family Physicians, AAFP7, American College of Obstetricians and Gynecologists, ACOG4, American College of Nurse Midwives, ACNM4, American Academy of Physician Associates, AAPA4, and National Association of Pediatric Nurse Practitioners, NAPNAP%. The comprehensive summary of the ACIP recommended changes made to the child and adolescent immunization schedule can be found in the January 11, 2024 MMWR report. XX25cde.gov. Euro immunization schedules Q. Table 1, by age. Recommendations for ages 19 years or older, United States, 2024. Print. Euro back to adult immunization schedule homepage. Vaccines in the adult immunization schedule WA get email updates. How to use the schedule. Download the To make vaccination recommendations, healthcare providers schedule. Should print the schedule, color 1. Determine recommended vaccine by age, Table 1, by age. 2. Assess need for additional recommended vaccinations by print the schedule, black and medical condition or other indication, Table 2, by medical EE height B condition, white FA 3. Review vaccine types, dosing frequencies, and intervals, and download the mobile app considerations for special situations, notes, 4. Review contraindications and precautions for vaccine types, appendix, compliant version of the CHEJA 5. Review new or updated ACIP guidance, addendum, soles. Legend. Recommended no vaccination for adults vaccination based on recommendation / not who meet age with an additional risk shared clinical applicable requirement, lack factor, or another decision-making documentation of indication vaccination, or lack evidence of immunity. Vaccine 19 to 26 years 27 to 49 years 50 to 64 years 265 years. COVID-19 at one or more doses of updated, 2023 to 2024 formula, vaccine, see notes. Influenza inactivated, IIV4. COVID-19 at one or more doses of updated, 2023 to 2024 formula, vaccine, see notes. Influenza inactivated, IIV4, or influenza recombinant, RIV4, @ Copyright 8000 OC HHH HHS 00008 H008 HH00000 HSHHH Hushcoach His Heshizco registered. 1 dose annually influenza live attenuated, LAIV4, at 1 dose annually. Respiratory syncytial virus, RSV, at 260 years. Tetanus, diphtheria, pertussis, Tdap or TD, at 1 dose Tdap, then TD or Tdap booster every 10 years. Measles, mumps, rubella, MMR, at. For healthcare personnel, see notes. 1 or 2 doses depending on indication, if born in 1957 or later. Varicella, VAR, at 2 doses, if born in 1980 or later. Zoster recombinant, RZV, at 2 doses. Human papillomavirus, HPV, at 2 or 3 doses depending on age at initial vaccination or condition. 27 through 45 years. Pneumococcal, PCV15, PCV20, PPSV23, at. See notes. See notes. Hepatitis A, HEPA, at. Meningococcal AC, WY, MEN ACWY, at. Meningococcal B, MEN B, at. Haemophilus influenza type B, HIB, at. Mpox at. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age 3. Review vaccine types, frequencies, intervals, Table 1, by age, and considerations for special situations 2. Assess need for additional recommended, notes, vaccinations by medical condition or other 4. Review contraindications and precautions for indication, Table 2, by medical condition, vaccine types, Appendix 5. Review new or updated ACIP guidance, Addendum. This schedule is recommended by the Advisory Committee on Immunization Practices, ACIP, and approved by the Centers for Disease Control and Prevention, CDC, American College of Physicians, ACP. 4. American Academy of Family Physicians, AAFP. 4. American College of Obstetricians and Gynecologists, ACOG. 7. American College of Nurse Midwives, ACNM. 7. American Academy of Physician Associates, AAPA. 4. American Pharmacists Association, APHA. 4. and Society for Healthcare Epidemiology of America, SHA%. The comprehensive summary of the ACIP recommended changes made to the adult immunization schedule can be found in the January 11, 2024 MMWR report. Suspected cases of reportable vaccine-preventable diseases or outbreaks to your state or local health department. Degree clinically significant adverse events to the Vaccine Adverse Event Reporting System, VAERS, at www.vaers.hhs.gov or 800-822-7967. Questions or comments, contact www.cdc.gov/cdc-info or 800-CDC-INFO, 800-232-4636, in English or Spanish, 8 a.m. to 8 p.m. Eastern Time, Monday through Friday, excluding holidays. Helpful information. Sent Complete Advisory Committee on Immunization Practices, ACIP, Recommendations UW and UOWELP XAL MPMTEIS WIPA PH in LORS. XX25CDE.gov. Table 2, by medical indication. Recommendations for ages 19 years or older, United States, 2024. Print. Euro back to adult immunization schedule homepage. Vaccines in the adult immunization schedule. How to use the schedule. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age, Table 1, by age. 2. Assess need for additional recommended vaccinations by medical condition or other indication, Table 2, by medical condition. 3. Review vaccine types, dosing frequencies and intervals, and considerations for special situations, notes. 4. Review contraindications and precautions for vaccine types, appendix. 5. Review new or updated ACIP guidance, addendum. Legend. Not recommended for all adults who lack documentation of vaccination, or lack evidence of immunity. Recommended for all adults, but recommended for some adults based on either age or increased risk for or severe outcomes from disease. Recommended based on shared clinical decision-making. Recommended for all adults, and additional doses may be necessary based on medical condition or other indications. See notes. A. Get email updates. Download the schedule. Print the schedule, color. Print the schedule, black and white. Download the mobile app. Compliant version of the schedule. Precaution, might be contraindicated, indicated if or no benefit of no. Recommended, protection. Guidem, * vaccinate after, outweighs APPL. Pregnancy, if risk of OO indicated adverse reaction. Always use this table in conjunction with Table 1 and the notes that follow. Medical conditions or indications are often not mutually exclusive. If multiple medical conditions or indications are present, refer to guidance in all relevant columns. See notes for medical conditions or indications not listed. Kid. I _ kidney HIV infection CD4 8% and count end-stage immunorenal chronic compromised men who asplenia, heart disease, liver, excluding COVID-19 at C notes. IIV4 at or RIV4 1 dose annually. At EENEO 1 dose LAIV4 at annually if age 1 dose annually if age 19-49 years 19 to 49 years. RSV at seasonal administration. See notes, see notes, see notes. Tdap or TD at Tdap, 1 dose each, 1 dose Tdap, then TD or Tdap booster every 10 YRS pregnancy. 1 or 2 doses depending on indication. See notes. See notes. HPV at pneumococcal EG/Fayrol low plus. A precaution for LAIV4 does not apply to alcoholism. B. See notes for influenza, hepatitis B, measles, mumps, and rubella, and varicella vaccinations. X. Overview of viral hepatitides. Viral hepatitides comprise the infectious diseases hepatitis A, B, C, D, and E, which have various routes of transmission, example fecal-oral, sexual, parenteral, and perinatal transmission. Most patients are either asymptomatic or experience mild symptoms, which usually resolve spontaneously within weeks to months. However, patients with hepatitis B virus, HBV, infection, hepatitis C virus, HCV, infection, or hepatitis D virus, HDV, infection may experience a chronic disease course, increasing the risk of cirrhosis and hepatocellular carcinoma, HCC. Pregnant individuals with hepatitis E virus, HEV, infection have an increased risk of developing fulminant hepatitis. Diagnostic studies include liver function tests, viral serologic testing, and measurement of viral load. Treatment of acute hepatitis primarily involves supportive care. HCV infection can be effectively treated with early direct-acting antivirals. Treatment of chronic hepatitis involves antivirals to reduce viral replication and infectivity. Vaccination is available against hepatitis A and hepatitis B. This article contains an overview of viral hepatitides as well as hepatitis D and hepatitis E. See also hepatitis A, hepatitis B, and hepatitis C. Go. Or. Overview. Overview of viral hepatitis. Hepatitis A virus, HAV, hepatitis B virus, HBV, hepatitis C virus, HCV, hepatitis D virus, HDV, hepatitis E virus, HEV. Asterisk sexual parenteral 7 hen, EEEPT, sent fecal oral equals into hepatocytes route of transmission fecal oral sent parenteral asterisk parental asterisk perinatal asterisk sexual, rare, sent perinatal. Asterisk sexual or perinatal, rare. Asterisk co-infection, HDV and HBV 1 to 6 months incubate law 2 to 6 weeks asterisk 1 to 6 months 2 colonase weeks to 6 months asterisk 2 to 8 weeks riva o peri. Asterisk superinfection, HDV after HBV 2 to 8 weeks. Scent varies significantly similar to HBV adults, acute and equals 7 plus asymptomatic if clinidid subclinical hepatitis in typically asymptomatic co-infection, usually leads to cell-timite clinical course. 70% of cases most patients develop chronic severe acute hepatitis. Children, typically, MNEEA, can develop into a HCV infection if untreated. Superinfection, increased risk asymptomatic, chronic infection of liver cirrhosis. Similar to HAV, but milder increased risk of fulminant hepatitis in pregnant individuals. Increased risk of HCC no plus yes no. Amenable to treatment acute, degree, asterisk no CUS 209 asterisk yes plus yes in cutest with antiviral therapy asterisk chronic, yes asterisk chronic, yes. Immunization asterisk HAV vaccination asterisk HBV vaccination asterisk not available HBV vaccination, asterisk not available. QB vowels, A and E, are transmitted via the bowels, fecal-oral, and usually only cause acute hepatitis. OOA. OSOE. Hepatitis DL2. Pathogen, hepatitis D virus, HDV. O belongs to the Deltaviridae family and the genus Deltavirus. Copyright defective, circular, single-stranded RNA virus. Copyright incomplete viral particle resembling a viroid. Copyright comprises an outer lipoprotein envelope made of the hepatitis B surface antigen, HBsAg, for entry into host cells and an inner ribonucleoprotein structure in which the HDV genome resides. Scent epidemiology, 5% of all patients with chronic HBV infection carry HDV. Scent route of transmission, sexual, parenteral, perinatal scent risk factors. O men who have sex with men. V. Back collapse. Find text outline. Hepatitis D L2 plus pathogen, hepatitis D virus, HDV, O belongs to the deltaviridae family and the genus Delta virus. Degree defective, circular, single-stranded RNA virus. Copyright incomplete. Viral particle resembling a viroid. Copyright comprises an outer lipoprotein envelope made of the hepatitis B surface antigen, HBsAg, for entry into host cells and an inner ribonucleoprotein structure in which the HDV genome resides. Scent epidemiology, 5% of all patients with chronic HBV infection carry HDV. Scent route of transmission, sexual, parenteral, perinatal scent risk factors. EO men who have sex with men. Copyright history of STIs. O multiple sexual partners. E sex workers. Copyright injection drug use. O multiple blood transfusions. Copyright individuals born in countries with a high prevalence of HDV infection. Scent incubation period. Copyright acute co-infection, acute HBV and HDV infection 1 to 6 months. O acute HDV superinfection, HDV after HBV 2 to 8 weeks. Scent clinical features, similar to acute HBV infection. Scent clinical course. Degree acute co-infection with HBV usually leads to severe acute hepatitis. Equals 2 peaks of ALT and AST elevation may be observed. 3 equals approximately 5% of patients with co-infection progress to chronic HDV infection. 4 OHDV superinfection in patients with chronic hepatitis B increases the risk of liver cirrhosis and HCC. Equals more than 80% of patients with superinfection progress to chronic HDV infection. 4L equals the development of chronic HDV infection can exacerbate hepatic injury caused by HBV. Diagnostics. The presence of HBsAg is necessary for the diagnosis because of the dependence of HDV on HBV. Copyright confirmatory testing equals presence of HBsAg and IgM anti-HBc equals anti-HDV antibodies equals serum HDV RNA. Copyright liver biopsy, not routinely indicated. See pathology of viral hepatitis. Scent treatment. Copyright acute hepatitis D, supportive care. Copyright chronic hepatitis D equals pegylated interferon alpha, PEG-IFNA, equals indicated in patients with active liver disease and detectable HDV RNA. Scent complications, same as complications of hepatitis B. Scent prevention. Copyright HBV vaccination. O measures to prevent HBV transmission. Scent prognosis. O patients with superinfection have a poor prognosis. Copyright while most patients with acute co-infection successfully recover from both HBV and HDV infection, co-infection presents a greater risk of acute liver failure compared to acute HBV infection alone. And remember the 3 Ds of hepatitis D, defective delta virus dependent on HBV HBsAg code for entry. Y. And hepatitis E sile. Pathogen, hepatitis E virus, HEV, O belongs to the Hepaviridae family and the genus Orthohepavirus. Copyright small, 34 nanometers in diameter, non-enveloped virus with single-stranded, positive sense RNA. OHEV genotypes 1 and 2 are found only in humans. Genotypes 3 and 4 are zoonotic diseases with reservoirs in both humans and animals such as pigs, monkeys, and dogs. 7. Scent epidemiology. E uncommon in the US. O an important cause of endemic viral hepatitis in developing countries and equatorial regions, example India, Western and Northern Africa, Middle East, Mexico. Scent route of transmission. O fecal oral, contaminated water and food, example uncooked meat, v. Back collapse. Find text outline. X overview of viral hepatitis. O liver biopsy, not routinely indicated. See pathology of viral hepatitis. Scent treatment. E acute hepatitis D, supportive care. Copyright chronic hepatitis D equals pegylated interferon alpha, PEG-IFNA, equals indicated in patients with active liver disease and detectable HDV RNA. Scent complications, Same as complications of hepatitis B. Scent prevention. HPV vaccination. Measures to prevent HPV transmission. Scent prognosis. Patients with superinfection have a poor prognosis. Copyright. While most patients with acute co-infection successfully recover from both HPV and HDV infection, co-infection presents a greater risk of acute liver failure compared to acute HPV infection alone. Remember the 3Ds of hepatitis D, defective Delta virus dependent on HPV HBsAg code for entry. WA CE Hepatitis E Silel Pathogen, hepatitis E virus, HEV, belongs to the Hepaviridae family and the genus Orthohepavirus O. Small, 34 nanometers in diameter, non-enveloped virus with single-stranded, positive sense RNA. HEV genotypes 1 and 2 are found only in humans. Genotypes 3 and 4 are zoonotic diseases with reservoirs in both humans and animals such as pigs, monkeys, and dogs. 7. Epidemiology. Uncommon in the US. An important cause of endemic viral hepatitis in developing countries and equatorial regions, example India, Western and Northern Africa, Middle East, Mexico. Route of transmission. Fecal-oral, contaminated water and food, example uncooked meat. Parenteral, blood transfusions. Copyright perinatal, vertical transmission. Incubation period, 2 to 8 weeks. Clinical features. Copyright similar to clinical features of acute hepatitis A. Copyright in the majority of cases. The disease is self-limited. Symptoms resolve after 2 to 4 weeks. Diagnostics. Copyright confirmatory testing. 1 equals anti-HEV IgM antibodies, active infection. Equals anti-HEV IgG antibodies, past infection. Equals PCR, can detect HEV RNA in stool and serum samples. Liver biopsy, not routinely indicated. See pathology of viral hepatitis. Treatment. Copyright acute, supportive care. Copyright chronic, ribavirin complications. Copyright chronic HEV infection in immunosuppressed individuals, example due to transplantation, HIV infection, silo-fulminant hepatitis prevention. Advise all travelers to follow primary preventive measures such as food and water safety. No HEV vaccine is available. Prognosis. In most cases, HEV infection is self-limited, patients should make a full recovery. High mortality risk in pregnant individuals with fulminant hepatitis B and women who are expecting a child should be fully aware of the risks. Hepatitis E can lead to fulminant hepatitis. A fulminant course occurs in up to 20% of pregnant individuals with HEV infection. It is life-threatening for both the mother and fetus. Back collapse. Find text outline. Overview of viral hepatitides, 1/1. RNA DNA RNA defective, RNA, HAV, HPV, HCV, HDV, HEV, sexual, transmission. Fecal-oral parenteral, parenteral, fecal-oral perinatal. 2 weeks to incubation period. 2 to 6 weeks. 1 to 6 months. Enanth 1 to 6 months. 2 to 8 weeks. Rare progression to 5 to 10% in adults, up to 85%. Phase 3 and never ein. Yes, possible in chronicity. 90% in infants if untreated. Immunosuppression. No typically resolves. Extrahepatic only as co-infection. TAI without sequelae. Manifestations with HPV. EPA pregnancy. Immunization. Yes, no. HPV vaccine. No. Overview of viral hepatitis VV. Copyright Boss X. Hepatitis A. Hepatitis A is a viral disease caused by the hepatotropic hepatitis A virus, HAV, and usually spreads through fecal-oral transmission. About half of all patients with hepatitis A in the U.S. acquire the HAV during visits to countries in which HAV is endemic, tropical or subtropical regions. HAV infection can cause acute viral hepatitis, which initially manifests with prodromal symptoms, fever and malaise, followed by jaundice. The laboratory findings in hepatitis A are similar to those observed in other forms of acute viral hepatitis and include high serum transaminase levels and mixed hyperbilirubinemia. Serological detection of anti-HAV IgM antibodies confirms the diagnosis of hepatitis A. While prodromal symptoms typically resolve within a few weeks, jaundice may persist for 1 to 3 months. Hepatitis A is typically self-limited with no chronic sequelae, and acute liver failure rarely occurs, therefore, only supportive care is typically required. In the U.S., routine immunization against HAV is recommended for all children 12 months of age. Individuals at increased risk of infection, such as travelers to areas in which HAV is endemic, as well as individuals at increased risk of severe disease, such as those with chronic liver disease, should also be immunized against HAV if they have not been previously vaccinated. The hepatitis A immunization series generally provides long-term immunity, without the need for booster doses. Epidemiology. Cent incidence, in the U.S. 2,000 cases per year, 50% acquired during travels abroad. 1 Copyright hepatitis A virus is the second most common cause of acute hepatitis in the U.S. Co-copyright hepatitis A is very common in tropical and subtropical regions. Cent age, vaccination programs have made the disease fairly rare in children. Infection is now more widespread in adults. 2 Epidemiological data refers to the U.S., unless otherwise specified. 7% CE. Etiology. Cent pathogen, hepatitis A virus 2 copyright belongs to the family of Picornaviridae and the genus Hepatavirus copyright small, 27 nanometers in diameter, non-enveloped virus with single-stranded, positive sense RNA copyright resistant to denaturation by gastric acid, heat, and chemicals, and can remain viable for months in fresh and salt water. Humans are the only reservoir for the hepatitis A virus. 3 * route of transmission, fecal-oral, 41 copyright contaminated water and food, example raw shellfish, copyright risk groups, international travelers, nursing home residents, prison inmates, men who have sex with men, 4 drug users. Infectious period, 2 weeks before to 1 week after the onset of the illness. 3. And when it comes to viral hepatitis, vowels, A and E, are bowels, transmitted feco-orally. OC. OES. Pathophysiology. HAV is not cytopathic in itself. Research suggests that liver damage is caused by cellular immunity, especially CD8 plus T cells. 2. Air. _FDA. WAOE. Clinical features V. Back collapse. Fine text outline. Clinical features. HAV infection in children is typically asymptomatic. The risk of symptomatic disease increases with age and co-infection, example with hepatitis B. Incubation period, 2 to 6 weeks plus phases of acute viral hepatitis, 21L41. Prodromal phase, 1 to 2 weeks equals right upper quadrant pain, tender hepatomegaly equals fever, malaise equals anorexia, nausea, vomiting. 2. Ioteric phase, 2 weeks equals jaundice equals dark urine and pale stools equals pruritus. 3. Resolution of symptoms. Potential complications, cholestasis, relapsing HAV infection, and autoimmune hepatitis plus prognosis. Copyright. The mortality rate is 0.1 to 0.3% because few patients progress to acute liver failure. Individuals affected with hepatitis A, unlike with hepatitis B and hepatitis C, do not become carriers nor do they develop chronic hepatitis. And when it comes to viral hepatitis, vowels, A and E, cause only acute hepatitis while consonants, B, C, and D, may have chronic sequelae as well. YES. Diagnostics. Laboratory testing, SII6LL7. Cent routine studies, O1 serum transaminase levels, AST, ALT, OAST/ALT ratio is usually sent confirmatory testing copyright anti-HAV IgM antibodies, present in patients with active infection, equals usually detectable 5 to 10 days after exposure and 5 to 10 days before clinical symptoms develop equals levels peak commonly 1 month after infection. Equals may persist for up to 6 months after infection. 07 anti-HAV IgG antibodies equals develop during active infection and persist indefinitely after infection or vaccination equals production begins within 2 to 3 weeks of infection. Copyright HAV RNA can be detected in stool and serum samples using PCR. Copyright the presence of anti-HAV IgM antibodies or HAV RNA confirms active hepatitis A detection of anti-HAV IgG antibodies in the absence of anti-HAV IgM antibodies indicates immunity against HAV due to prior infection or vaccination. 3. Further testing. Further diagnostic testing is not routinely necessary but may be used to rule out differential diagnoses or fulminant hepatitis. If performed, additional tests may show the following findings: if acute viral hepatitis is present, liver biopsy, not routinely indicated. 10 copyright periportal inflammation, mononuclear cell infiltration, 11, O hepatocyte swelling copyright ballooning degeneration O bridging necrosis O Councilman bodies, apoptotic hepatocytes, 21 plus ultrasound 3 copyright increased brightness of portal vein radical walls copyright decreased echogenicity of the liver. V. Back collapse fine text outline EA. Differential diagnoses. For an overview comparing the different types of viral hepatitis, see overview of viral hepatitides. The differential diagnoses listed here are not exhaustive. OO. OFU. Treatment. Hepatitis A is generally self-limited. CENT offer supportive care. 5. O recommend rest as needed. -1 copyright consider symptomatic treatment, example antiemetics. E recommend alcohol avoidance. Use medications that are metabolized by the liver with caution, example acetaminophen. CENT more intensive treatment may be required in rare cases in which hepatitis A leads to acute liver failure. 270E. Prevention. Hepatitis A pre-exposure prophylaxis 6LL71. Advise all travelers to follow primary preventive measures such as food and water safety. Hepatitis A vaccine. See ACIP immunization schedule for scheduling details. CENT recommend routine active immunization for, copyright all children 12 months of age copyright individuals at increased risk of HAV infection, including those who, are traveling to a country in which HAV is endemic expect to be in close contact with an adoptee from a country in which HAV is endemic have a potential occupational exposure to HAV are men who have sex with men use injection or non-injection drugs have unstable housing copyright individuals at increased risk of severe disease individuals with chronic liver disease adults and children 12 months of age with HIV copyright any individual requesting to be vaccinated. Copyright hepatitis A vaccination is considered suitable for use during pregnancy in previously unvaccinated individuals with an increased risk of infection or severe disease. 6. Hepatitis A post-exposure prophylaxis 6. Post-exposure prophylaxis is indicated for all previously unvaccinated individuals who have been in contact with an individual with serologically confirmed hepatitis A within the past 2 weeks. Hepatitis A is a notifiable disease. Recommended regimens for hepatitis A post-exposure prophylaxis type of post-exposure prophylaxis indications active immunization healthy individuals who are 1 to 40 years of age. Individuals with contraindications for vaccination passive ion with 2 infants. Individuals with chronic liver disease immunocompromised individuals consider in adults, both active and passive immunization copyright greater than 40 years of age copyright with increased risk of infection, see hepatitis A pre-exposure prophylaxis. dd percent v back collapse fine text outline AE 6H hepatitis A 1/3 central vein bile duct interlobular vein portal triad branch of hepatic artery sinusoid hepatic microstructure hepatic lobule VV. A lobule is a roughly hexagonal structural unit in the liver, separated from adjacent lobules by connective tissue. In each lobule, plates of hepatocytes are separated by hepatic sinusoids. At the vertices, branches of the hepatic artery and portal vein are arranged with bile ducts into portal triads. The flow of blood is from peripheral to central, as blood from the arteries and veins in the portal triads mixes in the sinusoids and drains via a central vein. Note that sources differ regarding the distribution of portal triads, with some sources depicting them at every vertex of the hepatic lobules, as shown here, and others at only every second vertex. Copyright emboss. Urohepatitis A, 2/3. Branch of hepatic artery branch of portal triad vein interlobular bile duct. Liver sinusoid. Bile canaliculi. Central vein. Hepatic microstructure, hepatic lobule showing bile canaliculi VV. A lobule is a roughly hexagonal structural unit in the liver, separated from adjacent lobules by connective tissue. In each lobule, plates of hepatocytes are separated by hepatic sinusoids. At the vertices, branches of the hepatic artery and portal vein are arranged with bile ducts into portal triads. The flow of blood is from peripheral to central, as blood from the arteries and veins in the portal triads mixes in the sinusoids and drains via a central vein. Between the hepatocytes is a network of bile canaliculi, which drains bile towards the interlobular bile ducts in the portal triads. The flow of bile is from central to peripheral, and thus opposite to the flow of blood. Copyright emboss. Urohepatitis A, 3/3. SS 47/YY, IQ 3, OI equals AOA. AEECX at Luke at hepatic microstructure, sinusoids, parasinusoidal space, and hepatocytes equals NE. Sinusoid parasinusoidal space ITO cell hepatocyte OA microvilli. Kupfer cell. Discontinuous endothelium. Bile canaliculus. From the sinusoids, plasma can enter the parasinusoidal space through the highly fenestrated endothelium. Microvilli on the basolateral surface of the hepatocytes increase the surface area for efficient substance exchange. The apical surfaces of adjacent hepatocytes form the bile canaliculi, which drain into the peripherally located interlobular bile ducts. Copyright emboss. Urohepatitis A, 1/1. EESESEEEEE- Infection /TTTTTTO, D23456:78Y101112 1 weeks. HAV-RNA in serum. Serology of hepatitis A virus, HAV, infection VV. Anti-HAV IgM antibodies are detectable 5 to 10 days after infection, 5 to 10 days before clinical symptoms develop, with peak levels 1 month after infection. Levels typically become undetectable within 3 to 6 months post-infection. Assessing for the presence of anti-HAV IgM antibodies is the standard diagnostic test for active hepatitis A. During HAV infection, anti-HAV IgG antibodies are typically detectable when clinical symptoms develop and subsequently persist indefinitely. They are also produced in response to vaccination and are a marker of immunity to reinfection. HAV-RNA can be detected in stool and serum samples in patients with hepatitis A. This test is not routinely used but can be helpful during outbreaks, as HAV-RNA can be detected as early as the first week after infection. Copyright emboss. X. Hepatitis B. Hepatitis B is a viral infection caused by the hepatitis B virus, HBV. It occurs worldwide and is transmitted sexually, parenterally, or vertically. After an incubation period of 1 to 6 months, most patients develop asymptomatic or mild inflammation of the liver, which usually resolves spontaneously within a few weeks or months. However, 5% of adult patients and 90% of infants infected perinatally develop chronic hepatitis B, CHB. Individuals with CHB may be asymptomatic carriers or develop ongoing hepatic inflammation with an increased risk of cirrhosis and hepatocellular carcinoma. Serologic testing initially includes measurement of hepatitis B surface antigen, HBsAg, hepatitis B surface antibody, anti-HBs, and hepatitis B core antibody, anti-HBc. A detectable serum anti-HBs, indicating seroconversion, is a sign of recovery or successful immunization. CHB with persistent liver inflammation is characterized by detectable HBsAg and elevated HBV DNA and ALT. Treatment of acute hepatitis B consists of supportive measures. In patients with fulminant hepatitis, liver transplantation may be necessary. For chronic active hepatitis B, nucleoside or nucleotide analogues, example tenofovir, are the preferred agents for reducing viral replication and infectivity. Prophylactic immunization with a recombinant vaccine is recommended for all age groups. Other preventive measures include post-exposure prophylaxis for infants born to individuals with HBsAg positive or unknown status and for unvaccinated individuals with recent exposure to HBV. See also acute liver failure. Epidemiology. Cent prevalence. Following the introduction of the hepatitis B vaccine in 1991, rates of acute hepatitis B in the U.S. have declined by approximate 82%. I copyright in 2016 there were an estimated 862,000 cases, 0.3% of U.S. population, in the U.S., L2LLS. Copyright in 2015, there were 257 million cases worldwide, 3.5% of the global population. For copyright, the Western Pacific is the most affected region worldwide, 6.2% of its population. 4. Epidemiological data refers to the U.S., unless otherwise specified. WA. OOIOS. Etiology. Virus. Cent hepatitis B virus, HBV, O member of the hepatinovirus family. Copyright circular, partially double-stranded DNA virus. Cent. See general virology for more information on viral structure. Transmission. 41. Frequency and patterns of transmission vary worldwide. 1. Cent. Sexual, transmitted when bodily fluids come in contact with broken skin or mucous membranes, mouth, genitals, or rectum. Cent. Parenteral. Copyright contaminated needles or instruments, including those for procedures like body piercings, tattoos, and acupuncture, that come into contact with the patient's blood. Copyright blood transfusions or organ transplants. Vertical transmission, mother-to-child transmission, 4 common associations. Copyright hepatitis C virus, HCV, and HIV-positive individuals. Copyright travelers to regions where HBV is endemic. 5. Risk factors for HBV infection and groups at risk, 42728. Cent. Vertical transmission. Copyright individuals born in countries with medium to high HBV prevalence, equals 2%. Unvaccinated children born to parents from countries with high HBV prevalence, equals 8%. Copyright infants born to HBsAg positive individuals. Cent. Parenteral or sexual transmission. Copyright injection drug use, current or previous. Copyright history of sexually transmitted infections or multiple sexual partners. O. Sex workers. EO. Men who have sex with men. V. Back collapse. Find text outline. U.S. O. Household, sexual, or needle-sharing contacts of individuals with HBV infection. O. Current or previously incarcerated individuals. O. Healthcare personnel, example needle stick injury, Copyright HIV infection OHCV infection, current or past, copyright chronic liver disease degree end-stage renal disease copyright dialysis. 7 VU 6. Pathophysiology. Replication cycle of HPV, 1L101I11. HPV carries a DNA polymerase with both DNA and RNA-dependent functions, also known as reverse transcriptase, RT. 1. After entering the host cell's nucleus, reverse transcriptase completes the positive strand of the virus's partially double-stranded relaxed circular DNA, re-DNA. 2. The rcDNA is converted to covalently closed circular DNA, cccDNA, primarily by host enzymes in a process that is not entirely understood. 3. The cccDNA is then transcribed into viral mRNA by host RNA polymerase. 4. The viral mRNA leaves the nucleus and is translated into HPV core proteins and new reverse transcriptase in the cytoplasm. 5. Viral mRNA and reverse transcriptase are packaged into a capsid, where viral mRNA is then reverse transcribed into viral rcDNA. 6. New viral DNA genomes are enveloped and leave the cell as progeny virions. Acute infection 121. In acute infection, the cellular immune response causes damage to hepatocytes. Sent hepatitis B infected hepatocytes express viral peptides. On their surfaces, detection of the HPV-derived peptides by lymphocytes and the subsequent activation of CD8 plus T cells that attack the infected hepatocytes. Hepatic inflammation with destruction of hepatocytes 13. Chronic infection 14. Caused by viral persistence due to failing immune clearance, which promotes persistent hepatic inflammation, necrosis, mitosis, and regeneration processes, cirrhosis and cellular dysplasia, hepatocellular carcinoma, HCC, plus integration of HPV DNA into the host genome, altered expression of endogenous genes, chromosomal instability. HCC1 sent HPV proteins fulfill numerous immune modulating functions that allow them to elude detection by the immune system and avoid clearance. 13. ERNI. E. OIOE. Clinical features. Acute hepatitis B virus infection. Acute HBV infection is defined as infection acquired in the past 6 months. Sent incubation period, 1 to 6 months. Clinical course, varies significantly, 15L, 16L. Copyright serum sickness-like syndrome can develop during the prodromal, preicteric, period 1 to 2 weeks after infection, rash, arthralgias, myalgias, fever. 17. Copyright subclinical hepatitis, 70% of cases, 1/21. Asymptomatic hepatitis, 30% of cases. See also acute viral hepatitis, equals fever, skin rash, arthralgias, myalgias, fatigue equals nausea, anorexia equals jaundice equals right upper quadrant pain. O symptoms usually resolve after a few weeks, but can last up to 6 months. 2. O may develop into fulminant hepatitis, 0.5% of cases. Chronic hepatitis B virus infection, 14. Chronic HBV infection is defined as infection persisting for more than 6 months with detection of HBsAg and, possibly, signs and symptoms of liver damage. Most patients are inactive, non-contagious carriers. 18. Potential reactivation of chronic inactive hepatitis can manifest variably in the following ways. O asymptomatic 1V. Back collapse. Fine text outline EE, 6H. O asymptomatic. Copyright unspecific symptoms equals fatigue, malaise equals nausea, poor appetite equals unspecific abdominal pain. Copyright similar to acute hepatitis. Copyright hepatic failure J. E. The younger when infected, the more likely a patient develops chronic HBV-19. Copyright 90% of infants. Copyright 50% of children between 1 and 5 years. Copyright only 5% of adults. OIOE. Overview of HBV serology. Overview of HBV antigens and their corresponding antibodies. HBV antigen/DNA description. Corresponding antibodies. Scent protein on the surface of HBV *anti-HBs papadals aongen * first evidence of infection. 20 Copyright indicates immunity to HBV due to resolved infection or vaccination * presence for 2-6 months indicates a chronic infection. Copyright usually appears within 3 months of infection or vaccination. *anti-HBe_. Scent protein of the nucleocapsid. Copyright anti-HBc IgM, indicates recent infection with HBV, within. _protein secreted by infected hepatocytes into the bloodstream. SREB EPAES SENA RN Ana-Uslo hepatitis B antigen, HBAG, indicates active viral replication and thus high transmissibility and a poor risk prognosis. St. Screening. Indications for HBV screening, 71 L221 I23. Obtain initial HBV serology for the following individuals. See diagnostics for interpretation of results. Sent all individuals aged = 18 years, at least once per lifetime. Sent pregnant individuals, once per pregnancy, preferably in the first trimester. See perinatal hepatitis B. 24 * individuals with risk factors for HBV infection. 1. 71 L25 sent patients with elevated transaminases of unknown etiology * blood and tissue donors. 23 individuals who require immunosuppression. 23 any individual who requests screening. VAYFO, OA. Diagnostics. Approach 231 L8 I26. Suspected acute HBV infection. Obtain HBV serology to confirm the diagnosis. Sent consider routine laboratory studies to assess liver damage and function. 7. Back collapse. Find text outline EAE. Chronic HBV infection. Sent perform a clinical evaluation to assess for degree risk factors for comorbid liver disease, example high-risk alcohol use, metabolic syndrome or family history of HCCEO, symptoms of cirrhosis. Sent assess for liver fibrosis. Sent screen for other infections, including HCV, HDV, and HIV. Sent consider abdominal ultrasound and / or liver biopsy in certain patients. HBV serology, equals L2 sent LL2327. Sent indications. Copyright screening for HBV infection. Patients with symptoms of acute HBV infection or chronic HBV infection plus initial tests. 2 Silel 70 HBsAg. Copyright anti-HBCO anti-HBs. Sent interpretation. Copyright HBsAg or anti-HBc IgM is detected, positive for HBV. Copyright chronic HBV infection is confirmed if positive results persist for = 6 months. Sent further disease markers, indicated to assess disease activity if initial tests are positive. OHBAG, marker of high HBV replication and transmissibility. Copyright anti-HBe, an undetectable HBAG with development of anti-HBe indicates immune clearance or an inactive carrier state. OHBV DNA, quantification of viral load. Interpretation of hepatitis B serology. Acute infection window period. Active, high transmissibility, chronic infection inactive, low transmissibility. Resolved infection immunity. HBV vaccination. HBsAgt. Undetectable. ACAT. Undetectable. Interpretation of hepatitis B serology, 2023-28 anti-HBs undetectable. Undetectable. Anti-HBc HBAG anti-HBe IgM undetectable. IgM IgG undetectable or 7. Undetectable, IgG 7CJ undetectable. IgG undetectable. IgG undetectable. HBV DNA. Undetectable or T undetectable or T. HBV DNA 2000 IU/ml. HBV DNA S 2000 IU/ml. Undetectable. Transaminases 1, Alt-AST, 1, Alt-AST. Normal or TJ. Normal 1. Undetectable. HBAG, beware. Extremely infectious. During the window period, anti-HBC IgM and anti-HBe may be the only markers available to diagnose an acute HBV infection. Seroconversion of HBsAg to anti-HBs indicates resolution of acute hepatitis. Additional laboratory studies 271I26. Liver chemistries, elevated in acute infection, normal or elevated in chronic infection. O mixed hyperbilirubinemia. O ferritin. O alp. O GGT. O alt and AST equals AST alt ratio 1 in chronic hepatitis may be a sign of cirrhosis. Scent laboratory diagnostics for cirrhosis. EOJ albumin, TINR. Copyright F. bilirubin. OJ platelets plus evaluation of co-infection, copyright hepatitis C serology, anti-HCV antibodies, E. hepatitis D, anti-HDV antibodies, E. HIV testing. Back. V equals DQ. Collapse. Find text. E. US. A. Outline. Scent evaluation of co-infection. Ta. Copyright hepatitis C serology, anti-HCV antibodies, copyright hepatitis D, anti-HDV antibodies, copyright HIV testing. Copyright hepatitis A serology, anti-HAV IgG antibodies. 1. O. Laboratory findings in chronic HBV infection are highly variable. Liver function tests may be normal or only mildly abnormal. Abdominal ultrasound 291 I271 I261. Indication: to evaluate liver parenchyma and biliary tract and screen for fibrosis and/or HCC. Scent findings in acute hepatitis. OJ liver echogenicity. Copyright 7 echogenicity of portal vein radical walls. Scent findings in chronic hepatitis. Degree 7 liver echogenicity. Copyright J echogenicity and number of portal vein radical walls. Liver biopsy 271. Scent indications. Copyright diagnostic uncertainty when results will be used to guide treatment decisions. Copyright exclusion of other possible causes of liver damage in chronic disease or severely affected individuals. O assessment of the severity of liver disease. Scent findings. See pathology of viral hepatitis. Feedback. OD your notes. RO shared notes. Manage. Pathology. Active viral hepatitis 3 degree I31. Scent eosinophilic single-cell necrosis, Councilman bodies, scent bridging necrosis. Scent Kupffer cell proliferation. Chronic viral hepatitis 0 LL31. Scent formation of lymphoid follicles and mononuclear infiltrates. Interface hepatitis, piecemeal necrosis, AO periportal liver cell necrosis with lymphocytic infiltration. O the cause of interface hepatitis is a CD8 T-cell induced hepatocyte apoptosis. Indicates chronic active hepatitis and poor prognosis. Plus fibers septa, 09/82 plus ground glass hepatocytes. 33E hepatocytes with swollen transparent cytoplasm due to hyperplasia of the endoplasmic reticulum resulting in a ground glass appearance. E pathognomonic for hepatitis B. Copyright result from increased production of viral membrane particles, HBsAg. QB ground glass hepatocytes are pathognomonic for HBV, whereas interface hepatitis, fibers septa, and periportal infiltrates also occur in other types of chronic hepatitis. Feedback 40 for your notes. A shared notes. Manage. Differential diagnoses. NN ala al. Back collapse. Find text outline. X hepatitis B. Differential diagnoses. For an overview comparing the different types of viral hepatitis C. Overview of viral hepatitides. The differential diagnoses listed here are not exhaustive. OSOE. Treatment. Approach 23, 27, 26, 28. Sent all patients. Copyright provide supportive care and patient education as needed. Copyright consider referral for liver transplantation in patients with end-stage liver disease due to HBV fulminant hepatic failure, emergency transplantation, sent acute hepatitis B. Copyright antiviral therapy is generally not indicated. Sent chronic hepatitis B. Assess the need for antiviral therapy. Most acute hepatitis B infections in adults are self-limited. Antiviral therapy is not routinely indicated. Antiviral therapy for chronic hepatitis B 23L271I2 Sent 1. Treatment decisions should be made by a specialist and based on the risk of liver-related morbidity and mortality. The following information applies to non-pregnant individuals. For pregnant individuals, see Management of hepatitis B in pregnancy. Sent indications for antiviral therapy for HBV infection include copyright cirrhosis or advanced fibrosis, copyright acute liver failure O immune active phase, alt equals 2xULN plus significantly elevated HBV DNA levels with or without HBAG O HBV reactivation, copyright co-infection with HCV or HIV. Sent agents. For details on mechanisms of action and adverse effects, see Overview of antivirals against hepatitis B and Overview of antivirals against both hepatitis B and C. O-nucleotide reverse transcriptase inhibitors, NTRTs, example tenofovir disoproxyl fumarate, TDF, or tenofovir alafenamide, TAF, O-nucleoside reverse transcriptase inhibitors, NRTIs, example entecavir, ETV, O-pegylated interferon alpha, PEG-IFNA, sent treatment regimens. ONTRTLS or NRTIs are usually the preferred option. Treatment duration varies but can be indefinite. OPEG-IFN, example for 48 weeks, is a treatment option for certain patient groups, example patients with HDV co-infection. Treatment goals include immunologic cure, i.e., clearance of HBsAg and sustained HBV DNA suppression, and reduction of liver-related morbidity and mortality. Pegylated interferon is a pregnancy category C drug, and is contraindicated in patients who have decompensated cirrhosis or uncontrolled psychiatric conditions. Supportive care and patient education. Avoid hepatotoxic medications. Advise alcohol cessation. Provide treatment of alcohol use disorder and or management of substance use disorder as indicated. Provide counseling on weight and diet changes to encourage weight loss as indicated. 34. Educate patients on measures to prevent HBV transmission, including 23. Degree vaccinating household and sexual contacts, abstaining from blood and tissue donation, practicing safer sex, example using condoms, covering open wounds, cleaning up blood spills with diluted bleach, avoiding for drug use or practicing harm reduction strategies if injecting drugs, avoiding sharing of personal care items, such as razors, toothbrushes, glucometers, and injection equipment. Degree. HBV can survive outside the body, example in dried blood on a surface, for at least 7 days, and remains infectious during that time. I5. V. Back collapse. Find text outline. Complications. Acute liver failure. Plus epidemiology, affects 1% of acute HBV infections. 85. Diagnosis, evidence of hepatic injury, example T transaminases, 7 bilirubin, hepatic encephalopathy, and coagulopathy, INR 1.5. Management, see acute liver failure. Long-term complications of hepatitis B, 14. Sent liver cirrhosis plus hepatocellular carcinoma, HCC, 1/3 Sent L plus extrahepatic manifestations, 10 to 20% of cases, 187. Copyright polyarteritis nodosa, strong correlation, in 36% of cases, hepatitis B virus is the causative agent, 38L Copyright glomerulonephritis equals membranous glomerulonephritis, more common, equals membranoproliferative glomerulonephritis type 1, less common, copyright aplastic anemia scent reactivation of previous HBV infection due to immunosuppression * post-hepatitis syndrome copyright chronic fatigue, weakness or nausea, loss of appetite possible upper quadrant pain. We list the most important complications. The selection is not exhaustive. WA Degree IEEE Prevention Vaccination /51L39 Scent. The hepatitis B vaccine, HBV vaccine, is an inactivated recombinant vaccine that contains a subunit of the hepatitis B virus. 40 Scent. A 3-dose HBV vaccine series should be administered to all infants at birth. Copyright birth weight equals 2 kilograms, within 24 hours after birth. Birth weight. Infants and children who did not receive a dose of vaccine at birth should receive the first dose as soon as possible. Hepatitis B post-vaccination serology /5LL25 Registered in infants, do not check post-vaccination serology until they are at least 9 months of age and their last HBV vaccine dose was at least 1 month ago. 42. Scent. Anti-HBs equals 10 IU/ml, immune, and no further management is required. Scent. Anti-HBs. Hepatitis B post-exposure prophylaxis 5. For perinatal post-exposure prophylaxis recommendations, see infants born to individuals with HBsAg positive or unknown status. Scent. Exposure is defined as percutaneous or mucosal contact with blood or body fluids. Scent. HBV PEP recommendations differ for exposures in occupational and non-occupational settings. Scent. Depending on immunization status, affected individuals will receive one of the following: copyright active immunization, i.e., hepatitis B vaccination, passive immunization, i.e., hepatitis B immune globulin, copyright combined active and passive immunization, copyright no intervention. Occupational exposure, i.e., healthcare providers. HBV PEP for occupational exposure 5 Source Nation v. Back collapse. Find text outline. Occupational exposure, i.e., healthcare providers. HBV PEP for occupational exposure 5 Source patient HCP vaccination status HBsAg negative, HBsAg positive or unknown, anti-HBs 10 μU/ml, no intervention required, complete series anti-HBs. Non-occupational exposure. Exposure types include needle sharing and high-risk sexual contact. HBV PEPing ional exposure 5LL441. Source individual patient vaccination status HBsAg unknown, HBsAg positive. Anti-HBs equals 10 μU/ml. Scent. No intervention required, complete series anti-HBs. OS. OOB. Perinatal hepatitis B. Approach 45 17115. Scent. Perform universal screening for HBV in pregnancy, preferably in first trimester. If anti-HBs 200,000 IU/ml. Scent. Provide appropriate immunoprophylaxis to infants born to individuals with HBsAg positive or unknown status. Administer first dose of HBV vaccine within 12 hours of birth. Copyright infants born to HBsAg positive individuals. Additionally, administer 1 dose of HBIg within 12 hours of birth. Hepatitis B in pregnancy /451-23127. The prevalence of HBV infection in pregnant individuals in the U.S. is 0.9%. 46. Screening for HBV infection in pregnancy 451 I71 241. Method. Scent. During each pregnancy, as part of initial prenatal screening for comorbidities during the first trimester, all pregnant individuals, test for HBsAg. Copyright individuals with any of the following: Measure anti-HBs and anti-HBC titers. Equals no documented completion of HPV vaccine series equals no documented initial HPV serology after 18 years of age equals risk factors for HPV infection developed after documentation of initial HPV serology and/or are ongoing. Management of HPV infection in pregnancy 471I48. During pregnancy. Sent for patients with newly positive HBsAg on prenatal screening, obtain additional HPV serology sent refer to infectious disease and/or hepatology specialists. Plus evaluate the need for antiviral therapy with tenofovir disoproxil fumarate, preferred drug, 1, 27148E standard indications for antiviral therapy for HPV infection. Example cirrhosis. A hepatologist may recommend therapy throughout pregnancy to prevent complications. 271/48E HPV DNA 200,000 IU/ml. Initiate therapy during the third trimester to reduce the risk of vertical transmission. Antiviral treatment is recommended in pregnant individuals with an HPV viral load 200,000 IU/ml to reduce the risk of vertical transmission. 45b. Back collapse. Find text outline. X. Hepatitis B. The prevalence of HPV infection in pregnant individuals in the U.S. is 0.9%. 46. Screening for HPV infection in pregnancy 45 LL71I24. Method. Sent during each pregnancy, as part of initial prenatal screening for comorbidities during the first trimester. Copyright all pregnant individuals, test for HBsAg. 1. Copyright individuals with any of the following, measure anti-HBs and anti-HBC titers. Equals no documented completion of HPV vaccine series equals no documented initial HPV serology after 18 years of age equals risk factors for HPV infection developed after documentation of initial HPV serology and/or are ongoing. Management of HPV infection in pregnancy 471,148. During pregnancy. Sent for patients with newly positive HBsAg on prenatal screening, obtain additional HPV serology refer to infectious disease and/or hepatology specialists. Plus evaluate the need for antiviral therapy with tenofovir disoproxil fumarate, preferred drug, 271I48. Copyright standard indications for antiviral therapy for HPV infection. Example cirrhosis. A hepatologist may recommend therapy throughout pregnancy to prevent complications. 271/48 HPV DNA 200,000 IU/ml. Initiate therapy during the third trimester to reduce the risk of vertical transmission. Antiviral treatment is recommended in pregnant individuals with an HPV viral load 200,000 IU/ml to reduce the risk of vertical transmission. 45. Pegylated interferon alpha is a pregnancy category C drug and is therefore not recommended as first-line therapy for HPV infection in pregnant individuals. 48. During delivery. Sent HPV infection is not an indication for cesarean delivery. 45-23 plus follow standard precautions. 49. After delivery. Sent breastfeeding may be started immediately if there are no contraindications, example cracked or bleeding nipples, * continue close monitoring, example of HPV DNA and ALT levels, for at least 6 months postpartum. 47 Hepatitis B in infants /5 LL251I45. Management of infants born to individuals with HBsAg positive or unknown status. These infants are at risk of acquiring perinatal HPV infection and developing complications. Administer the birth dose of HPV vaccine to all infants within 12 hours of life. Sent if the birthing parent's HBsAg status is unknown, obtain test immediately. Determine the need for HBIG. Copyright. This depends on the birthing parent's HBsAg status and infant's birth weight. Copyright. If HBIg and HBV vaccine are administered concurrently, they should be given in different limbs. Report case to state and local perinatal hepatitis B prevention programs, see tips and links. Infants born to HBsAg positive individuals should receive 1 dose of HBIg and the first dose of HBV vaccine within 12 hours of birth. 5L25. If birth weight is infants with HBV infection. Scent transaminases are usually normal or only mildly elevated. 1 acute hepatitis B may develop in rare cases. Chronic HBV infection 5L copyright develops in 80 to 90% of infants infected at birth. Copyright 25% of those with chronic infection develop cirrhosis or liver cancer, leading to premature mortality. And V. Back collapse. Find text outline. Hepatitis B, 1/3. Central vein bile duct interlobular vein portal triad branch of hepatic artery sinusoid. Hepatic microstructure, hepatic lobule VV. A lobule is a roughly hexagonal structural unit in the liver, separated from adjacent lobules by connective tissue. In each lobule, plates of hepatocytes are separated by hepatic sinusoids. At the vertices, branches of the hepatic artery and portal vein are arranged with bile ducts into portal triads. The flow of blood is from peripheral to central, as blood from the arteries and veins in the portal triads mixes in the sinusoids and drains via a central vein. Note that sources differ regarding the distribution of portal triads, with some sources depicting them at every vertex of the hepatic lobules, as shown here, and others at only every second vertex. Copyright emboss. Urohepatitis B, 2/3. Branch of hepatic artery, branch of portal triad vein interlobular bile duct. Liver sinusoid. Bile canaliculi. Central vein. Hepatic microstructure, hepatic lobule showing bile canaliculi VV. A lobule is a roughly hexagonal structural unit in the liver, separated from adjacent lobules by connective tissue. In each lobule, plates of hepatocytes are separated by hepatic sinusoids. At the vertices, branches of the hepatic artery and portal vein are arranged with bile ducts into portal triads. The flow of blood is from peripheral to central, as blood from the arteries and veins in the portal triads mixes in the sinusoids and drains via a central vein. Between the hepatocytes is a network of bile canaliculi, which drains bile towards the interlobular bile ducts in the portal triads. The flow of bile is from central to peripheral, and thus opposite to the flow of blood. Copyright emboss. Urohepatitis B, 3/3. SS 47/YY, IQ 3, OI equals AOA. AEECX at LOC at hepatic microstructure, sinusoids, parasinusoidal space, and hepatocytes equals NE. Sinusoid parasinusoidal space ITO cell hepatocyte OA microvilli. Kupfer cell. Discontinuous endothelium. Bile canaliculus. From the sinusoids, plasma can enter the parasinusoidal space through the highly fenestrated endothelium. Microvilli on the basolateral surface of the hepatocytes increase the surface area for efficient substance exchange. The apical surfaces of adjacent hepatocytes form the bile canaliculi, which drain into the peripherally located interlobular bile ducts. Copyright emboss. Urohepatitis B, 1/2. HBV-infected hepatocyte HBcAg, nucleocapsid, \OHBsAe. 7. DNA polymerase DNA. %lipid bilayer. Hepatitis B antigens VV. The hepatitis B surface antigen, HBsAg, is found on the outer wall of the virion's lipid bilayer and confirms the presence of the virus in the blood. HBsAg is the first indicator of infection and can be detected as early as 1 week after infection. An infected hepatocyte may also release the hepatitis B envelope antigen, HBAg, a protein produced by the virus that serves as an indicator of active viral replication. Copyright emboss. Hepatitis B, 2 halves. HBAg period I anti-HBC total. Infection J\XSS, anti-HBC IgM \anti-HBSPs UEE on P equals EE. Anti-HBE GSTT TTTTO, 62345. HBV DNA 7 transaminases months years. Serology time course of acute and resolved hepatitis B infection VV. Schematic depiction of the time frames in which HBV DNA, antigens, and antibodies are measurable, and transaminases elevated, during acute HBV infection and resolution. Note that the timing can vary significantly between patients and that the pattern in chronic infection differs. The window period is an interval in which HBsAg is no longer measurable, anti-HBs is not yet measurable, and only anti-HBC and anti-HBE can be detected. HBV DNA, hepatitis B virus DNA, HBsAg, hepatitis B surface antigen, HBAg, hepatitis B e antigen, anti-HBC IgM, anti-hepatitis B core antigen IgM antibody, anti-HBC total, anti-HBC IgM plus anti-HBC IgG, conventionally measured together, anti-HBs, anti-hepatitis B surface antigen antibody, anti-HBE, anti-hepatitis B antigen antibody. Copyright emboss. Hepatitis B, 1/5. Overlay. Councilman body VV. Photomicrograph of a hepatic tissue sample, H&E stain, 400x magnification. There is heavy necroinflammatory activity in this hepatic lobule. The hepatocytes show reactive changes, including prominent swelling, exemplary green outline. Several apoptotic hepatocytes, also known as acidophilic bodies or Councilman bodies, examples indicated by yellow outlines, are visible. These findings are typical of inflammatory changes consistent with an acute viral hepatitis, in this case hepatitis B exacerbated by hepatitis E co-infection. Source, Fig 1, in, hepatitis E virus superinfection, an under-recognized trigger of acute hepatitis B virus flare by a Beta AE, Monty G, Saeao W, Shinoda H, Lim H, Curious, licensed under CC by 4.0. Modifications, removal of the white arrow in the center of the image. Hepatitis B, 2/5. Overlay. Chronic hepatitis B VV. Photomicrograph of a liver biopsy specimen, H&E stain, high magnification, a chronic inflammatory infiltrate, blue overlay, consisting of lymphocytes, plasma cells, and eosinophilic granulocytes can be seen in the center of the image. The infiltrate is located at the interface of the portal tract and hepatic lobules, yellow overlay, which is referred to as interface hepatitis. These features are typical of chronic hepatitis. In this case, hepatitis B chronic inflammation of any tissue typically shows mononuclear cell infiltration. Example lymphocytes, plasma cells, macrophages, and fibrosis may be present simultaneously as well, not present here. Source, File 617281676469188SL5 by Texas Pathologist WSW, Wikimedia Commons, licensed under CC by SA 4.0. Hepatitis B, 3/5. Overlay. Liver cirrhosis in chronic hepatitis B. Photomicrograph of liver tissue of a patient with chronic hepatitis B infection, H&E stain, low magnification, there is total loss of liver tissue architecture, absence of defined hepatic lobules, combined with bridging fibrous septa, yellow overlay. These findings indicate liver cirrhosis following chronic viral hepatitis. Source: Copyright IMPP. SOE. Overlay. Liver cirrhosis in chronic hepatitis B. Photomicrograph of liver tissue of a patient with chronic hepatitis B infection, H&E stain, low magnification, there is total loss of liver tissue architecture, absence of defined hepatic lobules, combined with bridging fibrous septa, yellow overlay. These findings indicate liver cirrhosis following chronic viral hepatitis. Source: Copyright IMPP. Eurohepatitis B, 4/5. Overlay. Chronic hepatitis B VV. Photomicrograph of a liver biopsy specimen, H&E stain, high magnification, most of the hepatocytes have a pale, homogeneous cytoplasm, ground glass hepatocytes, examples marked by blue overlay. Ground glass hepatocytes are often found in chronic hepatitis B infection. Source: Ground glass hepatocytes high mag 2 by Michael Bonard, Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Equals 72A, equals A in IP, CL00 5 and X7, YAT. 4 REI. Me. OLTINEGS. Bala *_AAIA at. Overlay. Chronic hepatitis B. Photomicrograph of a liver biopsy specimen, H&E stain, high magnification, most of the hepatocytes have a pale, homogeneous cytoplasm, ground glass hepatocytes, examples marked by blue overlay. Ground glass hepatocytes are often found in chronic hepatitis B infection. Source: Ground glass as hepatocytes high HH mag 2 by Michael Bonard, Nephron, Wikimedia Commons, licensed under CC by SA 3.0. PW equals WOJAA, ABLES in OOA. Copyright of Smart Zoom. Histopathological changes in chronic hepatitis B. Click on the microscope icon to view the entire specimen through a virtual microscope. Source: Copyright Smart Zoom, Smart in Media. Image and annotations in digital microscopy, PDDRMED Alberto Perez Buza, Focharst für Pathology. Smart Zoom Viewer. Powered by Smart Zoom. Copyright 2023 Smart in Media. Smart Zoom Viewer. 7E pound at equals. Degree registered. OE. P% star. BS cent EAE. At SVE. Cent degree 4 EA. PI at 64. I-YT. Asterisk ET Fay at. Slash, EE2 at OE. LS degree SE. EEIs. EEEM5J registered. Yen degree registered 6. A asterisk dash. Asterisk EO. Y hashtag at P we registered E asterisk D. Dash asterisk AUF, 9, registered dash at E1BY re. Off 3A asterisk VAT CE is 6 at QE at. Asterisk EE backslash equals OA registered. 4 at percent at 2E. 7 EE copyright 0% EASI re WYYA2 registered 019, 2 NSOI. Registered asterisk AE, A9, AOE LOFA 822, re VTT. 4 backslash Y asterisk S4, portal field XOB, and registered J9A. Underscore 9 plus portal fields, also known as portal areas or portal $*GE at, OAE Euro, tracks, consist of portal triads of the following: 9 OPS 1 a branch of the hepatic artery and 2 a branch of the portal vein, copyright. A portal field also contains lymphatic vessels and degree. Small branches of the vagus nerve. These structures 8 copyright and O are often difficult to identify. EEGEESRO, 7, E. HW equals R, E and E. Lapira plus 2 at 3F, AE4W 257 Ru EAE I7A, OSEYESESYWR 5 euros. VE registered OS dollar asterisk EE asterisk registered EBT 7 asterisk 42 TNIHE a ping. Bad OBE backslash asterisk ya underscore. E asterisk euro, degree backslash a euro asterisk ER dash asterisk backslash. J asterisk slash yen percent E. CSA, A, pair NSS4, VY. Smart Zoom Viewer. GY Rally, POA underscore POP4E ground glass hepatocyte A asterisk, 7 asterisk percent SD add, S. WZTE degree a ground glass hepatocyte is a hepatocyte with a degree plus PEESTA. 4 Smart Zoom Viewer. N. Central vein X equals asterisk registered. Add yen, Q and plus each central vein is located in the center of a classic SSES4 at a yen asterisk me liver lobe. They receive mixed blood from the liver re7 al, asterisk sinusoids and return it to systemic circulation via the hepatic vein. And equals EEOE at, OE at. Degree. EEOSOE at asterisk equals, copyright $we. Registered. Registered yen e euro. BSSS asterisk S. 7 ROM, EERAAEA, asterisk E4 JABI SG Pi AARSSENEOA. HA at 2W7 at degree. T asterisk, S. And at asterisk G registered P. EAY backslash G Sun. 74. QLA. Asterisk A, by and percent and, at registered at 2 Fe. Underscore. And P, E. V4 asterisk at degree. 8. 4 asterisk, registered IDECS, Feoy at A. Degree K, W degree, JPA XAQEA and AR registered equals EA. Asterisk, degree RA $4 AE at. Equals BD. 47 Copyright 2023 Smart in Media Dive Mag backslash comma, FG is. Smart Zoom Viewer. / star. P424. New York discrete inflammation of the portal fields X asterisk Fe. Percent, OB2ES degree 4EB and in this case, only mild chronic inflammation of the EEE cent TASAES at E% plus portal fields, mild chronic hepatitis, is present OE copyright EE54M0 backslash V3S at 7D.KE, AEEY OIRIN, adds We3ZO. Asterisk, asterisk, AQ, copyright XEOR asterisk A asterisk at E24S registered ES. T. 0, registered ION. EEEIS asterisk E copyright PTO. 2, registered asterisk ETES at asterisk, underscore ELO 2, 7 asterisk MSES WEOE. And. Backslash E. EO. A equals. 2O. Registered 6 ME IUS EE4 EEES copyright ES6 to 4. Asterisk, degree EE. 4% asterisk E7 degree bad. SFEOE asterisk air asterisk IJ ETSSBS. Degree. Cent add. Degree asterisk E. 4% registered at. A asterisk and A. Y. A. Powered by Smart Zoom. Copyright 2023 Smart in Media. X. Hepatitis C. Hepatitis C is an infection caused by the hepatitis C virus, HCV, which attacks liver cells and causes liver inflammation. HCV is a blood-borne pathogen commonly transmitted through needle stick injuries in healthcare settings or through shared drug injection needles. Screening plays a central role in detecting HCV infection because most infected individuals are asymptomatic or mildly symptomatic. Approximately 85% of individuals with an acute infection that is not recognized and treated will develop chronic hepatitis C, which is associated with cirrhosis, hepatocellular carcinoma, and increased mortality. The presence of HCV antibodies and HCV RNA confirm the diagnosis. HCV infection can be safely and effectively treated with direct-acting antivirals, DAAs, which have cure rates of over 95%. Simplified algorithms for the use of DAAs in treatment-naive patients without decompensated cirrhosis reduce the need for specialist-guided care. Heats 0. CE. Definition. Scent acute hepatitis C, HCV infection that develops during the first 6 months following the exposure. Scent chronic hepatitis C, HCV infection that persists beyond 6 months following the exposure. NL 7 OSOD. Epidemiology. Etiology. Pathogen. Scent hepativirus C, hepatitis C virus RNA virus of the hepativirus genus and Flaviviridae family. Scent. The risk of chronic infection is multifactorial and depends on the host's ability to clear the pathogen through activation of multiple innate immunity pathways against the viral envelope. 5. Flawed proofreading capability of RNA-dependent RNA polymerase, No35 activity, introduces mutations into genes encoding viral glycoprotein envelope and enabling novel antigen production. Copyright. Rapid replication rate produces many antigenically unique viral envelopes. Infection persists because the production rate of new mutant virions exceeds the production rate of host antibodies. Asterisk. There are 6 genotypes. In the US, the main ones are genotype 1, 65 to 80%, and genotype 2, 10 to 15%. Scent reinfection with another HCV genotype is possible. Transmission. Scent parenteral degree needle sharing among individuals who use injection drugs, needle stick injury, example healthcare workers. 71 Copyright blood transfusion. 18 Copyright dialysis. Scent organ transplantation. Scent sexual, rare, in contrast to HPV and HIV. Scent perinatal, vertical, risk factors for HCV infection. Scent injection drug use, past or current, especially long-term use. A9 Scent hepatitis B virus or HIV positivity. Scent history of incarceration plus individuals born between 1945 and 1965. 1/01 Scent individuals who received a blood transfusion or organ transplant before 1992. 1. Patients at high risk of HCV infection should be tested. WAOE. Clinical features. V. Back collapse. Fine text outline. Clinical features. Incubation period 2 weeks to 6 months. Acute course. Asymptomatic in 80% of cases. Symptomatic. See acute viral hepatitis, malaise, fever, myalgias, arthralgias ORUQ pain, tender hepatomegaly nausea, vomiting, diarrhea jaundice, possibly pruritus I. Symptoms are nonspecific and may be similar to those of other acute viral infections. Chronic course. Seen especially in asymptomatic individuals, up to 85%, as the disease may go undiagnosed and treatment may be delayed or never initiated. Carrier state. High, findings often mild, nonspecific, example fatigue, plus liver cirrhosis, up to 25% of cases, within 20 years of infection. 11 extrahepatic features of HCV, common, eohematological equals mixed cryoglobulinemia lymphoma, especially B-cell non-Hodgkin lymphoma, IDP autoimmune hemolytic anemia equals monoclonal gammopathies. Renal equals membranoproliferative glomerulonephritis, more common, equals membranous glomerulonephritis. OE rheumatological equals polyarteritis nodosa equals Sjogren's syndrome. Copyright dermatological equals porphyria cutanea tarda equals lichen planus. O endocrine equals diabetes mellitus equals autoimmune thyroiditis, may lead to hypothyroidism. O vascular, leukocytoclastic vasculitis. Copyright others, sialidinitis. 7. Screening. Individuals without risk factors for HCV infection 121131114. Plus all individuals aged equals 18 years, at least once per lifetime, IL-15 pregnant individuals, once per pregnancy. 14. Add, the CDC recommends against universal screening in settings where HCV disease prevalence is. Individuals with risk factors for HCV infection, 151L141. Sent one-time screening O upon diagnosis with HIV. Copyright individuals. Back collapse. Find text outline. Diagnostics. Hepatitis C tests 15. Sent anti-HCV antibodies, EIA/ELISA immunoassay initial test for immunocompetent individuals who are HCV naive. HCV RNA, qualitative PCRO if anti-HCV antibody test is positive. Interpretation of hepatitis C tests. Interpretation of hepatitis C tests. 15 anti-HCV antibodies negative positive netity * no infection * resolved infection negative S * or within the window period * or false positive antibody test. HCV RNA * active infection positive. Copyright within the window period * active infection, acute or chronic, copyright or patient is immunocompromised - Anti-HCV antibodies may take as long as 6 weeks after HCV exposure to be detectable on tests. HCV RNA may take as long as 2 to 3 weeks after viral exposure to be detectable on tests. Additional evaluations, 121. Laboratory studies. Sent viral load determination, quantitative PCR for HCV RNA. Sent routine studies. Copyright CBC, BMP. Copyright O hepatocellular enzymes equals normal or T transaminases, 10 to 20 xuln, 61 equals fluctuating alt peaks indicate acute HCV infection. 15 O cholestasis parameters equals 1 GGT equals T alkaline phosphatase equals 7 bilirubin. Copyright liver synthetic function tests, alteration suggests cirrhosis, equals albumin equals J total protein equals PT/INR. Sent evaluation of co-infection degree. HIV testing. O hepatitis B serology. O hepatitis A serology. Sent serum pregnancy test, if applicable ideally performed directly before initiating treatment. Liver biopsy. Sent consider when, copyright etiology of hepatitis is unknown. Copyright accurate liver fibrosis staging would alter treatment. Sent supportive findings, see pathology. OE. Pathology. Plus acute phase, 171. Copyright focal areas of macrovesicular steatoses. Copyright bile duct injury. Copyright sinusoidal inflammation of hepatic cells. Copyright lobular involvement in the form of eosinophilic single-cell necrosis. 7. Back collapse. Find text. A. Outline. Sent chronic phase. Copyright lymphoid follicles in portal triad. Copyright necroinflammation of periportal liver cells. O variable degree of fibrosis. O severe hepatocyte injury without treatment, the disease will ultimately progress to liver fibrosis, cirrhosis, and hepatocellular carcinoma. C. Pathology of viral hepatitis. OO. OXO. Differential diagnoses. E. Autoimmune hepatitis cent cholangitis cent C. Overview of viral hepatitis. The differential diagnoses listed here are not exhaustive. Why? ORS. Treatment. General principles, 15. The goal of treatment is sustained virologic response, SVR. Cent refer patients with end-stage liver disease for liver transplantation evaluation. Antiviral therapy, 15. HCV infection is always treated with a multi-drug approach, no antivirals are approved as monotherapy. Cent direct-acting antivirals, DAAs, copyright antivirals target and inhibit HCV-encoded proteins that are essential for the HCV replication cycle. O example regimens equals glecaprevir plus pibrentasvir, all 6 genotypes, equals sofosbuvir plus velpatasvir, all 6 genotypes, ledipasvir plus sofosbuvir, genotypes 1, 4, 5, and 6, asterisk interferon plus ribavirin. 8O was the preferred treatment before the development of DAAs O associated with severe adverse effects, example arthralgias, thrombocytopenia, leukopenia, depression, anemia, and teratogenicity. Copyright contraindicated in patients with decompensated cirrhosis, high risk of worsening. Cirrhosis decompensation. DAAs have superior efficacy and safety profiles compared with interferon or ribavirin-based regimens and are thus preferred. And acute and chronic HCV are treated with the same antiviral regimens. Supportive care. Central individuals with HCV copyright avoid hepatotoxic drugs, example acetaminophen, and alcohol use. Copyright counsel about HIV and hepatitis B prevention. E-counsel regarding adherence, reinfection prevention, and medication risks. Cent hepatitis A and B seronegative individuals, offer hepatitis A vaccination and /or hepatitis B vaccination. People who inject drugs. Copyright counsel on harm reduction strategies. O refer for treatment of substance use disorder. 6. Monitor for complications of HCV infection in individuals who decline antiviral treatment or do not achieve SVR. OSCES. Complications. Plus rarely fulminant hepatitis, liver failure, 220, 21 cent liver cirrhosis cent hepatocellular carcinoma v. Back collapse. Find text outline. G. Monitor for complications of HCV infection in individuals who decline antiviral treatment or do not achieve SVR. OCES. Complications. Plus rarely fulminant hepatitis, liver failure, 20121 cent liver cirrhosis cent hepatocellular carcinoma cent secondary hemochromatosis. We list the most important complications. The selection is not exhaustive. WARO, booze. Prevention 22. Cent primary prevention. There is currently no effective pre-exposure or post-exposure prophylaxis and no vaccine against HCV infection. Use standard precautions for bloodborne pathogens in healthcare settings. Copyright educate individuals with HCV infection about preventing transmission, e.g., equals do not donate blood, semen, etc. Equals do not share personal items that might have blood on them, example needles, razors, toothbrushes. Equals cover open cuts and sores. Cent secondary prevention, C. Screening for hepatitis C virus infection. Spontaneous resolution of HCV and successful treatment of infection do not confer immunity to reinfection. HAT. Special patient groups. Considerations in pregnancy 231. Plus vertical transmission, approximate 5 to 15%, 1, 24L Copyright C section does not lower risk of transmission. Copyright avoid amniocentesis or the use of fetal scalp electrode, due to increased risk of transmission. Copyright HCV infected patients, without HIV co-infection, may breastfeed as normal. Sent prenatal screening, anti-HCV antibody testing recommended for all pregnant women during the initial examination, 10 weeks of gestation. Sent postpartum treatment. Copyright the medication regimens currently available are all contraindicated. Copyright infants should receive vaccinations for hepatitis A and B. FU OS Related 1-minute telegram. 1-minute telegram 57-2022-3/3 HCV reinfection rates low among drug users receiving opioid agonists. Interested in the newest medical research, distilled down to just 1 minute? Sign up for the 1-minute telegram in tips and links below. FOOE Tips and links. Sources. Back. Last updated December 20, 2023. VA collapse. A. Find text. O. Outline. Symptomatic disease. 7x////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////////// 7/NX, ARAROSS, EEAEGTSG BOSSTT equals TT01ZX4 *12845. Transaminases. Months, years. Serology of resolved hepatitis C infection VV. If the infection has cleared or has been successfully treated, HCV RNA cannot be detected and transaminases return to normal levels. However, anti-HCV IgG antibodies persist indicating previous infection. Copyright Emboss.